morning, everyone. Good morning. It is a pleasure to welcome you to St. Louis University School of Law for the 2026 Health Law Symposium. We're grateful to have so many distinguished scholars, practitioners, alumni, and students with us today, and we are especially appreciative of the time, expertise, and thoughtfulness each of you brings to this important conversation that we will engage in today. I would like to begin by extending my sincere thanks to all of today's speakers. Your willingness to share your expertise and engage in thoughtful dialogue is what makes this symposium such a meaningful and impactful gathering year after year. We are particularly honored to welcome our keynote speaker, Professor Wendy Parmet from Northeastern University School of Law, whose work at the critical intersection of public health, law, and policy will certainly give us a great start to today's symposium. We are grateful to have her here with us and look forward to her insights. For several decades, the Center for Health Law Studies has been a national leader in shaping the field of health law. What began as a bold vision has become one of the most respected programs in the country, defined not only by its reputation, but by its impact. Each year, the symposium brings together leading voices to engage with some of the most pressing and complex issues in health law and policy. And those conversations extend far beyond this room, informing scholarship, influencing policy, and shaping practice across the country. That leadership is built on a strong and enduring foundation of people. Our faculty are deeply engaged in the work of advancing health law, producing scholarship that informs courts, legislatures, and public discourse, while also mentoring the next generation of leaders. They are not only observers of change, but active participants in shaping it. Our students are a critical part of that mission. They arrive with a commitment to improving systems and communities, and through their work in the classroom, in clinics, and alongside faculty, they contribute meaningfully to the conversations that define this field. They are thoughtful, engaged, and prepared to lead. And our alumni continue to carry that work forward in powerful ways. Across the country, they are influencing policy, advising health systems, advocating for patients, and serving in leadership roles across government, private practice, and public interest organizations. They are a reflection of the center's longstanding commitment to excellence and impact. Today's symposium continues that tradition. While the focus this year touches on questions at the intersection of vaccine, science, law, and public trust, issues that are both timely and deeply consequential, it is also part of a broader legacy. The center has long been a place where complex and at times difficult conversations are not only welcomed, but elevated. This is where we bring together different perspectives, examine emerging challenges, and walk toward thoughtful, evidence-informed solutions. At a moment when health law is increasingly shaped by shifting policy landscapes, rapidly evolving science, and real questions about how we build and sustain public trust in our health and science systems, convenings like this are essential. They remind us of the important role that law plays in translating knowledge into practice and in ensuring that our systems serve the public effectively and equitably. I would like to extend my sincere thanks to the center leadership for their continued vision and stewardship of this extraordinary program. Their work ensures that the center remains not only a leader, but a convener, bringing together voices from across disciplines to engage in meaningful dialogue. And I want to offer special recognition to Dr. Michael Sinha for organizing today's symposium. Dr. Sinha's leadership, research, scholarship, and commitment to fostering these conversations are evident in the program we will have today. We are deeply grateful for his work in bringing this important gathering together. Thank you all for being here today, for your engagement, and for your continued contribution to the field of health law. Dr. Sinha?
Welcome to the SLU Law Center for Health Law Studies 38th Annual Health Law Symposium. This year's theme is a defining moment for vaccine science and policy. I selected the topic in October of last year, and a lot has happened since then, including in the last few weeks. The moment feels right to be having these critical conversations, and I'm honored that each of you in person and on Zoom are here to join us. I am grateful to our incredible speakers who are joining us from far and wide. I am also grateful to my colleagues at SLU Law, in the Center for Health Law Studies, and the ongoing support of the Health Law program from our Dean, Twinette Johnson. I would like to thank the terrific student editors of the St. Louis University Journal of Health Law and Policy who are in attendance and helping the symposium run smoothly. Molly Sheridan is going to be our fall managing editor and will be working with speakers at this event for the articles related to the symposium. I've been fortunate enough to advise Molly on her student note, which is also related to vaccine policy. So flashback to November of 2024, a few days after the election. I presented on a public health panel at the University of Chicago Legal Forum. At the event, I made the case that, given our experience with COVID-19, vaccine manufacturers would have little incentive to invest in vaccine research and development in future pandemics. Despite skepticism from some in the audience, I'm sorry to say that the last year and a half under the Trump administration and Secretary of Health and Human Services, Robert F. Kennedy Jr., has demonstrated that those predictions may indeed have been correct. That article is now published in a symposium issue titled Law in Times of Disaster. That title feels pretty appropriate and could have easily been the title of this conference. Yet I have seen glimmers of hope in the last few months. I have seen the power of coalition building in pushing back against vaccine policy reforms aimed at undermining the evidentiary basis and trust in vaccines. I've seen the impact courts can have in reining in egregious practices. And I've seen the powerful voices of people speaking at our symposium today who stand up so often to speak out against the administration's anti-vaccine agenda. I teach public health law, but the speakers you will hear from today have far more expertise in vaccine law and policy than I do. I look to them as de facto leaders of the movement to restore expertise and evidence in the law governing vaccines, and I hope the conversations we have here today will continue in the weeks, months, and years to come. To start us off, I have the privilege of introducing a personal mentor and friend of mine, Professor Wendy Parmet, the Matthews Distinguished University Professor of Law and Faculty Director of the Center for Health Policy and Law at Northeastern University School of Law, and our keynote speaker for this symposium. Professor Parmet is a leading expert on public health law, and disability law. She also holds a joint appointment at the Northeastern University School of Public Policy and Urban Affairs and serves as co-editor of the law school's SSRN publications, Human Rights and the Global Economy, and Public Health Law and Legal Theory paper series. Her scholarship has received major recognition, including the J. Healy Teaching Award from the American Society of Law, Medicine, and Ethics in 2016, the APHA Law Section Lifetime Achievement in Public Health Law Award in 2022, and a 2024 ranking as one of the top 10 most cited health law faculty nationally. She's published widely on public health, bioethics, discrimination, health law, and AIDS law, including some articles that I've co-authored with her. She is the author of Constitutional Contagion, COVID, the Courts, and Public Health, which is a book that will be available for purchase during lunch, and Professor Parmet will be able to sign books at the reception at the end of the day. She also authored Populations, Public Health, and the Law, and is a co-author or co-editor of several additional books. Earlier in her career, she clerked for Chief Judge Levin H. Campbell of the U.S. Court of Appeals for the First Circuit and practiced at a large law firm. She has served in numerous leadership and advisory roles, including as associate editor for Law and Ethics at the American Journal of Public Health. She has also litigated key cases, including Bragdon v. Abbott before the U.S. Supreme Court and Finch v. Commonwealth Health Insurance Connector Authority before the Massachusetts Supreme Judicial Court. So without further ado, Professor Parmet, the podium is yours. Thank you for joining us.
Thank you so much. Many thanks to Michael. As he said, we've known each other a long time, and it feels like only yesterday that we had that initial lunch at Obompet, and you said to me, I think I want to get into health law. And I remember, and the rest is history. And he's here at this amazing Center for Health Law Studies, which I have long thought of as one of the meccas for health law, and I have no idea how to get to my slides now. Weird things are happening here. Weird things. Okay. Thank you. Thank you so much. And thank you to Dean Johnson and everyone here. It is a real privilege to speak to so many giants of the field right now. I hope you will indulge me this morning for a few minutes as I share some personal reflections and maybe some strange hauntings that have plagued me as I thought about this conference. So during the first year of the COVID pandemic, when we were still, not supposed to go into indoor spaces, my husband and I went on frequent outings. We explored nearby beaches and parks and walked old towns that we had previously only driven through. We strolled through cemeteries too. One of the odd privileges of living in New England is that there are some amazing cemeteries. We strolled the gracious lawns of the Mount Auburn Cemetery in Cambridge, peering at the monuments of all the famous people who are buried there, and there are many famous people buried there. We meandered through the graceful Mount Feake Cemetery in Waltham that overlooks the Charles River. We also discovered many small colonial-era graveyards within a short distance of our home. Among the historic burial grounds we came upon was the Old Village Cemetery in Dedham, Massachusetts. The cemetery, which dates back to the early 17th century, is not particularly large or imposing. Most of the headstones are small. Many are hard to read. But standing among the modest tombstones, we found a monument far larger than most to George Frederick Williams and his family. I jumped up and down. My husband was completely baffled. I'm guessing that most of you, maybe all of you, have never heard of George Frederick Williams. Has anybody here heard of him before now? Dorit. But no one else, right? Williams was a minor celebrity in his day. He kind of turned up whenever history called. He was a reporter for the Boston Globe, a congressman from Dedham. I don't know what's going on here. Sorry, weird things are happening. Okay, sorry. It's probably George. He was a Republican mugwump, you can look that up, who switched parties from Republican to Democratic. He was a leading supporter of the populist presidential candidate William Jennings Bryan, who was famous for his Cross of Gold speech. You might remember that from history class. Later, Williams became Woodrow Wilson's ambassador and envoy and minister, what we would today call ambassador, to Greece and Montenegro. Some stories in the press of the time, which I have seen but have not verified, claim that Williams spoke out against atrocities committed against the Albanians and got involved in a plot, or at least was put forth in a plot, to make him king of Albania. The stories go on to suggest that that plot was associated, however loosely, with the assassination of Archduke Ferdinand, and some stories blame Williams for the start of World War I. As I say, he was an interesting guy. Why is this not going forward? Okay, it's not going forward now. That's what I want. Okay. But the reason I was excited to see Williams's tomb was that he was Henning Jacobson's lawyer in the landmark 1905 case, Jacobson versus Massachusetts. That case, which I suspect many of you have heard about, rejected Williams's argument that an order that required all residents of Cambridge, Massachusetts be vaccinated or show proof of vaccination was unconstitutional. In the first few months of the COVID pandemic, courts around the country, as well as the Chief Justice to the U.S. Supreme Court, cited Jacobson approvingly in rejecting challenges to the emergency orders that were put in place limiting gatherings to quell the pandemic. During those early months of the pandemic, when I was roaming cemeteries, as one court after another cited Jacobson, and as I was in the middle of writing 2 articles about Jacobson, it seemed kind of fitting, if not weird, that I stumbled upon his headstone. His grave seemed almost to symbolize the death of the constitutional challenge he waged. No, this is not right. Or maybe it. Okay. Yes, it is. Okay. Karma, however, is fickle. As I should have realized on Easter Sunday, 2023, when after the Supreme Court had sidelined Jacobson in a number of cases, striking now COVID-related measures, Henning Jacobson's church burned to the ground due to suspected arson. The ghosts of Jacobson and Williams seemed restless. Last December, my husband and I returned to Dedham to see a manger that gained quite a bit of notoriety in the local press due to its pro-immigration display, which the Archdiocese objected to. As we wandered through Dedham, I decided to return to the old village cemetery. I needed to see Williams again. This time, everything felt different. In a moment when our vaccine laws were being dismantled, Williams's tomb seemed not as a reminder of his defeat, but a testament to his potential vindication. Williams was a politician, a populist, who advocated for religious dissidence and the right to reject public health recommendations and mandates. His arguments, which were supported by a very well-financed and organized anti-vaccination movement, ran against and tried to undermine the teachings of the science of the day. Today, other populist politicians follow in his footsteps. They disparage scientific expertise and ally with religious objectors and public health critics to topple our vaccinating laws. Williams, I suspect, is smiling. But Williams's tomb was not the only one that spoke to me in the old village cemetery last December. I also heard from the small, worn, often very hard to read tombstones of the infants and young children who are buried in the graveyard. This picture shows several that I took that day, plus one, the Quentin Clark family that Professor Sinha shared with me when I told him I was collecting pictures of children's tombstones. Unlike Williams, they don't have grand monuments. They didn't live long enough to become minor celebrities of the day. But their tombstones are a reminder of the days when infectious diseases killed young children in horrific numbers. I share these reflections today as we gather to talk about vaccine law, because we do so in the shadow of the old village cemetery and the many other burial grounds like it scattered across the country. We also do so in a moment when, as in 1905, the geopolitical situation is volatile, to say the least. Religious groups are aligned with populist politicians, science is under attack, and the future of vaccination seems uncertain. During the conference that follows today, we will hear from many of the most distinguished experts in the country about the ins and outs of vaccine law. We will hear what has worked and what hasn't worked. And I suspect we will hear many innovative and important proposals for reform and rebuilding. Critically, the status quo pre-2025 was not perfect. But as we partake in the discussions, I ask we keep the graves of the children in mind. And we remember that when leaders promised to make America healthy again, the past was not kind or healthy for our children. Whether the future will be equally unkind is unknowable. But in the time I have left, I want to talk about what has been lost, both in terms of vaccine policies, but also in terms of the social compact. For if we want to repair and reform vaccine laws, if we want our children to be healthier than those who are buried in the old village cemetery, we need to rebuild that compact. Let me begin with what has been lost. Given the significance and impact of the number of changes that have happened in the past 14 months, I might be forgiven for focusing on everything that has happened since Secretary Kennedy took over at DHS. But I think it's important to understand that vaccine law, which really provides the foundation for vaccination in this country, rests on a three-legged stool. One leg represents the political branches of the federal government. Let's call that Kennedy's leg. One represents state laws, and one represents judicial decisions. Over the last 5 years, all three legs have become wobbly. Let me start with the courts, because that's where the changes began and because I'm haunted by Williams. They began chipping away at Jacobson long before Kennedy took office. Justice Harlan's opinion for the majority in Jacobson was, as I don't like to quote myself, but I like this one phrase I said, was a Delphic opinion, subject to varied and conflicting interpretations. As Justice Alito correctly noted in his 2020 dissent in Calvary Chapel, Dayton Valley versus Sisolak, Jacobson was decided before the Supreme Court had incorporated the First Amendment into the 14th Amendment. So Williams did not raise religious liberty claims, even though Jacobson personally came to some of his objections to vaccination due to his faith. But instead, Williams cited the preamble to the Constitution. That was a quick loser. And the protections for liberty provided by the 14th Amendment. And although Williams didn't use the term, today we would say his argument sounded in substantive due process. This was, after all, the Lochner era, and Lochner was decided just shortly after this. And although Justice Harlan took the due process arguments quite seriously, and that's what's interesting, and he suggested some important limits on the state's ability to mandate vaccine. He ultimately rejected Williams's contentions, explaining that real liberty, in quotes, required, in quotes, manifold restraints on what individuals could do for the common good. And Harlan concluded that local boards of health were the experts with the scientific knowledge to make the decision about whether or not to mandate vaccination. In the years since 1905, even after the repudiation of Lochner, Jacobson, and even after the incorporation of the First Amendment into the 14th, Jacobson was read by court after court after court, Supreme Court down to trial courts, as making clear that states could mandate vaccination. It was about as settled as an issue of constitutional law can be. That started to change in late 2020. In a series of articles and books, I traced the upsettling of the Jacobson consensus, both within the Supreme Court and the lower courts. I'm not going to repeat that story here. Instead, I want to make just a few points. But before doing, it's worth noting that the shifts in the court's jurisprudence mirrors at least declines in trust in vaccines and vaccination rates around the country, which began long before Kennedy took office. But back to the courts. First, the unwinding of the Jacobson consensus started with the court's increasingly expansive conception of religious liberty. That change began in challenges to COVID restrictions on religious worship. Eventually, the court held that any state action that substantially burdens an individual's sincerely held religious belief, which is to be construed very liberally, is subject to strict scrutiny as long as the state has regulated some, in quotes, comparable secular activity. As a result, religious objectors now have what many have called for most favored nation status. Vaccine opponents quickly during the pandemic exploited this shift in the jurisprudence to begin to argue that vaccine mandates that had medical exemptions treated a secular objection, which they claimed was comparable to religious exemptions, more favorably. Initially, the Supreme Court avoided the subject. Most lower courts continued to uphold mandates, but eventually some courts began to rule the other way. And most notably in 2023, in Borsage versus Edney, a federal court in Mississippi ruled that the state had to add religious exemptions to their childhood vaccine laws because they have medical exemptions. And then last December, in Miller versus McDonald, the Supreme Court granted certiorari and vacated a Second Circuit opinion upholding the lack of exemptions in New York's mandates. The court ordered the Second Circuit to reconsider the case in light of the Supreme Court's own religious liberty rulings. Second, the judicial decision striking vaccine mandates, along with the Supreme Court's decision in Loper-Bright overturning the Chevron doctrine, demonstrate the judiciary's increasing refusal to defer to public health expertise. And we see that in many courts cases. Third, at the time of Jacobson, when the bodies of children filled the burial grounds, courts frequently invoked the notion of the common good, or, as I've written, salus populi suprema lex. The public health is the highest law. That concept has largely disappeared from our jurisprudence. And instead, what we increasingly see are decisions that allow individuals to decide for themselves what is best for them or what follows their own conscience. This is a point I'm going to return to. But for now, I want to stress that the erosion in law of the notion that vaccination is a public good began with the courts. So let's look at the states. Public health law is often viewed as largely a matter of state law. It's something of a trope when we teach public health law. Public health is part of the police powers, that's state law. We kind of say that. But when it comes to vaccines, that's only partially true. Most vaccine mandates do come from the states, although we had federal mandates during the pandemic, and we still have federal mandates for armed forces, for example. And state laws affect vaccines in many other ways. For example, in determining scope of practice, who gets to administer vaccines. So states matter. So where are the states? In brief, they are splintering. The leg of the stool is divided. In the last 5 years, at least 13 so-called red states have enacted various types of medical freedom laws that limit the ability of employers or schools to mandate vaccination. In contrast, some of the so-called blue states have continued to encourage vaccination, forming multi-state alliances to counter the messaging coming from Washington. Some states have even taken steps to disentangle their scope of practice and insurance laws from what the federal government does, and states are continuing to defend vaccine mandates in court. But there are limits to what states can do. Not only because of the constitutional decisions by the courts, which of course limit what the states can do, but because of the inherent limitations of their authority and their funding. Most obviously, states cannot make up for the lost federal research funds for basic research, which Professor Sinha had referred to. They cannot provide the broad immunity provisions offered by federal laws, and they cannot make available vaccines that the FDA does not license. What happens in Washington matters. And that takes us to the federal government. The list of all the ways in which the federal government affects vaccines is too long to share, as is the list of all the changes that the Trump administration has implemented. For present purposes, it's important to note that the weakening of the federal leg has happened both on what I call the demand and the supply side. In other words, the federal government has taken steps designed to impede access to vaccines and to impede the desire to be vaccinated. Before saying this, I want to stress that I am not claiming that all of the federal vaccine laws before 2025 were perfect. Far from it. I've long been a critic of many of them, but the multiplicity and scope of the changes that have been made in the last 14 months suggests that the federal government is not seeking to reform our vaccine laws. It is seeking to bulldoze them. Let's start with the demand side. On the demand side, we are seeing a dramatic change in federal messaging, as this slide shows, with quotes from the secretary. The message is now clear, or at least I take that back. What is clear is confusion, undermining trust, saying vaccines do not cause autism, asterisk. And I don't think you can, we're only saying this because we were told to say it. I mean, how clever is that, right? The confused messaging and the anti-vaccination messaging is having its effect. Trust in vaccination is declining. Second, under Secretary Kennedy's leadership, CDC has instituted a variety of steps that seemed designed to undermine demand. These steps, which were the subject of litigation in AAP versus Kennedy, in which a stay was issued by a federal court a little over a week ago, or 2 weeks ago now, included a unilateral change to the federal vaccination schedule, the replacement of the Advisory Committee on Immunization Practices with many folks who were not expert in vaccination and some of whom were long outspoken anti-vaccinationists. As I noted, these changes are now stayed by an opinion order of Judge Murphy, and it's not at all clear whether the federal government is going to appeal, but then again, chaos may be the point. On the supply side, the Department of Health and Human Services has undermined or contemplating undermining the supply of vaccination in many ways. First, NIH cut research funding for the next generation of mRNA vaccines. Although that money was restored, the funding and investment climate is at best uncertain. And of course, all basic science research is now affected by cuts to NIH. Second, in a memo obtained by the New York Times last December, the then director of FDA's vaccine division, Dr. Vinay Prasad, stated he would propose requiring vaccine makers to conduct randomized controlled trials of new shots in all subgroups, including pregnant persons, and would increase the requirements for licensing updated vaccines for respiratory diseases, i.e. flu and COVID, in ways that would significantly delay, if not totally preclude, the availability of updated annual vaccines. Now, Dr. Prasad has since left his position, and what's going to happen with that, we don't know. But again, it puts confusion and a pall. More ominously, Kennedy has hinted that he wants to change the vaccination compensation scheme under the National Childhood Vaccination Act. Just this week, longtime Kennedy ally Aaron Siri petitioned Kennedy to add many injuries, including autism, to the vaccine table. As Ezekiel Emanuel and Paul Fredericks explained in an op-ed in the Washington Post last winter, Kennedy can quote, overwhelm the vaccine compensation scheme. This would effectively destroy the scheme and bankrupt and basically take vaccines off the market. Now, what Kennedy will do with this petition, we do not know. But don't be shocked if he's arguing within the White House, within the administration, to support that petition. I'll come back to the fact about that he may be arguing with the White House in a minute. To be sure, there are reports, right, that the administration, for political reasons, wants to at least de-emphasize the attacks on vaccines, at least until the midterms. And there's a story in the Times today suggesting people think that Kennedy might actually be on his way out. Still, I want to emphasize, a lot of damage has been done, and more may be coming after the midterms or even if Kennedy leaves. More importantly, even beyond Kennedy, the attack on science, the so-called populist attack, is fundamental and creates existential dangers to our vaccine laws, our drug laws, and frankly, all of our health laws. That's what Williams was arguing for. That's in some way one of the most fundamental things that Jacobson rejected. And this leads me to the social compact, the floor upon which our three-legged stool rests. As I said at the beginning, Jacobson is a complex case. The canon has been read in many ways. But what it and the state and federal and judicial laws that preceded it, because Jacobson was really just restating the law in many ways, and followed it, all had in common was that when it comes to communicable diseases, the health of one affects the health of another. Our health is not our own. We're in this together. For that reason, since the introduction of inoculation, the predecessor to vaccination, in North America in the early 17th century, you're indulging me for a little bit more of New England, that is the street sign that 2 blocks from my house. Dr. Zebediel Boylston, if anyone who's ever been to Back Bay in Boston knows Boylston Street, right? He did the first inoculations against smallpox. And Dr. Boylston, as he did it, laws were enacted to ensure their safety. They then required him to do it out in the harbor islands so that if there was disease spread, it wouldn't spread. From the very beginning of before our 200, we're now celebrating the 250th. Long before that, we had vaccine laws, or call them inoculation laws, right? And we have laws designed in recognition of the fact that when it comes to our health, That boy's health affects the health of other children, and the health of other children affects that boy. So Massachusetts gave out inoculations for free, but required them to be in the Harbor Island safety. Asterisk, inoculation, unlike vaccination, spreads live smallpox, but much less dangerously. So I return again to the children of the Old Village Cemetery. Despite Williams's best efforts, their premature deaths served to support the social compact. However unequal and flawed, and of course it was unequal and flawed. I am not saying the 17th century was the best of times in any way, that recognized the importance of public health and laws supporting the public health. In other words, as Justice Harlan quoted from the Massachusetts Constitution, the oldest written constitution, government is constituted for the common good, for the protection, safety, prosperity, and happiness of the people, and not, I want to underline this today, for the profit, honor, or private interests of any man, family, or class of man. Today, that recognition has faltered. All three legs are splintering. We face one of the greatest crises we have faced in vaccine law, but really health law, and indeed the rule of law. But there are glimmers of hope. One is to read about that those who are attacking vaccines are recognizing they are coming up against public opinion. It's important to remember that the vast majority of the public wants access to safe vaccines for their children, and they want the children who their children play with and school with to be vaccinated. And another glimmer of hope are these conversations. It's the work that all of you are doing, and it makes me encouraged. It makes me feel like what you do day in and day out is going to help ensure that the next generation of children do not meet the fate of the children at the Old Village graveyard. Thank you.
All right, we have some time for questions from the audience. I will probably start with one of my own and take the moderator's privilege. It's interesting to me the sort of political dynamics that brought Kennedy to the forefront and brought him into the role that he currently has. And on the one hand, I think back to the Secretary of Health and Human Services being a far more sort of political role than someone who has any scientific background, which I think Kennedy does fit. But at the same time, they're constantly leaning on the expertise of those in the agencies that they oversee. So what do you think changed in this moment? Because I think in the first Trump administration, there was at least some recognition that expertise was valuable. The Operation Warp Speed that got vaccines to the market very quickly. And here, this seeming vast contrast. What do you think was different this time?
Well, yeah, that's a great question. I mean, I think without getting into the personal psychology, of Trump 2.0, and he's learned he can do what he wants to do, and he, Trump unbounded, unguarded. I think in many ways what we're seeing is the further development. I don't want to say the logical conclusion of, because I don't know where we are on this, of this populist attack. I mean, there were certainly glimmers of it in Trump 1.0, and there were glimmers of it, certainly. It accelerated during the pandemic. Remember ivermectin, bleach, hydroxychloroquine, right? Memories, remember all that? So we saw that then. But I want to be clear. I think the populist attack on expertise their roots predate Trump, right? I mean, they've always been there, right? That's my point about Williams. I mean, there was a very large organized anti-vaccination movement in the turn of the 20th century. It's always been there. But I think we need to recognize how, a variety of forces from the changing, media environment, i.e. social media and everything, to really the dysfunctionality of our healthcare system. I mean, there are real reasons why people become their own experts, because they can't afford a doctor, or they can't get a doctor even if they have insurance, right? I mean, I'm in Boston again. Try to get an appointment. You can have great insurance and the best doctors in the world, and it could take you 4 months to see somebody. So there are all kinds of forces, and there's direct to consumer advertising, and some of the FDA experts in this room will know more than I. We created this system where alternative medicines and wellness products, right, can get to market without going through the regulatory hoops of medications that are really subject to rigorous review. And Michael and I had worked for a while on a project on direct to consumer prescriptions. I mean, there are a multiplicity of sources that are designed to tell people, you are the expert, do your own research. That was even before AI, use ChatGPT, right? And now people don't feel like they need to listen to the experts. So, distrust of expertise, particularly in the healthcare system around health, has been growing. It's really, I mean, in some papers, goes back to the women's health movement, the AIDS movement. There are long roots. And much of that distrust was justified, right? I mean, we could talk about Tuskegee. We could talk about, psychiatry calling, being gay as a disease. I mean, there are lots of reasons for the roots of this distrust. But what has happened again is at some point it morphs from rational skepticism to epistemological nihilism. And that's the big shift, right? You go from asking questions to expertise does not matter. In fact, the modalities, and one of the things I'm working on right now is about how what we're seeing is this shift so that the very idea of the fundamental methodologies and ways of knowing, the epistemology of science is now being so attacked, so that how do I know something? And it's not, right, increasingly, it's not through expertise or empiricism or disciplinary knowledge, it's through other sources of knowledge, be they, influencers to gut, to religion, to authority, right? Some influencer or prominent person. So we're changing how we know things. And I think Kennedy embodies that and embodies the political movement behind that, which does ally with the MAGA movement to a degree. But we're also seeing the limits to that. It's important to recognize it, but it's important not to overstate it. And I know, I will note, supposedly Kennedy had shoulder surgery a few weeks ago. And as far as I know, he didn't, use a rabbit's foot or a magnetic bracelet. He went to a hospital and had a surgeon fix his shoulder.
I just had a quick question, kind of piggyback of what Professor Sinha said. I think a lot of us have people in our lives who we love and care about who are starting to buy into this. And a lot of them, maybe necessarily didn't pursue a higher education, or even if they did, are just really buying into this messaging about vaccines being bad and dangerous. I just wanted to ask you, how do you advise that we go about having sort of like a healthy conversation with these people? Because I think there's a lot of alienation. I think a lot of people are maybe intimidated or even distrust higher education. How would you go about having these conversations with your friends and your family?
Well, that's a great question. I wish I had the answer to that. I will tell you what the problem is. And, one answer is always really, listening, obviously, engaging. But for a long time, public health has emphasized to parents the benefits to their own child. And part of the problem with that is it actually buys into the individualism and undermines the social compact. So I think, it's you hear people, you hear them out. I like to, and I don't, have as many people in my life, but I do sometimes have some who are skeptical, and I make comments somewhat differently than I just made, which is, if you had a health problem, if you needed surgery, where would you go? It's interesting because the skepticism towards science that I'm talking about obviously does not extend everywhere. I mean, the people who are skeptical of science use a phone, and I, for the life of me, have no idea how this phone does what it does. It's completely awes me, right? But it's actually, of course, scientists and engineers, it's experts who created the phones and the internets, and very few people, even if they also do some alternative treatment, will not, if they're having a heart attack, they'll run to the hospital. And I think it's engaging in people, why are you drawing these lines? We really and it's okay to ask questions. You should ask questions, but to completely discount, you don't just, you would go to a hospital if you had an MI. Why not listen to the physician to keep your child from going to the hospital, right? I mean, it's different, right? People, when they're exigent, when they're acute, they see the need, but I don't have a great answer. I mean, I've read so many articles on how to have these conversations, and I have to say, I don't know that anybody has the perfect answer. They're very time consuming, and that's part of the problem. You can have these one-on-one, I don't know what's going on here. You can have these one-on-one conversations, but 5 quick tweets can undermine it.
Hi, my question is, in this environment where this mistrust in science has been building over time, and then now we have politicians who are making what I find reckless and truly dangerous statements about vaccine safety, sorry. Do you have any thoughts or ideas on what the most realistic path forward is to kind of rebuild that trust in vaccines?
Well, as I'm trying to say here, I think the most important, the distrust in vaccines is both a cause of, but also a symptom of this larger set of distrusts and the larger fraying of the social compact. And so at the end of the day, and not to discount the importance of the particular reforms and proposals that I think may be discussed today, I think it's really important to understand that our vaccines, our health, all of it, as long as the country is so divided, as long as the country is so individualistic, as long as people can't see, beyond, feel like the world is out to get them, so it's only me and mine. I don't think any of this works. I think we have to rebuild our social fabric and our political system, right? I mean, on day whatever, maybe the Senate voted yesterday, and some of us got here despite the TSA, but we don't have a very functioning, well-run, well-oiled political system right now. I think that's an understatement that people on all sides of the aisle can say. And so there are much bigger, the vaccine law, we could come up with a great new federal vaccine. I could sit down with Rob and Dorit, and we could write a great new model for the National Childhood Vaccine Injury Act 2.0. I think we could all agree that some things could be better and some things could be tweaked, and it could be brilliant. And we could go to Capitol Hill and we could get 400 members of Congress to individually tell us this is great, and it would never get enacted, no matter how great it is. And that's the problem, right? I mean, it's the fundamental political problem that we have right now is underlying the vaccine, but that's not a very helpful answer. But you know, we keep trying.
So I had the same question, but I'm going to reframe it a little bit to be more specific. Measles outbreaks. Is the experience of the consequences of being so skeptical of vaccines, do you feel like that's moving the needle such that there is an entry point beyond saying, let's just rebuild the social fabric, which just seems like such a sort of a difficult place to start? Is there any reason to believe that there's a change of heart that's happening as a result of watching how a measles epidemic can spread quickly through a community of children?
Well, I mean, I think the answer is yes. I mean, I think, right, if I'm going to claim that there was more of a recognition in the 17th century of the importance of inoculation and protecting it, it's because people saw people die. They went to all those funerals. And I do think we have seen where there have been local outbreaks, you know, even in some areas that are quite, the outbreaks happen in areas where there's a lot of vaccine skepticism and opposition. And then we do see people come in and get their kids vaccinated. And I do think that, unfortunately, those hard experiences, those tragic experiences, are reminders. But I also know I kind of thought the pandemic was going to do that, and it went the other way, right? I mean, you know, I think, I remember conversations about, well, we recognize the need to have a healthcare system that covers everybody during a pandemic because we recognize the vulnerability and we recognize, right? And, you know, that didn't happen. And then we saw stories of people in ICUs dying of COVID who denied that COVID existed. So I hate to say I'm hopeful that children going to hospitals make changes, but I do think it's possible. But the current political and informational environment is certainly strong and pushing the other way.
We have a question from one of our Zoom attendees asking about the issue of universities also being inhibited for emphasizing science. Is this a threat as well? And how do we deal with it?
Well, I think it is. And I think the attack on universities, on their funding, on their academic freedom, which we have seen in various ways and more in some states than others, it is all a part, right? It is part of this populist attack, right? I went to the allergist yesterday morning before I got on the flight, and all she's talking about is how they're losing all their grants for research for asthma. I mean, I think it's all part of the same. Like, no one's out there marching against, not having a better asthma rescue drug. It's no parents are organizing against that, and yet they're losing their funding for it. So it is part of this populist attack, I would call it. It's not just populist. What I want to also say is it is, you hear the word often now that we are in or some people think we are in a post-liberal period. Well, if you sort of look at what people who advocate for post-liberalism argue is really an attack on science and an attack, frankly, on enlightenment, the Enlightenment, and science as a tool of the Enlightenment. People back in the 15th, 16th, 17th centuries learned to use science to increase human knowledge. And that happened coincidentally at the same period, in the early modern period, with the development of the liberal order. And these are all under attack. And I'm not saying we're going back to the Middle Ages, but I am saying there is a strain that is in the current anti-vaccination attack. And it's back there in Williams. It's there with Henning Jacobson and some of the ardent vaccinationists who were writing in Boston in the 19th century. They denied that smallpox existed. As famous one guy, he got smallpox and like the Boston Globe figured it out, but he had to deny that it existed. It is this attack on modernity, right? And we see that in all kinds of ways. And so I just think vaccination is both a way to stop that attack, but it is also affected by the attack. And I think we have to sort of keep both sides of that relationship in mind. There's Sydney has a question.
Thank you, Wendy. This has been a wonderful keynote and raised so many questions. I want to throw into the many ideas you've presented to us of trying to understand what's going on. Do you think is any part of the skepticism that sometimes a vaccination prevents you from getting something? Very often it prevents you from getting something worse, from being a more complex case. Do you think some of what is happening is a lack of people's appreciation and understanding of that kind of nuance? I thought of that when you talked about COVID. COVID, we thought at first was the magic bullet, right? I can't get COVID, but then it's like, well, you can, but you're not going to be as sick. So there's a nuance there that maybe for the skeptical person to begin with, it's hard to process the risk benefit.
Oh, absolutely. And that's the problem. I mean, it's a broader problem with public health in general, right? Again, I said, even people who are skeptical of science, if their loved one suffers a heart attack, they're going to call 911 and go to the ER, right? They get that risk benefit, right? Right away. And explaining to somebody, in a world, right? There's a group out now like Grandmothers for Vaccines. You may have seen. I mean, in a world that's not like, that's why I start with the cemetery. We're not used to seeing the kids die. My mother, who's quite old, tells me the story of seeing her sister have surgery to open her mouth on the kitchen table for diphtheria. I mean, we don't see things like that, right, by and large. And so, yes, the benefit seems, and for the individual, I mean, we've long said this about public health, but especially vaccines, the individual, it's rational to be the free rider. If everybody else in your neighborhood has vaccines, well, get vaccinated, right? So at least for some vaccines that create herd immunity. So I do think that's there. It's a bigger problem for all of public health, right? It's the gains are communal and often far away. It's not like, ouch, I'm hurting. Stop, I'm hurting. So I do think it's very hard to do that nuance. And then particularly, that's always been a problem, right? And it's always part of the story about why we have underfunded public health and prevention as compared to, right, treatment for clinical treatment. But now you have the we now have these larger movements. And again, we've had them before, but they're really quite well financed and strong right now, pushing against that skepticism, right, to reinforce it. So I think absolutely, I think you're absolutely correct. And but it's hard to get people to see the benefit. And you're right too, the fact that the COVID vaccine wasn't the magic bullet adds to the skepticism.
You also make me think in terms of, linguists talk about we all need deep frames to be able to understand the information we get. And it's very clear to me, my old parents had a frame of fear of these contagious diseases. They knew other kids with polio. They knew what measles did. And that fear frame really changed their risk-benefit analysis of the benefit that a vaccination might provide. And many people have talked about this, that we haven't lived in a world with measles. So that fear frame falls away, and a frame of skepticism towards science can rise up to replace it.
Totally. I agree 100%. The fear is gone. So the free riding incentive, which is, it's just like, I don't see the benefit for me to do this. And you then add all of these concerted efforts to undermine your trust. You're sort of creating a perfect storm of distrust. Okay. Thank you so much.
Okay, folks, we're going to get started with the first panel of the day. I'm Rob Gatter, and I'm pleased to be able to moderate this panel with two wonderful speakers. Let me do a quick introduction of each, and then I will get out of the way. Anna Santos-Rutschman is professor of law, and she is also the founding faculty director of the Health Innovation Lab at Villanova University's Charles Widger School of Law. She is a nationally and internationally recognized expert on vaccine law and policy, as well as emerging technologies and access to medicines. She's the author of Vaccines as Technology, Innovation, Barriers, and Public Health, published in 2022, and her scholarship has appeared in leading law reviews and peer-reviewed journals as well. Among her many contributions, she has consulted with the World Health Organization on drug and vaccine development related to COVID-19, Zika, and Ebola. Additionally, we have with us Dorit Rice, professor of law and the James Edgar Harvey Class of 1950 Chair of Litigation at the University of California College of Law, San Francisco. Professor Rice specializes in vaccine law and policy, including exemption laws and tort liability related to non-vaccination. Her work has also been published in many law reviews and peer-reviewed journals and blogs on legal and policy issues related to vaccines. And she is co-author of Vaccine Law and Policy, published in 2023 with Professor Y. Tony Yang. We will start with Professor Rutschman, then Professor Rice, and then we'll have an opportunity for questions to the panel at the end. Professor Rutschman.
All right. Thank you, Rob. Can you confirm you can hear me all right? Yes? All right. Perfect. Thank you. And my understanding is that I have 25 minutes or thereabouts. First, thank you so much for having me at this event. I really wish I could be there. Unfortunately, physically, that was not possible. But I'm delighted to participate. Very pleased to be on this panel with Dorit as well. Allow me to say the following, and this is not outing Dr. Sinha too much. I'll be writing an article for this symposium, and those of you writing a piece were encouraged to be free and talk about whatever we wanted, even if spicy. That was the word that appeared in the email. And at that point, I thought, well, I would like to do that. And what would be a spicy topic right now? And the usual things came to mind. Vaccine federalism, on which I've been doing a lot of work over the past the past year, something more specific, maybe a case study on measles. And then I thought what would be really out there would be to talk about the Lyme vaccines. So it's a project I've always wanted to do, spend some time looking at both the regulatory and extra-regulatory aspects of Lyme vaccines, and that's what I will be talking about. And I'm going to do so. You'll see that this is sort of a travel back in time history and presentation, but I'm going to use it as an opportunity to reflect on the challenges that vaccines and vaccination in general face today. So without further ado, a very quick word on Lyme disease, because it's not what's in the news most prevalently today, but just so that we have some background, we're talking about a bacterial infection that, as probably many, if not most of you know, spreads through the bite of a particular pathogen. You see it down at the bottom. Symptoms include what you see listed here, from skin rashes to fever, headaches, and fatigue. And they can generally be addressed through a treatment with antibiotics. And I know that this is a symposium about vaccines, but one of the things I would like to suggest, and something I will definitely reflect on as I turn this into a written contribution, is the idea that vaccines are an ecosystem unto themselves with connections to different areas, from science, social movements, etc. But also they have connections with other products. Maybe SLU will do a symposium soon enough revisiting the topic of antibiotics and antibiotic resistance, but failing to prevent the onset of disease very often leads us to have to then rely on other types of interventions and medical products, and there are consequences for doing that. So we do have an effective treatment in this area that not everybody gets in a timely fashion, but there's a whole ecosystem suffering from different and related problems there. So I just want to point out that some of our misses with vaccines are likely and very often do have implications elsewhere for the healthcare system, for public health, for individual health. So the good news, we can address the disease that I'm thinking about, and we can do so effectively in many cases, but in some cases it doesn't work out, and in some cases treatment is not administered timely or ever, at which point this can turn quite serious. So there can be severe, lasting, and sometimes irreversible damage to the joints, to the cardiac system, and to the nervous system. All right. So this is the first, we're going to take two trips down memory lane. So we'll travel back to 1995, and this is data from the CDC. But for one instance, I was still able to pull all the information I needed for this presentation from the CDC's website. There was one set of data that used to be available that had been removed, but there is still some valuable data available there. So these are reported cases of Lyme disease. And one thing I'll say about this map and the following two maps is that they illustrate cases reported according to the residency of the person who was infected. So not where infection necessarily occurred, but where they reside. And you see obviously a focus on the northeast here, but already, north of Missouri, we start seeing some significant activity there. If we move forward to 2010, so here's your classical public health problem escalating, right? So the same areas begin to get way more reporting activity, and it's not going to come as a surprise. This is the last time we have data from at this point. Obviously, it has grown exponentially in the Northeast, upper Midwest, and it is growing everywhere. I will also highlight Florida here at the bottom. The reported cases are growing. There's also the problem of unreported cases, a problem for a different day. Just to put some more color into this before I talk about vaccines, I thought I would just show you the numbers. So, and again, they stop in 2023. So low activity, where this symposium is physically taking place, but escalating activity, things get more complicated and dire. So as Professor Gatter mentioned, I'm calling in from Pennsylvania, so I will group Pennsylvania with a couple of neighboring states, and as you can see, the numbers are extraordinarily concerning here. I will say that there were some problems with reporting of data for Massachusetts during a period of time. So I would not, so 2017 to 2021, I would not take those as representative, but you can see the trends between 2008 and 2023. So for instance, where I am right now, 3,800 to 16,000 plus cases reported. So this is my nutshell of an argument that we have a massive escalating public health problem. One last set of contextual elements in 2021, just to give you a sense how nationally this is escalating quickly. And this is data not yet captured by the CDC maps. In 2021, we were seeing around 300,000 new cases a year. The CDC last year calculated that we're now at 476,000 new cases per year. We have already covered or introduced this topic in the symposium. Professor Parmet talked about how the general malaise that's affecting our healthcare system has many ramifications, and one of them has to do with medical/scientific research. Lyme disease, in spite of the growing footprint of Lyme as a public health problem, has not been attracting, and this is prior to this administration, prior to COVID, everything has really not been attracting that much in terms of research dollars. So if the situation is now dire at the NIH, I will note that for the past decade, basically per patient, the dollar allocation has been $63 per capita in NIH allocated funding. Contrast with diseases that are also not at the top of the list of discussions that we have. They are somewhat regarded as niche diseases. I just picked West Nile, per capita 13,600, and there are reasons why the funding might play out differently, but I just want to give you a sense about how underfunded this field might be. And of course, the flip side of that coin is that patients diagnosed with Lyme disease face health costs, increased health costs individually, and so does the health system on aggregate. So I pulled some up-to-date estimates from Johns Hopkins, from the Bloomberg School of Public Health. I will also note that globally, the pathogens, albeit related, are not quite the same, but they can be targeted through the use of the same medical products, and I'll get to that in just a second. But I will point out that this is not a US-based problem. Dr. Sinha, in his introduction to the symposium, talked about his work implicating considerations about markets for vaccines and related products. So the point I would like to make here is that there is a public health concern, and there's also a market, presumably, for vaccines and treatments targeting Lyme disease in the US, but that's also true elsewhere. So there is a global market, and there's a global health problem that we are facing, and I just wanted to show you the geography corresponding to that. So let's talk about Lyme disease vaccines, and I was going to do this on a raise your hand kind of scenario. So I this morning I adjusted things a little bit, but I will ask you the question that I was going to try to prompt from the audience, and the question was going to be: do you know if there's a commercially available Lyme disease in the United States as of now, as of March? And I'm sorry, this should read 2026. It holds true for March 2025 as well. And we're in a law school, right? So the answer is going to be it depends. So there is indeed a Lyme disease vaccine that is available, but for your dog. And again, this should read March 26th. My apologies. For humans, in March 2025, March 2026? The answer is no. We don't have one. And in most vaccine-related stories, or for that reason, as we're trying to develop drugs to target complex diseases, often if the answer is no, we don't have a product that's commercially available, it's because of some kind of scientific impediment. If there's no product whatsoever, we're not quite there. The odd thing with this particular vaccine, why it's a spicy story to me and very illustrative of long-standing problems in our vaccine ecosystem, now magnified by some of the dysfunctions we are observing. So the quirk here is that we did have a vaccine that was commercially available for humans. Its name was LYMErix. So this is the case study I will be writing about and using as sort of a gateway into thinking about what the development of the imminent development actually of Lyme vaccines or vaccines in general now face in our legal/political ecosystem. So in the 90s, and remember we started with that map that didn't carry as much blue as the 2023 Lyme disease distribution map carried, but already Lyme disease, which we had known about for around 20 years at this point. So it had been a known problem and a public health problem that we saw growing, particularly in the north. Is this prompted pharmaceutical companies? Today, the companies in question have been absorbed by Glaxo, by GSK. So these companies did work on a Lyme vaccine candidate, and the work was successful. So by 1998, so we are 3 years post the first map that I showed you, the FDA approved the first human Lyme vaccine. It was commercialized under the brand name LYMErix. It required the administration of 2 boosters, one at 1 month and the second one at 1 year after the initial doses, which, as you can imagine, and this is not specific to vaccines, although we find these problems of adherence in the field of vaccines quite often when multi-dose regimes are required. So there were some logistical issues and some compliance issues, getting patients recommended for this vaccine to follow up and get those boosters, particularly the 1 year one. But here's what really happened. We have what, from a medical perspective, a scientific perspective, is a story of success. So we know that this particular vaccine, now FDA approved, reduces cases of Lyme by an estimated 80% in adults. In 1999, so a year after the vaccine comes to market, we also find, so data is beginning to emerge, and we find it to be cost effective. So on balance, reliable studies indicate that we're saving around $4,500 per case of averted disease. In 1999, ACIP, the federal advisory body to the CDC on vaccines, recommended the vaccines for individuals aged 15 to 70 years old, living in areas where Lyme is endemic. So again, recall the map, that's the Northeast, the upper Midwest. So this is from a scientific perspective, from a product development perspective, a successful story. And I will add, from a regulatory perspective, a normal story, right? We didn't see anything strange at the FDA level, have any discrepancy between data or science and the decision or the decision-making process itself. We didn't see that at the CDC/ACIP. Everybody expected the vaccine to be recommended. It was. So what happened? We're still in 1999 through 2000. Immediately, multiple class action lawsuits are brought against GSK. They allege predominantly 2 things: that the vaccine caused autoimmune arthritis, and that the company had failed to warn users of the vaccine, of the risks associated with administration of this particular vaccine, very often claiming that there was such a thing as a risk of autoimmune arthritis. Many different institutions looked into these claims, and so did the FDA and the CDC, and both non-regulators and regulatory agencies with expertise in these matters found that the claims were baseless. Glaxo ended up agreeing to a settlement, which didn't get any money at all to Lyme patients that were involved in this litigation. It merely covered the lawyers' fees, but it attracted a lot of negative publicity. As a result, there was low demand for the vaccine. So by 2001, and as you know from the maps, the public health problem had not gone away. If anything, it was increasing, but the company was only selling 93,000 doses per year, which is low, even for a vaccine that is administered only or largely in endemic areas, which were relatively confined from a geographical perspective. But these numbers are low compared to what we would have expected them to be. So the public is not buying into this, and importantly, because Lyme is not as known as, say, measles or other diseases are, at least to the public at large, physicians also are not buying into the benefits of the vaccine. There's relatively little awareness and unwillingness to prescribe. And a lot of it, the studies that were conducted at the time, a lot of it was attributable to this idea that they knew of litigation of potential risks. So the claims brought by a lot of the anti-vaccine organizations that, again, were well-funded. We've already heard something about this, and well-organized and very, very loud and nimble in the way they communicate to the public at large. But even physicians were hearing about these kinds of claims being made, and therefore they were under-prescribing the vaccine. That brings us to February 2002. That's an extraordinarily compressed timeline for a product that just entered the market less than 4 years. So in February 2002, the company that had the market authorization to commercialize a vaccine that was successful by any stretch of the imagination, if you're thinking from a medical perspective, they just decide to withdraw the vaccine from market and stop commercializing the vaccine. Only reason given: poor market performance. At the same time, a company that has now been absorbed into Sanofi Pasteur, one of the largest vaccine manufacturers in the world, they were developing their own vaccine candidate, Lyme. So if you think back to the 90s, we're back to the late 90s, the market is small in the US, but two large companies judge it to be big enough that they do put in the work to bring these vaccines to markets. Sanofi Pasteur gets the clinical trials underway in the United States. Data, as you see referenced here, is promising. Yet they don't bring the vaccine to market. Why? Well, observing what's happening at this point with GSK and LYMErix, they make two claims. First, the market is too small to make the vaccine profitable. So LYMErix becomes a case study in a market that turns out to be smaller than what the public health need indicated before commercialization of the vaccine. And there are also intellectual property concerns. They were also facing some threats of patent infringement from GlaxoSmithKline. So they said this is too much risk, right? The patent litigation risk, or the fact that we may have to negotiate with another company and pay them super competitive royalties. And it's just not worth it economically, because it turns out the market is smaller than our initial judgment, which was mostly based on public health need. I'll bring in a quote from one of the foremost vaccinologists in recent history, referring to LYMErix. This was the first time in the modern era that an FDA licensed vaccine in the US was withdrawn because of low public demand and class action lawsuits, despite the context of a high background rate of disease and the continuing, if not increasing, significant public health burden of morbidity. The consequence of this is that continuing significant morbidity and cost due to Lyme disease, both at the public level and at the individual level, continues to occur. So this was said a few years after market withdrawal, and we know from the maps that I began this presentation with, that public health threats and the rate of infections did indeed increase exponentially. All right, so let's get us to today. Let's hope I got the dates right and we're in 2026 and not before that. No, I got them all all wrong. This should read March 26th, 2026. So today and not a year ago. I was planning on doing a paper on Lyme disease vaccines even a year ago and 2 years ago, because new vaccines are in development, new vaccines targeting Lyme disease. But one of the signs, one of the glimmers of hope in our system is that in spite of everything that's happening in the vaccine ecosystem, we are poised to have a newly developed Lyme vaccine come to market. I would have phrased this with as many caveats as the ones that I'm going to go into in just a second. A year ago, or maybe not a year ago, but certainly 2 years ago. But I will note that we are sort of, history may be repeating itself or not, but we're getting back to where we were in the late 90s. So we now have different, better vaccine technology, and one large company, they're Pfizer, and another one that's not that small. They've partnered, and for the last decade, they've been working on this vaccine candidate. As I'll tell you in a moment, they're not the only ones, but they're the most advanced ones. If this presentation 2 years ago, I would be telling you a bit more about, do we really want a system that works like this, right? We bring a vaccine to market, we could curb infection rates, manage problems in a much more efficient, perhaps even humane way. And yet there's all this duplication, time lag in terms of products coming to market, all sorts of issues. But that's not what I'm going to talk about today, although I know that this is not how we would like for prevention and maintenance of Lyme disease to occur, right? That we have to basically go back to functionally where we were in the late 90s. But that's where we are in March 24, 25, 26. But at least some good news, we have a vaccine in the later stages of clinical trials poised to come to market. I'll talk more about the other Lyme preventatives out there to conclude this, but let me then use the present moment. So again, it's the late 90s again, functionally for us. We have a vaccine that is showing a great deal of promise. So that the clinical trial results were just reported 4 days ago, and they are promising. So the companies are submitting their application, their biologics license application to the FDA. So from the perspective of these emerging Lyme vaccines, which come with all this baggage, right? An area of a vaccine history that illustrates so many of the problems that are now magnified in the current ecosystem. So if we're bringing these vaccines to markets right now, what can we expect? And this is obviously where a 2026 presentation and thinking through these problems looks different from one we might have thought about a few years ago. So I'll finish with slides on the three and thoughts on these three aspects. I'll offer some reflections on the FDA side of things, and I'll contrast the situation this vaccine is in with recent hints from the FDA about what they're thinking about when they regulate vaccines and how they think about access to vaccines, which is a new thing, a more recent development in FDA regulation of vaccines. I'll reference the lawsuit that Professor Parmet already referenced, which I think highlights some of the things that affect both development and access to vaccines, but coming from a different part of HHS, so the CDC ACIP side of things. And then I want to just briefly reference some vaccine adjacent products, just to tie things back to my points. That's what's happening with vaccines. A lot of it is exclusive to the vaccine universe, but there are many implications also for the development of and access to non-vaccine products as well. So let me just start by offering, so the concluding thoughts, by offering some thoughts about the FDA side of things. And to do that, I'm going to reflect on something that FDA did very, very recently, which was to look at another marketing application from another company. You might have read something or heard something about this. So Moderna is seeking presently regulatory approval for its mRNA COVID vaccine for the 2026-27 season. This is an mRNA vaccine. So unlike Lyme disease, which we sort of don't fully know where, politically speaking and ideologically speaking, the administration stands on right now. We do know that mRNA technology is a disfavored technology. Going back to dollars spent on research, so NIH is not prioritizing that kind of research as it was until a few years ago. And from a regulatory perspective, FDA is beginning to behave markedly differently when looking at mRNA technology. So as the sponsors of as Pfizer and Valneva, the sponsors of any new vaccine, but in particular of our Lyme vaccine candidate, are about to do, Moderna went to the FDA. They had already had other products available, and FDA did something that was a first in the history of vaccines. They issued a refusal to file letter, which this is mildly redacted, but Moderna did post it on its website. So this happened last month. And this is, I don't know if you can see the cursor here, but I'm pointing at the bottom paragraph. FDA said, we have completed an initial review of your application to determine if it is acceptable. We have determined that it's not sufficiently complete to enable a substantive review. This was the first, as I mentioned, in the history of FDA review of vaccines. A refusal to file is indeed an indication that an application is incomplete. Now, when I heard about this, I thought, how strange, because the European Medicines Authority and drug regulators elsewhere from Australia to Europe, etc., they did accept a very similar application. I mean, the application that vaccine sponsors submit is very similar from all of these jurisdictions, partly because FDA set the golden standard, right, for drug and vaccine review. So all these systems are very similar. So why would something that's sufficient elsewhere be incomplete in the United States? And this is just amplified, but I also got this from the letter. So CBER, the center that regulates vaccines at FDA, said, we do not consider the application to contain a trial, quote, adequate and well-controlled, and the application is inadequate for review. Why not? Because your control arm does not reflect the best available standard of care in the United States at the time of study. First claim. Second, we've told you this, Moderna, right? I note that this determination is consistent with FDA's advice given to you prior to your study. Now, if I'm somebody in the public at large, or many of the people who started calling us, right, as FDA professors saying, oh my gosh, what did Moderna do? They have something that does not reflect the best available standard of care. You will be puzzled by this seemingly serious, right, language. The problem is that this does not really reflect any regulatory criterion that the FDA looks at when assessing if a vaccine is safe and effective. We don't ask about the best available standard of care. You're not going to find this in the law or regulations. And effectively what happened was that a certain vaccine with a certain dose was used for the control arm. Initially, the FDA told Moderna, hey, how about using a more potent vaccine? And this is a very normal conversation to have when you're engaging in clinical trial design. The Moderna came back and said, this is why we're using this particular level and not a more potent one. And FDA at the time said, okay, we agreed to let you proceed. So they agreed with that. So there is a letter that says we want to discuss your design and we want to recommend a more potent version of the vaccine you're using, the control arm. And then there's a determination from the FDA that they're actually fine. This was months and months ago with what Moderna had done with clinical trial design. Then they let Moderna proceed with their clinical trials. And at the end of it, they said, no, remember we disagreed about it. You basically did not comply with FDA's instructions, which is factually inaccurate. Also, this idea that they're applying the best available standard of care sounds like a legal criterion, does not really exist in the law. A few days later, against enormous backlash, they backpedaled and they agreed to review the application. But they bifurcated it and said, for some patients, we're going to review this in an expedited way. They have ways to do this, to do expedited review. The pathway that they chose, which normally is negotiated between the FDA and the sponsors, much, much earlier in the process, not when you submit your application, you have conversations about this earlier, much earlier. That particular pathway enables the FDA to require confirmatory clinical trials. So more clinical trials, the most expensive and time-consuming part of the process. We'll know by August 5th what the decision on this one is going to be. So they first said it's incomplete, and they said, wait, it's not. But then they trigger the application of a review pathway that enables the agency to require clinical trials, additional clinical trials, which we normally don't see and have not seen in comparable flu vaccines, even in the context of mRNA vaccines. What is the Lyme vaccine going to face? We don't know, but there's a lot of uncertainty. And one of the things I want to emphasize, a lot of official and legal sounding language that actually does not reflect a legal standard. So there's uncertainty at the FDA level. There is massive uncertainty at the CDC ACIP level. I will briefly reference the lawsuit that Professor Parmet alluded to. It is vaccine related because the American Academy of Pediatrics challenged a number of relevant things. The appointment of ACIP members after Kennedy fired everybody in the summer of 2025. And replace them with the judge opined here, not qualified members, many of them with very limited experience in the vaccine field and known to have promoted anti-vaccine views. They challenged ACIP decisions since the replacement of the committee, and they challenged the memo after an order from President Trump that HHS used to reduce the pediatric vaccination schedule, and the recommendations went down from 17 to 11. So last week we had a federal district court issuing a preliminary injunction that stayed all this. I note that the pediatric schedule and the Lyme vaccine don't go hand in hand. The vaccine is being developed primarily for adult populations. But if you already face uncertainty at the FDA level, and then you don't know if your vaccine is even going to be recommended by ACIP, the one from the 90s was, right, as we expected, vaccines with strong data on efficacy and with no known safety problems. Normally, they've been recommended by federal advisory bodies, and then the decision at the CDC level to add them to a schedule or to recommend it makes them eligible for a number of things and triggers a host of legal consequences that have to do with coverage and beyond that. But the uncertainty that we face right now, if you are a new vaccine sponsor coming to market, Lyme or not, right, you also face that. I will highlight in passing, I have, I think, 2 slides left and I'll race through that. I will highlight the tone of the decision because I think it fits perfectly into the themes of the day. The judge begins with science, like law is far from a perfect instrument of knowledge. History is littered with once universal truths that have come under scrutiny. Nevertheless, science and law is still the best we have. And it goes on to heavily criticize what HHS has been doing, many branches within HHS. So I will highlight that tone that ties into many of the discussions I think we're going to have today. And note that just yesterday, the Children's Health Defense Fund, the Secretary Kennedy's previous organization, anti-vaccine organization, petitioned their proposed interveners. They're trying to join this lawsuit as it is poised perhaps to go on appeal. So this is getting a lot of attention, and it's casting a lot of doubt about the status of our vaccine regulatory system and indirectly or directly vaccines in general. And finally, in 30 seconds, even if you are not bringing a vaccine proper to market, you're still going to encounter these players and these countervailing forces, organizations very effective at promoting anti-vaccine discourses. What are vaccines? They are preventatives. They are they are biologics, and there are even more complex biologics now being developed and close to being brought to the FDA to target Lyme disease and to also have a preventative function. So a company near where I am in New Jersey is developing one such product. And they already face a lot of unknowns. How will FDA regulate? Are they going to play some kind of regulatory game and try to change the standards or misrepresent what has happened? What will ACIP and CDC do? How will the lawsuit turn out? How are we going to have a new ACIP membership? Will they act in a way that's more in line with science, etc.? Will the states, something else Professor Parmet mentioned, particularly those in the Northeast, be willing to be more expansive in terms of covering or granting access to either vaccines, but also these kinds of preventative products if the federal government disfavors them? And what about the public? What are people going to do to anything that they perceive to be vaccine-like, even if it's a different type of product? So this raises many questions also at the trust and informational level. So I'm going to stop here, and I look forward to later on your questions, but most immediately to Professor Rice's presentation. Thank you.
Thank you. I'm going to wait a moment for my slides to go up. Thanks. Thank you. So I'm going to build somewhat on this, what you've heard from Wendy and Anna, and I'm going to tell you the story of HHS completely ignoring or violating norms of good governance. And I'm going to start by explaining why it's important. But the reason I think we should focus on these are threefold. One, because if we're looking for increasing trust by industry for the purposes Anna talked about, or the public and so forth, violating norms of good governance undermines that. Second, in terms of the problem it shows us, I think it shows us a deeper problem than the specific decisions, because one of the things that's going on is eroding of our institutions. And third, this is an area where we can actually do something, because courts may be a lot more inclined to intervene when you're violating procedural norms and established norms of administrative law than when it comes to substance. So I'm going to introduce a topic and highlight this, and I hope it comes together in a coherent story. So, reminder. How many of you remember your administrative law classes? If you don't remember, this is a reminder that what we're trying to do in administrative law is to balance, on one hand, allowing government to act with other important values such as transparency, legitimacy, individual rights, and so forth. We want to allow expertise to go forward, but also allow responsiveness, allow democracy and other value. It's never perfect. Our administrative law has a lot of issues, but it's still important to keep the basics. As a reminder, ideas of good governance have been debated both on a global level. There's a number of World Health Organization documents that set out what does it mean to have good governance. And they generally focus on transparency, accountability, participation. And it's also been debated nationally. We have the Administrative Conference of the United States, which is an agency created to offer recommendations on how to improve government. And those of you that do remember administrative law might remember that you've spent a lot of time addressing the lead from notice in a variety of contexts, rulemaking, but also individual notice to people. There's several rules that allow for participation. Agencies are required to explain, and courts are very aggressive sometimes in overseeing those explanations. And hopefully we will look at the rule of law. Now, I realize that the story I'm telling is not specific to vaccines and not necessarily specific to HHS, but that's my corner and I'm going to stick to it. And I think that very little embodies the complete drop of administrative law norms as this moment in May 2025, when the Secretary of HHS, the Director of NIH, and the Commissioner of the FDA got together and in a 53-second video told the population that they're delighted to announce that they're unrecommended COVID vaccine for pregnant women and healthy children. Why am I stopping at this moment? Since a lot have happened since. I think it really captures the problem. There was no notice of what's going on. There was very little explanation. The video was 53 seconds. It said very general things about children. It said nothing about pregnant women and why they're moving it. And it was accompanied by a very short memo after the fact that really gave a very simplistic view of the data, including a couple of AI-generated untrue citations and one study that was wrongly cited. And it includes the wrong people. These are not the people making vaccine recommendations. There was no one from CDC. So I think it captures a really deeper, more general problem. Let's look at that problem a little closer. So as a reminder, one of the most important things in administrative law is the need for notice. For notice to mean anything, it needs to be before the action, not after it. So, for example, when the member of the Advisory Committee on Immunization Practices, as mentioned by Wendy, were told that they were dismissed, they heard about it after the secretary put an op-ed in the Wall Street Journal behind a paywall, not before. Hearing about something after it's done is not notice. Sometimes the due process clause requires notice, and ignoring it is a constitutional violation, not just an administrative law. And giving notice has something that's part of the law, not just in the US, but in other democracies as part of basic fairness, especially when you're dealing with an action that affects an individual. What's going on HHS on notice? So, as you know, a lot of officials have been fired from HHS, including in the vaccine area, and some of them only found out when they got to work and they couldn't budge in. No notice. They were not given an opportunity for a hearing. Now, you don't need a hearing when you're reducing the workforce, but some of these people were told that there are issues, more specific issues with their performance. Still, there was no notice. When the HHS received grants, as we've heard mentioned, there was no notice and opening for hearing against. Here again, people got short letters telling them their grant were rescinded. This is not generally how administrative law works. You're supposed to give notice, opportunity to hearing, and move on. Both Wendy and Anna mentioned the schedule change. On January 6, 2026, the Secretary of HHS, with a number of other personnel, announced that the schedule is changed and 6 of our previously routinely recommended vaccines are now recommended at a lesser level, either for specific risk groups or for under shared clinical decision-making. Again, this was not noticed beforehand. In fact, we initially heard about it in December 2025 because of a leak. There was a leak that this is about to happen. There was this very strong reaction and the plan was rescinded. We all went on winter vacation. Some things happened during the vacation. One of the things that HHS has been doing, by the way, is doing things on Friday at 4 p.m., which is, again, another way to try and reduce attention. This doesn't work anymore because we all expect it. And then after New Year, it was again announced without any prior notice, certainly without opportunity to deliberate. The other side of notice is letting people deliberate and discuss the issues. We've seen a marked lack of deliberation on changes from the administration. And I want to go back to Anna's point about vaccine policy. Anna focused on specific decisions on specific cases, but FDA has been doing another thing, which is setting out framework guidance in paid journals. Again, in vaccines, they've set out several framework for assessing vaccines in medical journals, at least one of them behind a paywall, without any opening. As those of you that have worked with FDA before remember, the usual way FDA used to change its big policy framework was publish a notice, give opportunity to comment, sometimes hold public hearing, but at least give opportunity to comment, and then publish the revised guideline. None of that is happening right now. The schedule change, again, the schedule change was actually presented before it was announced to ACIP by Dr. Tracy Beth Hogg, who is now the acting director of the Center for Drug and Evolution Research. She did a presentation, members asked questions, but there was no public opening of the presentation for comments. There was nothing there. And before the agency announcement, again, there was no publication of this is our plan and opportunity to deliberate. Just didn't happen. I want to mention one more thing, which is there's an advisory committee that most of you probably never heard of called the Advisory Committee of Childhood Vaccine, whose focus is on changes to the vaccine injury compensation program that both Wendy and Anna mentioned. That committee is statutorily required to meet 4 times a year. In 2025, that committee met for 4 back-to-back half-hour meetings in December 29, which I hope most of you realize is when most of us are on vacation. It held presentation, and while there was an opportunity for public comment and for members to ask questions, 4 back-to-back half-hour meetings is not a great way to deliberate on the effects of the committee. So what we're seeing is pretty extreme. Let's talk about hard look. I teach this over 3 classes in administrative law. I'm going to boil it down to 2 minutes. So there's 2 things you need to keep in mind about what the courts require for agency explanation to survive judicial review. The first is that you don't need to read the slide. Agency explanation needs to be in real time. The 1943 Chenery Doctrine says agencies have to explain their action when they do them. Coming up with new arguments for litigation doesn't work. The second is that agency has to meet, again, don't read this slide. This is a slide I use for administrative law. The message I want this slide to give you is it's complicated. Agencies have to meet a number of demanding requirements for their explanation to survive judicial review. I also want to remind you of some other things that those of you that took administrative law may remember. If you change a policy, you need to explain 2 things. Your policy on the merits, why you're doing this, and why you changed. What's wrong with the private policy? What changed over time? Also remember that there's a long-established jurisprudence by the Supreme Court, including in FCC versus Fox by that luminary of liberal thought, Justice Scalia, that presidential administration change by itself is not an argument the agency can use to survive judicial review under the arbitrary and capricious standard. That's basics. How did it work for this in NIH? So you may remember that on March 10, 2025 was the first round of rescission of NIH grants, including on mRNA and vaccine hesitancy. Here's the explanation that people who lost their grants got. It is the policy of NIH not to prioritize research activities that focus on gaining scientific knowledge on why individuals are hesitant to be vaccinated. Therefore, the award is terminated. That's it. No discussion of the fact that these are already awarded grants and people are relying on them. And I will point out that we have several cases from the Supreme Court, including the case of the memo of DACA that says not addressing reliance and interests makes the agency explanation not good enough. And why this policy? Tell us why this is your policy. Put it somewhere. Not in this. So this is a very cursory explanation, doesn't address the specific grants, normally would survive. In March 24, 2025, the administration clawed back $12 billion in funding that was designed for, initially for COVID pandemic, but states were using this for a lot of public health things, including in vaccines. Taking it back meant that many states fired parts of their public health personnel. Minnesota shed a lot of people, to give one example. I don't know what happened in Missouri. Here's the explanation. At the end of the pandemic, provide costs to terminate COVID-related grants. Now that the pandemic is over, the grants are no longer necessary. No explanation on why you're receiving these very important grants. Very short, very cursory. Let's talk about the schedule change. So in January 2026, as I mentioned, the schedule was watered down, I think is a fairer way to say it. It was explained by a document written by Dr. Tracy Beth Hogg and Dr. Koldorf, neither of which is an acknowledged expert in vaccine. And the explanation memo had a number of really, really problematic aspects. It made some problematic claims, such as claiming the US has a limited post-licensure infrastructure, so every infrastructure is going to be limited. But the US has 4 different monitoring systems to oversee vaccine safety. We have more on this than in any other drugs. So tell us a little more. Presenting the US schedule as more of an outlier as it is. The US schedule has some differences from several European countries, but is, for example, similar or less than the Australian and Israeli schedules. And is most of the diseases are European peers. If they're peers, do vaccinate against. It alleged 84 or 88 vaccine doses. I don't know. No children in the United States, as far as I know, get that number. In terms of coverage, so it had about a paragraph on why they're downgrading the rotavirus vaccine. It had a very short discussion of each vaccine, and the discussion completely ignored the harm of moving away from the vaccine. It didn't even discuss the risk of cases of diseases. This is a really glaring something that's not there and usually would not withstand judicial review. The review of the data for the safety and effectiveness of the vaccine was very limited, cursory, partial, and incomplete. It didn't discuss what makes countries peer countries, and it didn't explain why they ended up following the Denmark schedule. For example, they didn't address any differences between the Denmark and the US. You all agree with me that Denmark and the US have some differences, right? So I can say more on that, but I know that I'm standing between you and your lunch, so I'm going to keep this to this. And I will mention that so you will hear after lunch about AAP versus Kennedy more in depth. These are not the arguments the judges focus on. I'm trying to not have too much overlap in this talk. But these are glaring omissions that normally would not withstand judicial review and didn't. One of the things that's going on in the background, one of the reasons this is important is there are over 40 cases brought against the administration on these administrative law issues, and the administration is doing very badly. The last issue I'll mention before I conclude is the administration is also not ignoring the rule of law to a large extent. For example, and again, I'm avoiding the point in AAP versus Kennedy, the administration is ignoring the requirements of the Federal Advisory Committee Act. I'm partly ignoring them. For example, FDA is convening things that are called panels to give advice. Maybe they think they can avoid the Federal Advisory Committee Act by calling these panels, but it doesn't work this way. If these are committees you're putting together to give you advice, you should follow the rules of Federal Advisory Committee. The real notice issue with meetings, both for vaccine and for other areas. For example, for the panels, the members of the panels are often not announced in advance, or at least used to be. I think they've gotten better about that. For ACIP, notice is often very shortly before the meeting. It's clear that members of ACIP and other committees meet and discuss things outside the meetings, which isn't something they should be doing. And for ACIP specifically, we've seen repeatedly that the votes were not known until the meeting, and there's some indications that the members of the committee had no idea what they're voting out until it was described in the meeting. The public certainly did not know, and during the commenting period, the public didn't know. Again, as I mentioned, ignoring line between NIH, FDA, and CDC's role in vaccine is something that happened consistently. And finally, another thing we're seeing is overriding the lines between federal and state law. For example, this is a Dear Colleague letter that was sent to doctors across the states by the federal government, warning them that the Vaccine for Children program that funds childhood vaccine may be at risk for the state if they don't make sure that the school mandate has a religious exemption. School mandates are state laws, Wendy told us. This is direct federal pressure interference in something that's traditionally a state issue, and we're seeing quite a bit of it. The federal government is putting pressure on states to move in an anti-vaccine direction in several ways. We're also seeing the federal government ignore sometimes blatant statutory requirement. For example, for grant rescissions, one of the points in the litigation against it is and a point that was accepted by federal district court judges, ignoring statutory requirements on how to rescind grants. There's a procedure in several statutes about some of these grants, and they were simply ignored. As I mentioned, the ACCV is supposed to meet 4 times a year. Crunching those into 4.5 hours on December 29 isn't really compliant. And further, the secretary dismissed, so the committee's composition is set in statute. It has to include an agency representative. The secretary dismissed her. So we're seeing ignoring of even a very clear statutory requirement. So my bottom point is administrative law has its issue. As Wendy said, our previous system were far from perfect, had a lot of issues. But what we are seeing is eroding of even basic principles of administrative law, and these are there for good reasons. They're there to provide transparency, accountability, and without them, we shouldn't be trusting this agency. The decisions have been non-deliberative, non-transparent, and often fail to follow the rule of law. This leadership is unlikely to change its course. Even losses in court might not be enough, but the problem runs deep and is likely to continue. And finally, given the blatant violation of these norms, these agencies' decisions do not actually deserve deference. One of the challenges long-term is that not deferring to these agency decisions that don't deserve deference might mean that we don't defer going on, which will further erode deference to expertise. But the reality is that an agency that ignores the most basic norms of good governance doesn't deserve deference. I'll stop here.
Hello. Yes. Okay. Bad. Okay. So we have some time for questions.
Maybe you can bring Anna back.
She's there. She's just behind the scenes. Well, I'd like to start with a question. So I am not only a vaccine law geek, but I'm also an admin law geek. So talking about arbitrary and capricious and hard look is right up my alley. I guess my question is this: am I right should I be seeing the fact that courts have declared federal government actions as arbitrary and capricious related to vaccines most recently as a good sign for good governance? Or should I see it as almost the canary in the coal mine? Our governance has sunk so low that even the incredibly easy to, the bar of arbitrary and capricious is so incredibly low that if it has teeth, that just says the quality of our governance has sunk so low that it's now a meaningful standard of review.
Yes. So my husband likes to answer every or question with a yes. So the short answer is, it's a good sign that our courts are willing to step up and draw lines in the extreme cases. That's something we can do, and we should use it, and we should push that. However, the fact that we need, and the fact that the rate of loss is so high, so for all of you may or may not know that historically, government used to win 60 to 70% of those arbitrary and capricious cases. The first Trump administration was an outlier in that many cases were lost. One of the issues here, this is not a Republican Democrat issue. This is so our civil servants know how to ride these and have done it for administrations from both parties across the time, but they need to be allowed to do that. So what we're seeing is the administration not even trying to meet those basic norms, as you're saying. And so on one hand, it's good that the courts are stepping in, but on the other hand, the fact that this is such an easy target means that we're in real trouble in terms of our government following basic norms.
So yes, both.
Can I jump in with a very quick comment, Rob?
Please.
Yes.
A related point, I think everybody in that room is a big believer in the judicial system. We'll see what happens, for instance, in the case that by now we've all mentioned, AAP via Kennedy. In the meantime, a lot of the damage is done. And that's why I talked a little bit about the Lyme vaccine. Word is getting out there that there is something wrong with the judicial system, right? That's a wrong, that's not an accurate comment, but that's how it's being portrayed, right? The judge in the blogs, and I'm sure in areas I don't have access to, is being insulted, diminished. There's so much criticism of this decision, and there are so many things said about the decision makers that doubt is cast. Ditto with the entire process or what the vaccines that are involved. Why are we not looking at Denmark? Yes, we know that Dorit and I know that's not the same scenario. Not everybody might find that a persuasive argument, right? That as they see it, higher income country to higher income country. Why not, right? So that reputational or doubt related area, the damage is done, a lot of it.
Agreed.
Well, you're just going to defer to me to keep asking some questions. There we go. Go ahead.
So this, I'm going to try to turn into one question, but it really is maybe two. This is Nicole. Hi, Dr. Richmond. Okay, so for the Lyme disease information that you talked about earlier, I'm wondering if you think that a vector-based solution may impede the necessity for a vaccination, as well as the necessity to even bring up the ability to have the re-upping of the approval for that vaccine. Also, I'm wondering if potentially there may be a solution to have a combined vaccine also fighting against the alpha-gal syndrome that we're currently seeing within the tick population, and if that might become a more viable solution, and a more, with that becoming especially more prevalent in the East Coast, a more necessary vaccine would be potentially a combination of Lyme disease with that.
So, hi, Nicole. I'll just say briefly. So, and like Professor Rice, I start every answer right now with, I don't know. Right. I know that there's a scientific / public health answer to your question. It's probably along the lines of what you are suggesting. But if you are bringing these vaccines to market, it's almost game theory, and it's a risk assessment that is not exclusively, sometimes even predominantly rooted in public health considerations. So we keep having public health demand, and all the legal interventions already alluded to, and that I think we'll continue to discuss. I mean, they are perfectly adequate, right? But it's kind of a whack-a-mole kind of thing. We solve one problem, maybe arbitrary and capricious allows us to basically stay with the vaccination schedule we have, but then something else happens. And if we are to pursue what you suggested, the necessary interventions from a public health perspective, how much risk are the companies, the sponsors willing to take in coming to market? Because market demand and public health demand are no longer the same. It used to be much truer in the case of just specific, outlier things like the Lyme vaccine. And now I think it's generalized. And I don't know how to solve that other than, as Professor Rice mentioned, is to keep highlighting, surgical interventions, but they're still not enough.
A question from one of our Zoom attendees. As to Denmark, isn't it true that the country has universal or close to universal health care such that children have access to better preventative and other health care than is true in the US? This is a reason why this country could not be a good comparison country.
I think that's a really important distinction point. Denmark has universal health insurance coverage. Denmark also has generally a robust social network. So they have paid leave. If the parent has to take time, they can do that. They have other protection for income and for survival. They're also a small, homogeneous country with much lower income inequality and levels of poverty than we have. All of these are meaningful differences. And also the risk profile for some diseases, I think, and I'm not an expert, maybe Anna knows more, or maybe some of you know more, but I think that our hepatitis B risk profile is higher in terms of prevalence. Certainly we have more cases, but that's partly because we're a big country. But yes, the health insurance is a big difference, and there are also other differences that make Denmark a tricky comparison. And Anna's point that that in terms of misinformation, the messaging is tricky to counter is, of course, completely true.
Thanks. These are great presentations. Dorit, you talked about the fact that the change of administration isn't sufficient. I guess if I could ask you to sort of talk a little bit. I mean, I think one of the things we're seeing is the clash, right, between administrative law and the signaling the Supreme Court gave the last few years for the rise of the unitary executive, right, which really pushes to that idea. And so, right, we see early in the Trump administration, pretty blatant, and one of your quotes has it sort of like, not in line with the president's priorities. That sort of becomes what the rule is. I wonder where you think, because we have not really seen a Supreme Court case other than the tariffs case, and that's kind of quite different. I think we can all recognize where the Supreme Court's going to go, sort of with this clash between administrative law and its the predilection or favoritism of some of the justices for the unitary executive.
So this is a question that deserves an hour-long answer, but I'm going to make 3 points in response, and I realize that it's not comprehensive. It's just a matter of timing. The first point I'll make is you're correctly saying we have a line of Supreme Court cases that emphasize the unitary executive. One area I didn't talk about is the appointment removal area. And we've seen the Supreme Court privilege political appointments in ways that make it hard to have civil servants that are independent from politics. So I don't think they're going to go back from that. So one thing that's going to happen in the background is the Supreme Court is going to continue to support political control over experts, which is going to make giving experts more leeway tricky. The second point is we are seeing that the HHS ignore norms that the Supreme Court has put in place, such as the Supreme Court has used arbitrary and capricious pretty aggressively. And again, they're not even trying very seriously to meet the basics. I think the Supreme Court is not going to be happy with that. They're going to want them to at least pretend to try. But the third part is going to your point. We are seeing from some judges some caution in response to some differences in response to different administration. I think it's hard to ignore that. And that's going to feed in. I will say that on the specific topic of vaccine and HHS, the partisan picture is a little more messy. It's true that mandates are increasingly tied to political identity, but a lot of these issues aren't about mandate, they're about access, and that's less tied to political identity. The Supreme Court might feel more comfortable upholding the things it used to say about administrative law in this context. There's more to say, but Anna, you want to add to that?
I will not talk about the administrative law side of things, and instead I think I'll just use this to piggyback on a comment about vaccine federalism and public health federalism. And under these circumstances, I don't know what's going to happen politically speaking in the nearish future, but I do know that what we are seeing with the increased lack of reliance on federal decision makers is further fracturing our public health system, and in particular the vaccine system. So all these discussions, and particularly the ones that are administrative and constitutional law specific, I think are a point for many of us to interrogate vaccine federalism and how it has worked out, how when one of the a locus for guidance is broken, how it quickly shatters into these state level leagues. And I think again this is the ecosystem just shattering, which from a public health perspective, usually we like something a bit more homogeneous, right? So there are many ramifications of all of this, and also it leads me to interrogate how do we want to structure this movement when we get past all of this, right? How do we want to structure our two-tiered approach to public health, but particularly to vaccines, right, and vaccine access in particular?
Well, I want to thank our two speakers on this first panel. This was wonderful. So Professor Rutschman, Professor Rice, thank you so much. We appreciate that.
So much for coming back after lunch, or if you're joining us for the first time this afternoon, also thank you for coming. I am Kelly Gillespie. I'm the director of the Center for Health Law Studies and have the distinct honor of moderating this panel, which is an amazing panel that Professor Sinha has assembled for this session. The plan is that I am going to do short bios, introductions on each panelist, and then we will turn it over to Dr. Maldonado, who is via Zoom, to start. And we'll save the questions for the Q&A session at the end. All right? All right. So let me tell you about our distinguished panelist. Jennifer Suh is the Pediatric Medical Advisor at the Illinois Department of Public Health. She is dual board certified in both internal medicine and pediatrics, and advises the department on health matters, provides subject matter expertise on vaccinations across the lifespan, supports public health recommendation and policy development, and serves as a liaison between healthcare providers and the state health department. She is formerly Chief Medical Officer of the Chicago Department of Public Health, where she led the city's public health healthcare system coordination strategy. Dr. Suh completed her medical training and a clinical ethics fellowship at the University of Chicago and earned her medical degree at Vanderbilt University School of Medicine. She also, because she's clearly an underachiever, holds a law degree from Columbia Law School. All right, our second panelist I want to introduce is Richard H. Hughes IV. He is the lead counsel of the American Academy of Pediatrics versus Robert F. Kennedy Jr. case, and he is going to share some interesting developments on that. He is also partner at Epstein, Becker, and Green. He's a nationally recognized thought leader in vaccines and prevention, and works at the intersection of public health and healthcare law and policy. He has led major efforts to expand and protect access to vaccine and preventative services and to strengthen public health outcomes. At his firm, he leads a multidisciplinary team of attorneys and advisors, and he previously served as vice president of public policy at Moderna, guiding the company's policy strategy during the COVID-19 pandemic. Again, another underachiever. He teaches also, in addition to all that, teaches vaccine law at George Washington University Law School, is a frequent public speaker and commenter, and has published works and media appearances in leading national outlets. All right. And our third speaker is Dr. Yvonne Bonnie Maldonado. Dr. Maldonado is the Vice Provost for Faculty Advancement, the Taub Endowed Professor of Global Health and Infectious Diseases, and a professor in the Department of Pediatrics and Epidemiology and Population Health at Stanford University. An infectious disease epidemiologist and former Senior Associate Dean for Faculty Development and Engagement. She also serves as the Stanford's Vice President of Faculty Advancement, which I did mention already, so I apologize. That's my fault. Her research focuses on the epidemiology, transmission, and prevention of vaccine-preventable disease and perinatal HIV infection. She has led NIH, CDC, Gates Foundation, and WHO-funded studies in the United States and internationally, and has conducted extensive research on COVID-19, served on major national, international committees, including ACHIP and the NICHD Council.
as she has published more than 300 peer-reviewed manuscripts and is the co-editors of Remington and Klein's Infectious Diseases of the Fetus and Newborn and the AAP Red Book, our third underachiever. With that, I'm going to turn it over to Dr. Maldonado. Thank you.
Well, thank you so much for that introduction. And I'm really honored to be part of this panel of experts in this area. And I am going to share some slides so that we can talk a bit about setting the groundwork for what's to come in the panel. And hopefully you'll have a robust discussion as well. And let me just share these slides. Oh, darn. Where's the share function here? I can't find it on the screen. Let's see. Hold on. Sorry about that. Okay, here we go. All right, so I'm going to take you through a bit of information, and I know you've had some great speakers already talk about vaccination and vaccine law and public health, but I, as you heard, do a lot of work in the area of vaccine preventable diseases. My research has been primarily in field trials and developing settings, looking at vaccine implementation and effectiveness in non-traditional settings around the world. And more recently have been working at the national and international level around vaccine policies and public health. So my topic today is really about our current U.S. vaccine system. We're at a crossroads, and are we how do we reinvent ourselves or risk regression? And so just my disclosures, I have not had active clinical trials since June 2024, but I do disclose that I was the Stanford Pfizer pediatric and maternal RSV vaccine clinical trials investigator for those studies at Stanford, and have served at the NIH in a number of capacities, as well as an advisor on their council. Now, what I want to talk about today is really just an overview of the roles as they existed in the past of the FDA, CDC, and ACIP. And as you'll hear, and as you've already heard, we are not clear what the paths of the FDA, CDC, and ACIP are, even at this specific moment in time. But I will give you the traditional view of these very long-standing and very trusted organizations and agencies. So this is a paper that I published with my colleagues. And just by way of introduction, you may have heard that last June, the Secretary of HHS summarily fired 17 members of the Advisory Committee on Immunization Practices. This is a congressionally mandated committee that must advise CDC on new vaccines and new indications for existing vaccines. I was a member of those 17 members, and we were let go without formal notice. We read about it in the Wall Street Journal in June of 2025. And at that point, we've continued to work together, the 17 of us, to really publish data and really help people understand how we can move forward. And this is a paper from last year that we wrote around the path forward for vaccine policy in the United States. But one of the figures that I wanted to show you here is that this is just the generally accepted way that ACIP and vaccine policy in general have been really have been operationalized in the US for many decades now. So at first, obviously, the clinical trial or real world data must be generated. It has to go to FDA first and their advisory committee called VRBPAC, that vaccines related and related biological advisory committee. And that panel looks at the actual clinical trials data and determines whether vaccines are safe and effective. They provide licensure and approval in some cases. Then there is a mandated, there's a requirement, it's a legal requirement that any vaccine that is licensed and approved must go to the ACIP. So this isn't an option. It has to go to the ACIP, who determines all the granular decisions around what this vaccine will do and in what communities it should be utilized. Then generally the CDC director will sign off. They may or may not agree with the ACIP. In the past, they were fairly aligned with the ACIP. By the way, the ACIP, and I'll describe who they are later, are not government employees of the CDC directly. And then, of course, there's public access to these products. Now, let me go into a little bit of depth here around this because it sounds like it's a pretty straightforward and simple approach. And one of the criticisms that the Secretary of HHS made in letting this go is that we were deemed to be rubber stamping industry products. Now, you see that very first square at the top. When you talk really about the development of vaccine recommendations and policy in more detail, that first box says vaccine development and testing. That box alone can take 5 to 10 to 20 years and can cost $100 to $500 million, $100 million to $500 million to do. So that's not a simple little box. That takes a long time. There are many products that come through that process. Most of them don't make it to the next step. And so when the public sees us meeting further down the list, where you see us meeting with the CDC and the FDA, et cetera, by the time we've gotten to that second box, it has taken sometimes a decade or more and hundreds of millions of dollars, with most of the products not making it to that point. And so when you think that, in fact, we are rubber stamping, there have been hundreds, if not thousands of hours of deliberation to even get to the submission to the FDA for a license and then discussion of the FDA licensure. So by that time, all of us on these committees have reviewed the data around safety and efficacy of these vaccines and the different populations that they have been studied in. So that is really an understanding of which has really been missed in the discussion about what these committees actually do. Now, as I mentioned, the VRPAC for the CDC, for the FDA advises them. They go through the data in great detail and have open public meetings about discussing what this product might need to in order to get further consideration for licensure or not. And again, most products don't even make it this far. But once they do get licensure, that licensure is based just solely on the clinical trials data. Now, once the vaccine product or the vaccine product goes to the CDC, the advisory committee must take up the discussion of this product at the next meeting. And these meetings are generally held 3 times a year. And by that point, the committee members have really been tracking these products for years, if not longer. Side by side with CDC, there are many other national medical societies, including the American Academy of Pediatrics, where I actually served as chair of that committee, of the Committee on Infectious Diseases for the Academy for 4 years, and served as a liaison, non-voting liaison to this meeting for many years. Once these considerations go forward and are voted on and the CDC director approves them, they are published in the federal MMWR, the Morbidity and Mortality Weekly Report. Those are official CDC policy. They are also published concomitantly in other National Society journals, such as the Journal Pediatrics, which is the flagship journal of the American Academy of Pediatrics, and other agencies, other federal national societies also publish them. Now, here's where it gets tricky, because now you've got an approved vaccine recommendation, but you also need uptake and financing, which is the critical piece, right? A vaccine is no good if it sits in the bottle. This is where state laws really come into play, where uptake and financing is really state dependent. And there you depend on public sector and private sector funding in addition to federal funding. And this is why our system of vaccination, like other healthcare systems in the US, are so fragmented, because we have a piecemeal implementation of vaccines. Now, let me talk a little bit about what the ACIP looked like prior to June 9th, 2025, when 17 of us were dismissed. Up until that point, up to 19 voting members were allowed on the committee, including the chair, and there was a very rigorous process for selecting members. As you can see here, with a 4-year term, HHS selects these individuals, and most of us took on average 1 to 2 years to get selected and sworn in to this committee. Now, when we were dismissed in June of last year, within 48 hours, 8 new members had been posted and accepted. One of them actually had to decline because of some unknown conflict. And there's always a consumer representative as well. And we're thoroughly screened, not only before, but during and after every single meeting of this committee. There are also ex officio members from federal agencies and 30 liaison organizations in the past representing national medical societies. And then behind the scenes are the workhorses, which are the work groups comprised of anywhere from 10 to 40 or 50 individuals from the CDC staff to subject matter experts to others who really help work through the day-to-day data collection and analytics of what it takes to get a vaccine to the ACIP for a vote, a review, and a vote. So this is really how this used to work. I won't talk about how it works now because I think my colleague panelists will talk more about that. So just to recap, the FDA compared to the ACIP, the FDA licenses vaccines based on clinical trials data alone. The CDC and the ACIP make evidence-based recommendations for vaccine use based on other clinical data, surveys, polling of membership, polling of the public to really understand what it takes to get the vaccine into local community settings. The FDA is a regulatory agency. The ACIP is not. The FDA, however, does not regulate the practice of medicine. So once a vaccine is licensed, anybody can use it, just like any other product that the FDA approves. Anybody with a medical degree, and to a certain extent, some pharmacists can actually prescribe these products, whatever they might be. So they don't regulate the practice, although, of course, people are still liable for their practices. They do not regulate that. The FDA, again, licenses only on the basis of clinical trials and data submitted by the manufacturers. And the manufacturers can only market vaccines based on information that they put together alongside the FDA into the package insert. So therefore, the ACIP recommendations may differ from the FDA licensure, but they only served really to expand the meaning and the clinical guidelines on how a vaccine can be used. For example, what happens if you miss a dose on the regularly scheduled time? How should you make it up? Should you make it up? What if the vaccine is spit up? Do you give another dose? Or if it's not, if the person has underlying conditions, what do you do about that? So there's lots and lots of depth to the ACIP recommendations that are different from FDA licensure. Now, what happened after June 2025, there have been a number of things. I'm just going to highlight the highest level significant issues. As I mentioned, the abrupt removal of the 17 ACIP voting members, appointment eventually of 11 new members with significant conflicts of interest in some cases, and especially anti-vaccine interests. And I'm not saying that lightly. These are people in some cases who've published extensively anti-vaccine tropes and misinformation and over the course of time. And apparently, we never got a firm answer to this, but there are specific guidelines on how vaccines are recommended using metrics for recommending based on safety and efficacy. And the removal of all of these has been clear since this new group started. And those include a process called evidence to recommendation, a PICO and GRADE, which are very highly metric and outcome-driven assessments of each of the vaccines for assessing vaccine, first of all, safety and then efficacy. There has been a tremendous amount of lack of transparency and absolutely lack of scientific expertise in these meetings, with significant mis and disinformation presented at these ACIP meetings to support weakening of the childhood immunization schedule. So, for example, just from September, the 2 September and December meetings in 2025. So in the past, the meetings were held generally in February, June, and September. This year, we held our February meeting. The June meeting was not held. There was a meeting in September, and then there was an extra meeting held in December. And in those meetings, the ACIP voted to remove thimerosal-containing vaccines from the U.S. formulary. They removed the choice of measles, mumps, rubella, and varicella vaccine as choice for the first pediatric dose. They removed the universal recommendation for the newborn hepatitis B dose. They added a suggestion to use hepatitis B serology after the first hepatitis B vaccination to determine whether to consider subsequent doses. That actually wound up not making it through, but that was a very last minute, poorly put together recommendation based on no data at all. And then recommended future votes on studying the safety of the overall childhood immunization schedule and the use of aluminum adjuvants. Now, what happened in January of this year, and you can see there on the right, the fact sheet that came out of the HHS, the CDC unilaterally, the secretary of HHS, without input from their ACIP, unilaterally decided that the CDC would continue to organize the schedule into 3 distinct categories, removing 6 of the recommended vaccines from the full recommended list there in number 1. So they pulled 6 of the vaccines out from there. And they included them in 2 groups, either in a group where they were recommended only for certain high-risk groups or populations, or made them available based on shared clinical decision-making. I should say that we never got full clarity on what the guidelines for these 2 other categories, category 2 and 3, were. So we never understood how to stratify and who to stratify. And then in addition, it failed to mention that shared clinical decision-making essentially is part of all vaccine recommendations for all children. So no clarity was given as to how to deal with that mandate. Now, the current status, and I'm sure you'll hear more from one of our other panelists, the current status of the ACIP as of last week is that, as you heard, there was a lawsuit by the American Academy of Pediatrics versus HHS Kennedy, and with a preliminary relief. And these were the FAQs here include the fact that the opinion stated several key federal actions, including the January 5th immunization schedule change, the appointments of the 13 ACIP members that were appointed in June, September of 2025 and January 2026, and the rescission of all votes taken by the ACIP since June 2025. As a result of that order, the January 5th schedule change is no longer in effect as well. And because the 13 ACIP appointments have been stayed, the committee as it's currently constituted cannot meet. In addition, because all votes have been stayed, the recommendations for most vaccines effectively revert to the immunization schedule in effect prior to those actions. And I'm sure you'll hear more about this from my colleague. But I just wanted to kind of summarize a few more key points here regarding the elements of why vaccines are important. I know you've heard a lot about this already, but also some of the mis and disinformation. So this is a statement that was put out by the National Academy of Medicine, and I'm a member of this National Elected Academy, because the Centers for Disease Control and the ACIP actually misrepresented and cherry-picked a statement from the National Academy of Medicine that was set up in the early 2000s based on 3 studies that were done by the National Academy of Medicine around the safety of vaccines. And they continued to affirm the safety of vaccines and vaccine schedules, but they did not have substantial data available to actually address some of the questions around safety. And because of that, they said we don't have data to substantially address certain very specific subtopics, but overall we have trust in the vaccines. Well, at the ACIP meeting in 2025, this panel basically misstated what the National Academy of Medicine, saying that the National Academy of Medicine had made a statement that there is no good way to support vaccines because of the risk of autism, and this is actually found not to be true, leading the National Academy of Medicine this year, or late last year, to issue this particular statement saying that based on their body of work on this topic and the overall scientific consensus, they do support the statement that vaccines do not cause autism. And this is a statement that was made in the original reports, but was cherry-picked out of the ACIP declarations around what their view of the National Academy of Medicine had talked about. So again, just one other version of misinformation. I wanted to just highlight two papers I've written. This last year, we've been extremely prolific, and the 17 of us who have been on the committee have been writing a number of papers really critiquing the deliberations of the ACIP to point out how distinct they are from the way the ACIP has worked before. And by the way, I should say that the ACIP has been in effect since the 1960s. So it has been making solid, safe vaccine policy for over 60 years. What this paper was put out by my colleagues and I at Stanford. It was a review of aluminum adjuvants. As you heard, the ACIP was slated to talk about removing aluminum adjuvants, which are critically important to about half of the vaccines that are already on the market. These help boost the immune response to the antigens included in the vaccines. And they were really trying to undermine the claims of safety of these aluminum adjuvants. And if they had advocated for their removal, would have essentially removed half of our current pediatric vaccines from the market. And just as a summary, and there's been a second paper that was written by Paul Offit and others, and Stanley Plotkin after this paper came out. But we wrote that aluminum salts have been used in vaccines for nearly a century across billions of doses with an exceptional safety record. Aluminum is the second most common metal in the earth and is in everything that we eat or drink. They also enable the immune system to generate strong, long-lasting protection against serious infectious diseases. And as I mentioned, many current vaccines would not provide adequate protection if we had to remove them. And we don't have a good alternative at this point. We actually pulled 800 papers from the literature and actually focused on 400 of them that address this issue very well. And we looked at the scientific evidence based on those papers and found no credible link between aluminum adjuvanted vaccines and autism, Alzheimer's disease, allergic disease, or autoimmune disease. And these were diseases that were claimed by the ACIP and their colleagues in the anti-vaccine groups that they thought would be linked to these diseases. And large-scale studies, including a recent analysis of over 1.2 million children, consistently demonstrate safety as well as efficacy. We then wrote another paper looking at the deliberations, and we used an internationally recognized way to assess a number of metrics of the quality of a deliberation of a meeting. And we looked at a number of issues. We looked at whether or not the ACIP relied on prior work so did they use previous data? Did they use metric and outcome driven methods to look at policy questions? Did they rely on a systematic review of the literature or other grade analysis, which is another way to use specific scientifically based outcomes and metrics to assess the data? Did they rely on a full evidence to recommendation analysis? Did they have a shared work group vote? The working groups work in the background. And then finally, did they solicit liaison output? These were the 7 different metrics we used. And based on our assessment of these metrics, we found that from October 2024, when the previous ACIP group met, to December 2025, when the new ACIP group met, we saw a major reduction in the transparency of the meetings, the closed meetings, public comment, the notice and agenda, public meetings, and minutes they did very well there. So they get an A+ for minutes, but the rest of it was very lacking in transparency. This is another paper that we wrote actually in April of last year, where we estimated, this is with colleagues at Stanford and Baylor School of Tropical Medicine, estimated the number of cases and complications in the U.S. of vaccine-preventable diseases under a scenario of declining vaccination for 4 diseases only: measles, rubella, polio, and diphtheria. We modeled this simulation across the 50 states and the District of Columbia, looking at current vaccination coverage rates and current estimates of population immunity, and knowing the infectious disease risk of transmission. The model evaluated scenarios over a 25-year period, and we looked at estimated cases of these 4 diseases and estimated cases of complications. And this is a hard slide to really understand, but basically, if you move to the left of each of these slides, this is a slide of 4 different diseases: measles, rubella, diphtheria, and polio. And as you move to the left, you see on the x-axis less vaccination coverage, And to the right is better vaccination coverage. And the line going, the vertical line really indicates where we are today. And if you look at this, you see that consistently across the board, with lowering vaccination coverage rates, we see more and more cases of disease. And we estimated there would be up to 11 million cases of measles in the US over 25 years, but only 5,800 cases, even with a 5% increase in current coverage. So we could eliminate millions of cases of measles disease if we just improved our vaccination rates by 5%. And we also sadly estimated that measles would reestablish itself as an endemic disease in the United States in the next 25 years, and it might even happen sooner. And then we also, of course, predicted other diseases, almost 10 million cases of rubella and congenital rubella syndrome, 4 million cases of polio, which is on the verge of elimination now globally, and about a little under 200 cases of diphtheria, with substantial thousands of cases of complications from these diseases. So clearly, our data demonstrated that reduction in vaccination leads to more cases. That seems to be an obvious issue, but we needed to quantify that so that people would understand the impact of these diseases without vaccination. So in summary, the value of vaccines are really clinical benefits. And we have to remember, though, that this is an investment and not just a cost, because most public health interventions cost something, but then we get some incremental value. But here, we are not just spending more money, we are actually spending less money than what we get back in the investment in losing deaths and hospitalizations and non-societal costs. There's clearly initial fiscal impacts, and the costs of non-vaccination need to be considered. And we need to include the contrast to antimicrobial resistance that some of these vaccines are actually helping us reduce, because the lack of bacterial infections from the vaccine, from these vaccine preventable diseases actually impact our antimicrobial resistance as well. And so these are all intangible benefits and indirect advantages that we don't always measure with the value of vaccines. In implementation, we always like to think about our guiding principles, which are equity, alignment, cost, capacity, and evidence-based. We want to continue to hope that our federal agencies will continue with these guiding principles. And then finally, in that same paper that we wrote in the New England Journal of Medicine last year, there was a big decision that was made, as you probably heard. The federal government really has upended the U.S. vaccine policymaking process, and that was a year ago. It's gotten worse since then. The ACIP sadly can't be replaced, but it may be possible to limit the damage. In this vacuum, it is urgent that other organizations step forward to reassert an evidence-based expert approach. And what we have seen over the last year is that this has happened. We've seen the American Academy of Pediatrics who's really stepped forward in a very strong and full-throated way. We've seen the Infectious Disease Society of America continue to endorse the previous vaccine policies, and other organizations like the American Medical Association and others. And these societies have a very strong backing in the healthcare workforce. The American Academy of Pediatrics has a membership of 67,000 people. The American College of Obstetrics and Gynecology also large population. The American College of Physicians and the American Academy of Family Physicians have over 185,000 members. And the Infectious Disease Society has about 12,000 members. And CIDRAP is a Center for Infectious Diseases Research and Policy. And these groups have really decided to take on different areas of recommendations for vaccines in different populations. So you can see there AAP is focusing on pediatrics, ACOG on maternal fetal populations, the American College of Physicians and the AAFP on healthy adults, IDSA, the Infectious Disease Society of America on immunocompromised populations, and finally CIDRAP has really been a voice for vaccine data analysis and white papers in these areas. So I'd like to stop there and thank you for your attention.
Thank you so much, Dr. Maldonado. If you don't mind staying with us till the end of the session, we'll turn it back over for questions. All right. And with that, I want to turn it over to Dr. Suh.
All right. While we're working on getting my slides up, I just want to say thank you for the opportunity to speak with you all. I'm coming from Illinois, and we're a neighboring state. We work very closely with the Missouri Health Department, a lot with St. Louis clinicians, because of course our residents, visitors are crossing over the Mississippi to meet with families, to enjoy themselves, to work. And so really, really grateful for the opportunity. So I'm here to give you all a state health department perspective on how we've been navigating all of these changes in federal vaccine policy. I'm hoping to give you some idea of what the real world implications have been for a governmental public health department like ours, and also to public health practitioners out there, and to provide you with some insights on how we approached our decision making and our response to protect vaccine access for our Illinois residents. So a lot has happened. Great. Perfect. So a lot has happened. It's been a year, more than a year. And my goal is to just take you along our journey as a state health department, navigating, starting from the beginning of the measles outbreak and having to respond to that, all of the changes that we've heard about today, and then up until the recent litigation, the AAPV Kennedy case. And what I'd like to describe to you all is how every step of the way our health department responded, because we knew we had to. We learned lessons from COVID-19. Silence wasn't going to work. And so I'll take you through how we made our decisions, how we decided to communicate what we were going to do as a state. Briefly, a little bit about our health department. So again, I'm from Illinois. I'm from our state health department. We have the pleasure of protecting the health and promoting the health of our over 12 million residents. I think one interesting thing to note about Illinois' public health system is that it is a decentralized public health system. So in addition to thinking about the federal public health system and the state public health system, we have 97 certified health departments. And while certainly we provide our overarching public health laws, guidance, each health department has jurisdiction over their particular locality. So they make the decisions on how they're going to implement their public health programs, how they're going to approach immunizations, how they're going to respond to cases of infectious diseases, et cetera. So a really complicated system and network that we're working within. And I think it's really important. We come back a lot to the COVID-19 pandemic. And I like to say I actually came of age during the COVID-19 pandemic as a public health practitioner. I was at the Chicago Department of Public Health during that entire time. And we learned a lot of lessons. In particular, learned a lot about the need for public health preparedness and the need to follow what we prepare for in times of peace that we implement during times of crisis. Public health legal preparedness makes a big difference. And so I'm hoping to share a little bit about why that is so important for a health department like ours. The importance of coordination at all levels of government. And that really requires clear communication, not only between all of the different stakeholders and players, but also with the public and with the community. So we learned a lot, but we also are now dealing with the fallout from a response that could have gone better. And this includes distrust, misinformation, which we've heard about today as well, because either we didn't say anything or we didn't say enough or we didn't explain in a way that made sense to the public as to why we were recommending certain actions take place during the pandemic. And this is all in the setting, too, of known funding cliffs. A lot of resources were put into health departments during the COVID-19 pandemic, and there was no plan for what happens afterwards. And we are continuing to have threats to our funding happen during this time. So lots of stress being put on our already stressed out public health infrastructure and system. And what this is doing is exacerbating weakening vaccine coverage. So we lost momentum during the pandemic. This is showing measles, mumps, rubella vaccination rates. But the thing is, we were already seeing declining rates before the pandemic. But I do want to point out, we are making some strides in certain areas. So In that 2019-2020 school year, that was the school year during which the pandemic started, Illinois had gotten into the green. We had 95% or higher coverage for our kindergartners for measles vaccination. That wasn't the case in the prior year. So we actually had made some progress. The pandemic hit, we lost momentum, and we went backwards. This is not only because of challenges with access, but again, because of loss of trust in our public health recommendations, our public health system. The other thing that I want to point out is, some people are like, you keep talking about the pandemic. We haven't recovered, and we know that a lot happened during the pandemic. We're also very mindful, if you look at the map on the right, 3 out of the 5 states that border us have less than 90% coverage of their kindergartners for measles. We know that diseases do not care about state borders. They don't care about international borders. They don't care about the human body borders. And so we are constantly thinking about the risk to our residents, but also to our neighboring states, because we are one country here. So the weakening measles vaccination coverage has, of course, led to our measles outbreak. And what I want to just point out is last year we had over 2,000 cases of measles in the United States. This isn't like the COVID pandemic where at the beginning we didn't have a vaccine. We've had a vaccine for decades. Already this year, we have surpassed that 50% mark. We're only in the first quarter of the year, and we have surpassed it. We have at least 65% of the cases that we had in 2025. So this is what we were dealing with at the beginning of last year. And we were playing a lot of defense. We were countering medical misinformation that was being said out there, promoting vaccination, making sure people knew that this was a preventable disease, really things that we got used to doing during the COVID pandemic. But the difference here was that this information was coming from the top federal health leader. So this is the pathway that Dr. Maldonado shared with you. And I just want to give you a perspective from how this is so important for a state health department. So in addition to trying to make sure that we did not have a huge outbreak of measles in our state during that springtime, that's when we start planning for the fall-winter respiratory virus vaccination season. So in the spring, we wait for what the FDA advisors are going to say in terms of what kind of flu strains, what COVID strains needs to go in the vaccine. And then in the early summer, that June ACIP meeting, that's when we hear who should get vaccinated, the recommendations of at what time, at what age, at what intervals. And then usually at the end of the summer, early fall, like end of August, early September is when the vaccines would be approved by FDA. The CDC director would sign off, and then we'd be set, we'd go to make sure that people had vaccination before that season of flu, COVID, RSV, those respiratory viruses really kicked up in October. We really, really depend on this too, not just because of the timeline. This is a well-coordinated, or it used to be a well-coordinated dance. We rely on this timeline, but we also depend on this particular pathway for the breadth and the depth of the data that the federal government can get from across all states, the infrastructure to receive that data, and the infrastructure for evaluation that Dr. Maldonado just described. These are things that states cannot do ourselves. We don't have the infrastructure, we don't have the resources, we don't have the access to the data and to the level of expertise that you can get if you bring together experts from across the nation. So we really, really depend on this tried and true process that was established and that was working well. So we're fighting off measles. We're trying to figure out what to do for that spring season. And then we start hearing first that New England Journal article that the FDA leaders wrote saying that they were going to take a different approach to approving COVID-19 vaccines. That was a sounding board article. Those articles are commentary. And then I started getting pings. Oh, there was a video on X. I'm not even on X, but there was a video on X, and they announced that they were changing the CDC the recommendations for COVID-19 vaccination in children and pregnant people. And the first thought was, is this real? Do 3 men on a video, does that count as actual federal policy? Because there was this pathway, but we also had our established lines of communication to the point that was made about notice. We would typically get some notice that this is going to happen through an official communication line, but instead we were hearing about it on social media. And I think what was really concerning to those of us in public health and in medicine was it wasn't simply a matter of broadcasting a different perspective or a belief. It wasn't just a thought exercise or some kind of philosophical debate. These are touching on viruses that, again, they don't discriminate. They don't care what your philosophy is. They don't care where you live. And so it was really concerning to us. Also, because there wasn't a clear rationale for it. There was no explanation and no clear evidence base for what was being said. So when we saw this and then saw that the ACIP was reconstituted, no recommendations came out in June for COVID-19, we knew as a health department that we had to start filling in the gap. Again, because we had learned from the COVID-19 pandemic, we cannot wait, we cannot be silent, we need to act. And we had learned some things along the way. So one unique thing about our state of Illinois is that we have an immunization advisory committee. This is a committee that has existed since 1998. I will just say the 1990s were an incredibly productive time for immunization advocacy and advancements. And I'll speak a little bit more about that in a moment, but created by statute in 1998, they're tasked with providing our IDPH director with recommendations on how to ensure vaccinations get out to our communities, how we increase coverage, and it includes experts from across the board. And what we really did during the summer was we started to fill the various positions. We knew that we wanted certain types of expertise in the committee. And what we did was we convened them and we gave them a very specific charge, which was slightly different from what they had been doing over the past several years, that we really wanted them to review the evidence and to give us guidelines for Illinois, give us recommendations based on your evidence review of what we should do for our Illinois residents. In August is when you began also seeing professional medical societies like the American Academy of Pediatrics come out with their own recommendations. Vaccine Integrity Project, they're out of CIDRAP, which Dr. Maldonado mentioned, started doing an evidence review. So in addition to our state health department, you're seeing all these other entities trying to fill that gap. But what's really important to know is that guidelines are only one piece of what the ACIP has done, not just clinical guidelines. It impacts the recommendations impact so many other areas of vaccination and our vaccine strategy. And the challenge here is that the state only has control over certain aspects. So we can issue our own clinical guidelines. In some way, that was the easiest thing for us to do as a bunch of scientists and physicians and whatnot. We can, change scope of practice, our various mandates. You can have all the clinicians you want out there who are willing to provide vaccinations. You can have all of the clinical guidelines and recommendations out there, but if you can't actually get vaccine supply, or if people can't access those vaccines because their insurance doesn't coverage, it's all for naught. So speaking of insurance, our Department of Insurance regulates some plans, but not all plans, right? So they don't regulate self-insured plans. They don't regulate public plans. We had many conversations with our state Medicaid program. It's a shared state federal program, but even if they wanted to go outside of guidelines, it's not as simple as saying, okay, fine, you can go and do this. They still need to apply for a state plan amendment to the federal government, and money matters. We would need to figure out how to pay for all of these vaccinations. And then the Vaccines for Children program. Let me just speak a little about this because this is such a vital program for us. The Vaccines for Children program, it's a federal program. It ensures that all children have access to vaccines. This was created in 1993 by Congress and they started distributing vaccines in 1994. This was in response to the measles outbreak that occurred between 1989 and 1991. So important. Vaccines for Children, vaccines are given to Medicaid eligible children, underinsured, uninsured children, Alaska Native American Indians. We depend on these vaccines. They're provided to us at no cost from the federal government, and we distribute it to our vaccine providers out there. I think what was really concerning is if you actually listen to some of the ACIP proceedings, there wasn't a clear understanding that the recommendations and their votes mattered because ACIP determines which vaccines are going to be provided through this program. We depend on this program. 50% of children in this country are enrolled in Medicaid, and that's the case for Illinois. We know that in the 2024-2025 years, over 600,000 Illinois children received a vaccine through the VFC program. Now, if we could get everyone access to their healthcare providers, and if we could convince everyone to get their annual flu shot and COVID vaccines, that number would be twice that number. And so if the Vaccines for Children program, so this is the supply end of things, this is something that the state itself cannot easily fill in the gap for. Significant impact if the VFC program is curtailed in any way. And so a lot of implications that come out of the ACIP recommendations. They're not simply suggestions. Some of the votes are written as, oh, these are suggestions in terms of how you should approach the vaccinations. It is far reaching beyond that. So at the end of August, the FDA kept true to its word that it had announced on the New England Journal, and it did limit who they were going to approve the COVID-19 vaccine for in terms of the age groups. And so what states did is they took action because we knew that we had to. And each state did it a little bit differently. So there were executive orders, standing orders, emergency rulemaking, pharmacy board bulletins, insurance bulletins, and even legislation. States also started forming some coalitions, and it was on the West Coast Health Alliance and the Northeast Public Health Collaborative. And what I will note is we tried in the Midwest, but the stars did not align. Political differences did not align, but that doesn't mean that all of our public health programs between our Midwestern states aren't talking. We are talking. We're talking about the best way to approach this in a unified way. So just a little bit of a brain break since it is in the afternoon, but I promise this does have relevance to what I'm talking about. Did you know that Illinois is the top producer of soy in this country? Decatur, Illinois, which has a connection to Professor Sinha, Dr. Sinha, is the proclaimed capital, the soy capital of the world. Apparently, a state can have a state bean, and our state bean in Illinois is soybean. And the reason why we are so productive in this soy space is that we have very fertile soils, flat terrain. I grew up in Northeast Tennessee, very mountainous, and I will say that in inclement weather, I would much rather drive through the flat terrain of Illinois than have to drive through the curves of the mountain of Appalachia. So the legal terrain matters. And so I want to just tell you a little bit about how Illinois approached responding to all of these changes and why the legal and, of course, the political terrain mattered too. So what we did at the beginning of September is our governor issued an executive order. This called for an all-of-government vaccine access initiative that was led by our health department. But what it really did was it mobilized state agencies to work together to ensure that there was vaccine access for our Illinois residents. This is something that public health cannot do alone. We learned that during the COVID pandemic really, really well. It also charged our health department to issue a standing order. And a couple of things about this. It gave us time. It gave us within 15 days. That was intentional because the timing of this, that 15 days would be after the September ACIP meeting. And while some states went ahead and said that they were going to endorse medical professional societies, we really wanted to take into account all of the voices and the data out there and make our own decisions. So not just the professional medical societies, not just our own data. We wanted to see, again, because the ACIP meetings have incredible data that a state alone cannot get, we wanted to take everything into account. Also, because we learned it's really challenging if each state, each locality has a different guideline because our states do not have walls between our borders. Also called for contingency planning. And I will say we actually started contingency planning in November 2024 when we got the results of the presidential election and announcement of who the president was likely going to nominate for HHS director. So for secretary of HHS. So contingency planning if vaccine supply was lost. And then also insurance coverage, called on our Department of Insurance to do whatever they could to make sure that insurance access remained for our Illinois residents. So standing order, why the legal terrain matters. This was fairly straightforward for us because IDPH already had the authority to order the administration of vaccines as necessary. Fun fact, this was enacted in 2004, and then Illinois State Senator Barack Obama was a sponsor of the bill, but we didn't have to think about, can we do this? We knew that we could. And in terms of the global public health context, this was right after that SARS outbreak happened. And so talking about public health preparedness, public health legal preparedness, very, very important that all of this is set up and ideally in times of peace. Our pharmacists actually had pretty good authority in terms of their scope of practice. So they could already vaccinate individuals 7 years and older with a prescription or a standing order. And there were no specifications in terms of must follow FDA labeling. It didn't say that they were required to follow ACIP recommendations. And then beyond PrEP Act authorities for COVID and flu vaccinations, our pharmacists could also independently order and administer vaccines to individuals 7 years and older. But this is where actually there was written into that law that they had to follow ACIP recommendations. The irony is, what I have heard is that medical societies were worried that perhaps pharmacists would not follow evidence-based guidelines. So that's why that was written into the law. A couple of other things. So a couple of states did declare an emergency, disaster emergency proclamations, New York and Hawaii. That is something that we considered because yes, it's a disaster. What is happening? But we were also really worried because at that time, CDC had predicted that the COVID-19 season could be the same as the prior year or potentially worse, depending on whether there was decreased vaccination. We did not do that ultimately. And here is why. We felt that we already had the tools that we needed at our disposal to preserve and strengthen access. Like I just said, we had a lot of laws in place that allowed us to do the things that we needed to do. We were also mindful that we needed to appropriately tailor our response. And so this was taking into account some of our lessons learned during the COVID-19 pandemic, but we knew that we had that tool if we needed to. If we needed to expedite procurement of vaccines or other things, we knew that we could do that. And we were planning to revisit it. We were planning for it if anything was jeopardizing our vaccine access, whether it was a surge of COVID-19 cases or if the ACIP decided to remove some vaccines from the Vaccines for Children program. So the ACIP met, they provided their recommendations for COVID-19. We convened our immunization advisory committee and we put our recommendations. Essentially, we aligned with what the professional medical societies had already said, but what we really wanted to highlight and make sure was apparent was that we were following a process, a transparent process of evidence review, taking into account all of the evidence and the opinions out there. So we put out our guidance. We also did our standing order. And for the standing order, there were a couple of reasons for it. It was not simply to make sure people could vaccinate, because many people already had the authority to vaccinate. We were trying to provide clarity and guidance. A lot of confusion had already occurred. And so this was providing clarity, also confidence to physicians, to vaccine providers, to pharmacists, that this is something that they can and that they should do. We also knew, again, going back to the fact that we are a decentralized public health system in Illinois, each local health department gets to decide on what they're going to do with their immunization programs. We knew that there were some local health departments who had some trouble getting standing orders or they weren't sure about liability and whatnot. So this was another way to ensure that people could get their vaccines, because local health departments in Illinois and other states are a vital safety net for individuals who can't get vaccinated elsewhere. We also, with these recommendations, actually put out another recommendation. And that was another guideline. We made it clear that in terms of the routine childhood immunization and the routine adult immunization schedules, that we were endorsing the prior CDC recommendations. So none of the recent changes with the combined MMR varicella vaccine. And we also incorporated the prior ACIP's April recommendation. So the ACIP that Dr. Maldonado was on. We wanted to say this up front because we didn't want to leave it silent. We didn't want to leave it up to interpretation. Our Department of Insurance also followed the directive that they received. They did emergency rulemaking to require insurance coverage of IDPH, so Illinois Department of Public Health recommended immunizations. But like I said, this is only for state regulated plans. Our governor, so I mentioned that we were not able to create something equivalent to like the West Coast Health Alliance in the Midwest, but our governor did join the Governor's Public Health Alliance. So this is an alliance of 15 governors, and it includes also the governor of Guam. And I think this was really important. It's not just a declaration of support from the top, which is so important, but a governor's support is critical in our space. It's not only can they mobilize state resources, but they can really work together with other governors to do those interstate collaborations. So the purpose of this is to share resources, strategies, ideas, on regulatory and logistical issues, on supply, to share data, and really to try to create an infrastructure to fill in that gap of the federal infrastructure that we're losing. And so you can see it's not supposed to be partisan. We're kind of lonely there in the middle, but other governors are certainly welcome to join. And it has been helpful when we have seen that, okay, we're going to bring everyone together, and here is our interpretation of what's happening. Here's our interpretation of what's going on, and kind of some recommendations on how to move forward. The other thing that we did is I said that we started preparing in November 2024. We did a review of all of our laws to see where there may be weak points if there were changes in the federal vaccine policy. And so we have a veto session in Illinois. And so in the fall session, with the governor's office support and others, we were able to introduce a bill to essentially codify what the executive order had required. This was signed into law in December. And what it does is it authorizes our IDPH director to formally issue statewide immunization guidance. Just very clearly states it out there. It codifies the structure of our immunization advisory committee, including checks and balances. And this is an interesting thing. So our IDPH director is an appointee appointed by the governor, and we know that times can change. And so our immunization advisory committee, if they feel that our director or our department has not properly taken into consideration their recommendations for immunizations, they can actually veto and override it themselves, and then their recommendation becomes our state guidelines for immunizations. So really trying to solidify an evidence-based process here. Our state-regulated insurance plan mandate to cover immunizations recommended by IDPH was written into statute. And we also broadened the scope of our pharmacists so that they could independently order and administer COVID and flu vaccines to individuals 3 years and older, because they had gotten practice doing that with the PrEP Act during the pandemic. And I want to point out here, we left in the ACIP recommendations. We made it an or state guidelines because, again, the ACIP and their role, it worked well, and we depend on that level of expertise. So perhaps this is our way of saying we are hopeful that we're able to get back to the way things were, and that we really do depend on the federal government. We can't do this alone as states. So communications, though, it's still the challenge. It's always been the challenge. But I will say with all of these things that we put into place, all of the new stuff that started coming out, the hepatitis B recommendation changes, the changes to the childhood schedule, in some ways it felt easy because all we had to say was no changes. There have been no changes. Everything is the same as before. Keep doing it because there have been no changes in the evidence. So there's no change in our guidance or our recommendations. Communications is, and it's always going to be the heavy lift. But because we have these strong legal tools, the strong legal landscape to work within, public health practitioners like myself, our clinicians, we can go out and do what we need to do to work on getting information to our communities, to getting access to our communities and implementing our public health strategies. So we endorsed the AAP schedule, and it was in part because of the acknowledgement that communications is key. So we convened our immunization advisory committee, and they, of course, reviewed everything. And at the end of the day, our guidelines had always aligned with the AAPs. But this was really, really important because the AAP has an established process by which it reviews vaccines. Their guidelines align with us, and we really did feel that it was better to have unified guidance because it can be confusing. It's confusing for clinicians. It's confusing for parents and families out there. In fact, that's something that the AAP worked together with the CDC on in the 1990s. 1995, they came together and brought together a unified schedule because it shouldn't matter where you live. The immunization recommendations are the same. So we endorsed the AAP schedule, And why this is also important is because we know that we've lost trust. As governmental public health, we have lost trust from our communities. Healthcare partners are so important. We need to regain that trust. But we also know that we're not obsolete. So while we know that we have to use the voice and the expertise of our healthcare partners, we know that we still need to work towards ensuring that infrastructure is there and all the support is there so that not only our clinicians can vaccinate, but our communities can really access the important things that they need. And so I'll just end with this. This is the seal of our great state of Illinois, state sovereignty, national union. That is our state motto. And I think this really brings out all of the tensions and the ideals of federalism. This really needs to be a both and situation. We are glad that we had the tools we needed as a state to provide evidence-based guidelines that are different from what came out from the federal government. But like I've been saying, we can't do this alone. It shouldn't matter. Again, I think that's what really breaks the heart of many public health practitioners, physicians. I think any human being, citizen of this country. It shouldn't matter if I live in Illinois, if I live in another state, Tennessee, for example, where I grew up. We're traveling all around. We're together. Diseases don't care about state borders. They don't care, like I said, about body borders. And so really, to come back to have a unified strategy to improve and protect the health of our children is so important. And with that, I am pleased to hand it over to my colleague, Mr. Hughes.
Thanks for having me. This is the first time in a long time that I've been in a room with Dorit where we haven't been co-panelists. And I think usually that's because she keeps me on track. And last year we were on so many panels together that I have this AI image that I should have brought to put up there of our national tour bus, our vaccine law tour. It's really great. So obviously I want to talk a little bit about our suit, but I should, be upfront that I'm not a litigator. I did not go to law school to be a litigator or to set foot in a courtroom. I've worked in the vaccine space for about 20 years. I started my career as a very young member of the Arkansas State Board of Health, where I was a proponent of the HPV vaccine, which got me kicked out of the state and led me on a path to DC. But I've focused on coverage and access issues, and I went back to law school to learn from Sarah Rosenbaum how to weave public health into insurance law and to assure coverage and access. And so when Robert F. Kennedy Jr. came into his office, I knew that my career was about to make an abrupt shift. So it's, not where I really want to be, but it's where I find myself. And just to go back, the Advisory Committee on Immunization Practices, and thank you, Dr. Maldonado, for providing such a thorough overview of the committee and its work, was established in 1964 under Section 222, essentially under Section 222 of the Public Health Service Act. It was established by the Surgeon General, but 222 gives the Secretary the authority to establish advisory councils and committees. And so ACIP is not a mandatory committee, but a lot of history and law has been built up around it. So there are 13 federal statutes that reference ACIP. There are 17 rules and regulations that reference ACIP at the federal level, not to mention the over 600 approximately laws at the state level, which are changing in real time, of course, that reference ACIP. The ACIP, as Dr. Maldonado so well described, goes through a rigorous process of using the GRADE criteria to look at the quality of the evidence that it relies upon, an evidence to recommendation framework across several domains to ensure that it's considering the right evidence before it makes a recommendation. And so Congress has entrusted ACIP in a variety of ways. As I mentioned, 13 different federal statutes. But this really creative approach that came about really through the Vaccines for Children program and then culminated with the ACA of dynamic incorporation, of embedding evidence-based recommendations into the law. It's a really unique form of delegation, and it's a little fraught, which I'll talk about. But it's really ideal, right, to have the law reflect evolving evidence-based standards so that we can keep up with that in real time. I ask my students all the time, I'm like, do you want Mitch McConnell deciding the reproductive care to which you have access? I don't think so. I don't think Congress is really equipped to make these decisions and do it quickly enough or to lend the adequate expertise. So we do have, under the Vaccines for Children program, this specific role contemplated for the ACIP, as Dr. Maldonado said. It determines the list of vaccines that will go into the program. And then, of course, with the Affordable Care Act and its preventive services coverage requirement, recommendations of the ACIP along with the U.S. Preventive Services Task Force, HRSA's women's and children's preventive guidelines, all must be covered. So I want to go back for a second to the challenge in Braidwood, because I think it's very relevant for those of you who followed as we think about AAP versus Kennedy and the role of these bodies. So this was a case, for those maybe who weren't following, of religious objectors, employers who did not want to purchase health insurance coverage for their employees, that included interventions that they disagreed with because they believed that things like the hepatitis B vaccine, the HPV vaccine, PrEP for HIV screenings for drug use or sexually transmitted infections, they believe all of that facilitated sexual activity outside of a marriage between one man and one woman. So in addition to a RFRA claim, they brought an appointments clause claim, essentially saying that these bodies wield too much authority. And when you think about it, they do wield a lot of authority. Under the ACA, we have given them the responsibility of making recommendations that are then interpreted into insurance coverage. As I said, that's pretty ideal. But this was challenged, and it did go, found its way to the Supreme Court. The lower court said that ACIP is okay. They have the director sign off before their recommendations go into effect. HRSA is okay. They're an agency. There's political accountability up the chain. But the U.S. Preventive Services Task Force, that is not, because they're so independent and they're insulated, that doesn't really cut it. And so this went all the way up to the court, and the decision came down last June. And essentially, the task force was saved, and it was really saved because the Supreme Court adopted the rationale that if the secretary has the ability, they said the secretary does have the ability to basically accept or reject its recommendations. And because of that, it survives. Now, what is really strange is the timing of this. I represented about 24 HIV/AIDS groups in an amicus brief where we supported the government's position that the secretary has this authority. By the way, they maintained the same position in the case that the Biden administration was going to take when the administration changed. And it was a really, really strange time that spring, because we're watching the secretary come into office, and I'll talk about some of the things that he did, but telling the Supreme Court, we actually want him to have this authority because we want to preserve and uphold this framework for preventive services coverage. It's a really odd place, very uncomfortable place to be. It's a very double-edged sword. So I'll come back to Braidwood again in a minute. As we know, after the election, we anticipated that Robert F. Kennedy Jr. would be the nominee to be HHS secretary. I started right away making a list of things that I expected that he would do, the authorities, the powers that he has, and how he would wield them, and I was told that I was crazy. I was in rooms giving presentations, listing these things out, being told that I was giving a playbook and needed to shut up, and people would get up and walk out. I was right. I'm sorry. And, they don't need a playbook. They know exactly what they're doing. And I think, we're not necessarily on our A game as a vaccines advocacy community when the secretary came into office. And so I immediately realized we would need the courts, that we would need to rely on the courts to check the secretary, because he has a lot of authority, but it's how he wields it that matters. The Administrative Procedure Act exists for a reason, and it's our last hope to keep the secretary in line. And so my team started really watching very carefully everything that the secretary did, the administration did and said about vaccines. I said, everything the secretary does is going to be arbitrary and capricious. So we're covered on that one, right? You look up those terms in the dictionary and his face is beside it. So he'll do those things. But what we've got to look for is the final agency action, right? So we can actually bring that claim. And so we started to watch. And we watched as, he said to Senator Cassidy to get his confirmation that he would maintain the ACIP without changes. We knew that that was a lie. And immediately the ACIP meeting was postponed. And then we started to see, that they actually did end up having their meeting, and it looked like a hostage situation. If you watched on video, the former members, including Dr. Maldonado, were in the room with the usual CDC staff, but there were other folks in the room. And it felt like they were hostages. I mean, the look of nervousness and anxiety on their faces was really hard to watch. And it's, this is the last time this committee is going to meet. There's no way that they're going to let this committee stay in place. And sure enough, that became true. But, we started to hear rumblings that they were going to change the COVID recommendations. And then we saw the rejection of Novavax's biological licensure application. And then Novavax had to negotiate to do post-approval placebo-controlled trials. And then Vinay Prasad and Marty Makary at the FDA come out with a framework for evaluating COVID vaccines that they published in the New England Journal of Medicine. So that's how we're announcing policy now. And, then we saw the 58-second video. So for those of you who haven't watched that video lately, this was, Secretary Kennedy flanked by Jay Bhattacharya, the NIH director, and Marty Makary, the FDA commissioner. And he said, "We are pleased to tell you that healthy adults and children no longer need to get the COVID vaccine," and said that the prior recommendations were based on no evidence. And I said, "There's our final agency action." So we started to, prepare. We were looking at, the harms and trying to evaluate whether, those harms were actually occurring and what standing would look like, how we would frame up the final agency action, the arbitrary and capricious nature of it. And then we saw the firing of all of the ACIP members, and we saw the reconstitution of the committee with the members that Dr. Maldonado described, folks that are not qualified to be making recommendations about vaccine policy. My favorite is Retsef Levi, who's an operations management professor from MIT, who does this like N of 6 study thing. He has 6 children, and he likes to share his little study outcomes on the committee. He has no scientific background. He started talking at his first meeting about how he had reviewed the clinical data. Well, I'm sorry, I'm not really interested in what I took an operations management class in college. I'm not really interested in what that professor has to say about clinical data. I don't think that's who I want making these kinds of decisions. And so it became a platform for misinformation and disinformation right away. Just these sort of like impromptu presentations out of nowhere. It was like they would go to lunch and come back and have some slides prepared, and they were having all these like side conversations and, taking up long debunked safety theories and, safety data that had been reviewed 13 years earlier on the MMRV vaccine by the ACIP. And, of course, changing the recommendations, and Dr. Maldonado described a lot of those changes, so I won't go through all of them, but based on little evidence. And so on July 7th, I was very grateful that Dr. Georges Benjamin with the American Public Health Association was the first to say, "We're in. Let's do this. Let's sue," and talk to the board of the American Academy of Pediatrics. And I know that was not a very easy decision for that organization to make. I don't think it was easy for any of the professional societies that we represent to step up. If you look at what they're dealing with right now, and just the constant steady stream of attacks and accusations. And, I was concerned about how this lawsuit would impact them. But I really felt like, and I said to them, if we don't do this, we're going to look back in 10 or 15 years and say we could have done something to stop him. And this isn't just about COVID recommendations. This isn't just about that 58-second video. It is about the fact that he's on a path to destroying vaccine policy, and he's not done. And I often use the analogy of the frog in the pot of water that you just slowly turn up the heat until it's boiling. They're shifting the Overton window and conditioning the public to think that all of this is normal. And if we don't stop it, he won't stop. And so on July 7th, we sued him in the District Court of Massachusetts. And we have amended our complaint 4 times. We've had a team of 45 attorneys and public health professionals on this. We have interviewed hundreds of potential plaintiffs and declarants, and have just been so grateful to all of the folks in the vaccine stakeholder community that have stepped up, former ACIP members, former CDC staff who have really guided us and helped us really lay out all of the processes and procedures and rigor by which this committee had been vetted and nominated, and all of their processes that they go through in making decisions. So when it comes to the claim of arbitrary and capriciousness, I think that we could not have done a more thorough job. And I'm so appreciative of the litigation team that I have, because I could have never done this. I'm not qualified to do it. I'm a vaccine lawyer, but thankfully we've been able to combine that expertise that we have, and have a wonderful litigation partner who's able to really stand up in court and make a convincing case, and we've done that. So we went in to court in August in front of Judge William Young, who has been on the bench for 40 years. He's 85 years old, and he's a very fiery judge. He's written some really great opinions lately. And we were in front of him, and he said he wanted to move the case forward expeditiously. And shortly after that, the government shut down, and the DOJ stopped compiling the administrative record, and we were effectively stalled. When we continued to see what they were doing on the committee, I said, we've got to go in and get this stay lifted so that we can proceed during the shutdown. And so we made the decision to go back and ask the judge to lift the stay. In the meantime, Judge Young's wife sadly passed away. The case was reassigned to Judge Brian Murphy, who's a Biden appointee, about a year at the time on the bench. And so we went in front of Judge Murphy in October and asked him to lift the stay. And he said, this is a case of national import. I'm going to lift the stay. And then the shutdown ended. So we... at that point, still don't have the administrative record. The government is still dragging its feet, and they had filed a motion to dismiss on standing. And so in December, we were in front of Judge Murphy again for the motion to dismiss hearing, and waiting through the break to see what happened. Meanwhile, the ACIP downgraded the hepatitis B birth dose recommendation. And then we started to hear, President Trump says he wants to look at peer nations and the Danish schedule. And so we're just waiting to see what they were going to do with the schedule, because we knew that we were likely going to need to amend, but we're waiting on the outcome on summary judgment. I tried to take a motion to dismiss. I tried to take a weekend away in Mexico. And it was like a Friday, Saturday, Sunday, Monday, Tuesday kind of thing, coming back on Tuesday. And my team was, he's going to run, your vacation is going to be ruined. And sure enough, on Monday, they changed the schedule. They released this new schedule. And then on Tuesday, we got the good news on our motion to dismiss. So vacation was over. So we were really happy with the news on Tuesday, but we said, we're going to do something about Monday. We're going to amend our complaint. And so we did. We filed the Fourth Amendment complaint, and we asked the judge for a preliminary injunction. We asked him to enjoin the committee from meeting again. We asked him to enjoin implementation of all of the votes, the January 5th schedule, everything. And the judge bifurcated the hearings. So on January 13th, we were in front of the judge, and then on March 4th. It's supposed to be on separate issues, but really March 4th kind of became where we're sort of tying the bow on everything. And, if you really just want to be pissed off, listen to your U.S. government in a court of law say that we're all here to promote public health. We just have differences of opinion and how to do that. And by the way, all of this is committed to agency discretion. The secretary has unbridled authority to decide these things. And the judge says, well, what if the secretary wanted to say, oh, kids, just don't get vaccinated. Just go have measles lunches. Let's just have a bunch of kids sit down, some who have measles and some we're just going to expose to measles. Is that okay? And to say that there's no binding, guiding law to guide the secretary, which they've argued, they start citing the isolation and quarantine statute, the provision that says that the federal government, the secretary is supposed to cooperate with the states on the control of infectious diseases. What is that? That's not the only statute to guide what the secretary is supposed to do here. It's this big ambiguous federal state, cooperation because, right, we're trying to acknowledge these concurrent roles that the federal government and the state governments have in public health. That's all that statute's about. Again, 13 binding statutes where Congress has referenced ACIP and contemplates its role. And I was so glad when the judge spoke up in the middle of the government's argument and said, what about these other statutes? What about this evidence to recommendation framework? Mike, he gets it. This judge understands the complexities of a very, very, very complex set of issues. And so it was then that I felt really confident about the outcome. And we waited very anxiously. And last Monday, we got the order staying the committee appointments for 13 of the members, the ones that were appointed last year that were in the scope of our complaint. He stayed the votes of that committee. And he said, he also stayed the January 5th schedule changes. He said, I don't need to stay the committee's ability to meet, for how could a committee without its members meet? And so, I said, there's a really great, if you've ever been to the CDC, there's a really great little sandwich shop around the corner. They could meet there and talk about vaccines if they want, but it's not going to be an ACIP meeting. And so have at it. We saw that Robert Malone, the vice chair of ACIP, has made a lot of noise and has stepped down. We're now seeing that, and the reason why I wasn't able to get over here earlier for some of the talks, Aaron Seary has now the lawyer that's affiliated with Robert F. Kennedy Jr. and they've coordinated efforts for a long time before Kennedy came into office, and while he's been in office, has petitioned to have the charter rewritten, the ACIP's charter rewritten, so that they can appoint the membership that they want. And so, in terms of what's next, we'll be watching that and prepared to act as soon as these actions occur and we have a final agency action. With respect to an appeal, we were really pleased that the judge ordered a stay and not an injunction. It is interlocutory in nature. They had until last Thursday to certify a question of law and to appeal. According to the spokesperson at HHS, they're not done with this. They're going to appeal and they have 60 days. So, we take the position that it is not an appealable order and that they can't appeal. We are at a point, not because of our lawsuit, but because of Robert F. Kennedy Jr., that we have no functioning ACIP. And we are going to encounter a situation where, at least going into June, we normally make decisions about flu vaccines and RSV vaccines and COVID vaccines, and we're going to start to see a pileup. We don't have a functional policymaking apparatus in this space anymore. And so we're going to do everything that we can to expedite the case, and we'll likely end up filing cross motions for summary judgment. And I think that symbolically, this case is really playing out to be what we hoped, which is to put a stop to the Secretary's assault on vaccine policy. We've seen that it's had a chilling effect. If you've seen some of the reporting of the last couple of days, the administration is politically concerned and ahead of the midterms. And we see a little bit of a slowing down, but we're not done. We're in active litigation and we have to see this through. And I worry that if we get complacent and let up, as I think sometimes some of us in public health can be prone to do, we will walk away not getting everything that we need. And so we're going to persist with this effort. And I'll say that there's this really, just to think about the future of first with administrative law and the powers of the secretary and within the executive branch, there's this really interesting tension building, right? Where Braidwood says the secretary a political actor, the secretary has to have the ability to have the final say so on these recommendations. You have our judge ruling that the secretary has to have consulted ACIP. And so, wow, we're really getting to this point, and I hope that becomes the law of the land, And maybe it all will hang together under a normal good faith actor secretary where, you know, we really protect the evidence-based processes while letting the political actors sign off. Not ideal, but it's where we are. I think that we have a lot to think about on a go-forward basis. If we can't get the ACIP back in order soon, or if the secretary stays in office past the midterms, and even if we slowed him down, we continue to wrestle with some of these issues. The professional societies, as Dr. Maldonado described, have really stepped up. And we know that under principles of malpractice law, because there have been these liability threats hanging out there, under principles of malpractice law, set aside the Vaccine Injury Compensation Program and the PrEP Act, under principles of malpractice law, professional society guidelines control, right? And so we should be reinforcing the role of the professional societies and standing up for that. I think that we have to think about, you know, how we rewrite some of these laws and the rewiring of things like this ACA framework, right? Where you have over 150 million people. I mean, now it's even more, where we have through Medicaid, through commercial health insurance, we rely on the ACIP, and under Medicare, rely on the ACIP. Do we need to think about something a little bit of a different kind of dynamic incorporation, a different kind of delegation? I don't think that we can necessarily farm it out to the professional societies. I don't know that Congress would get away with delegating that far. But, you know, one thing that I've sort of thought about is, you know, could we see standards that just hang on the provider's recommendation to the patient? You know, if a provider is following professional society guidelines, could we require coverage without cost sharing for those preventive services? It's just a thought. But we are going to have to think about how we move forward and maybe how some of these laws are rewritten as a result of all this. But, you know, I have a lot of hope that through our efforts, we will start to help correct course, and that we'll come out of this. I remind folks that, you know, we've been here before. There was a time in the 19th century where all of the states repealed their medical practice acts, right? And then they put them all back because they realized that for health and safety, we needed to regulate the practice of medicine. And so I think that there is hope. I think these things ebb and flow. And I think we'll come back to a place where we reestablish some of the norms, but we've got to also be innovative and think about how we want to, you know, how we want the system of the future to look. So thank you.
All right, we have a few minutes for questions here. And I'm going to have you guys just stand by and then I can pass you the mic. All right, we have any questions in the audience? Oh.
This question is for Dr. Shao. I know, given that you're from Illinois and what the politics in Illinois seem to be generally about, and you talked at the beginning of your talk about the fact that, you know, you have to cooperate with neighboring states. I do a lot of work with one of the local children's hospitals here in St. Louis, and I know we're constantly having those sorts of issues arise because we have so many patients from across the river. But what has been your experience with other bordering states that, shall we say, are somewhat red or very red in terms of the kind of cooperation that you're experiencing within Illinois in the political and administrative forces in Illinois, as opposed to, let's say, Indiana or Missouri or other bordering states?
That's a great question. I think one thing to keep in mind about Illinois is that kind of that Chicagoland area is a certain way. Our governor is, of course, a Democrat, but the rest of our state is very much like bordering states. I have gotten to know our state very well, having moved to the state health department, and the southern part of the state is more like where I grew up in Tennessee. And so I think, and the other thing to note is that public health is a very collaborative field, and we have been in conversations with the immunizations directors of each of the various states. And so we're all talking because we know what the data shows and what the science shows. And so it has been a very collaborative process, even if up front, in terms of big announcements of collaborations, that hasn't happened. The other thing that we know is that there are children, just like children from Illinois may come over to Missouri, children from Missouri, Indiana, Kentucky come into our state to get their medical care. And I think the good thing is, in terms of vaccines for children, as long as they are eligible, generally, our state providers will provide those vaccines. They might not get reimbursed depending on, like a few dollars that they may get from the state Medicaid programs, but they will give those vaccines. So I think clinicians, medical folks, public health, we're all working, I think, under the same system and understanding. And so it has been collaborative. And I think, as was mentioned before, the vast majority of folks out there want to get vaccinated. They think that mandates are an important thing. And we're certainly seeing that in our communities too. I think we maybe need to uplift that a little bit more. Just highlight, yes, people still believe in vaccinations. Public health is still working together despite everything that's going on publicly.
All right, thank you. I saw another question down here too. Oh, Rachel.
Thank you. This question is for Mr. Hughes. Thank you for your time. Just curious, why did you file in Massachusetts? What was that choice for? And how do you see, if your suit is successful, impacting other committees or other FACA committees in the government? Will they have to change based on your suit if it's fully successful? Thank you.
Yeah, thank you. It's, other than being a favorable venue, which we think it is, my team doesn't care as much as I do about this. I just think symbolically, it's the heart of vaccination in this country, vaccine law, right? So that was really special to me. But it's a favorable district, there's subject matter jurisdiction, and the First Circuit is favorable. So it felt like an obvious choice. We did look at a couple of other venues, but felt that that was the best. I think that, with respect to other committees, what's interesting is the U.S. Preventive Services Task Force is not a FACA committee. And the way that Congress has referred to it is it's a little different. It is a mandatory committee. It has to exist. So he can't get rid of it, but he could change its entire membership. And the Supreme Court was very clear about that in the Braidwood ruling. So he could just remove it. They actually said they adopted the government's rationale or reasoning that he could just remove members until he got the policy results that he wants. Oof. So, I think to the extent, though, that this is a case about following process and procedure and having rigorous evaluation of the evidence, hard look, reasoned decision making, explaining the decision, I think that is all very applicable to other committees.
Thanks. Also for Richard, two quick questions, hopefully. One, I wonder if you could comment all about the the sort of parallel AG case, the Arizona case, and where you think that's going. And then the second thought is, do you think you talked a little bit obviously about your legal strategy, but I always tend to think of law and politics as intersecting. And what role do you think these cases, both your case, maybe also the AG's case, may play in sort of the political pushback against what RFK has wrought?
Yeah. Thank you for that. So, I think with respect to, sorry, what was the first question? I got so focused on your second one. I'm sorry.
No, I was asking if you could just talk a little bit about your thoughts about the Attorney General's claim about what's happened at ACI.
Yes. Sorry. I did not. I was on the tarmac for hours last night and hardly slept. I'm sorry. Rough ride. Obviously they filed a little ways behind us and we'll help them. We want to help them. We hope that our case is very helpful to them. We hope that all of the declarations that we filed are helpful to them. And to the extent that we get favorable rulings in two different circuits, that's great. Obviously their harms are different. There's questions around standing will be different. I, of course, think they have it. But we're a little further ahead, and but I don't think it's a necessarily bad thing to have both of these cases out there. I'll say with respect to the political piece, I think it is already showing to have a chilling effect. There was an Atlantic article on I think it was Wednesday night, and a Times article yesterday that among the things that are starting to the administration is getting frustrated with Kennedy, and this focus on vaccines is kind of getting old for the administration, but they're also mentioning the lawsuit, right? And so I think it is working its effect. And I will say, I have learned so much about not just about litigating, but working with the media. I can't tell you, I've probably done 400 interviews in the last since November of 2024, and just have learned so much about the role that reporters play and how litigation in tandem with reporting works, and just how effective it can be when you coordinate with the media. And it's just so powerful. We have so many really wonderful journalists out there. I just have so much new respect. I always love journalists, but just so much new respect for what they do and how they want to get to the truth, and just the amount of time that we've spent. They're so interested in the law and just understanding it so deeply. So yeah, I think I see it as a part of a much bigger strategy.
All right, we maybe have time for one more question, and that is it. Well, I'll make it mine then. I'm going to ask my always in my pocket question, which is the magic wand question. And you can have more than one thing, but let's just limit it to one thing. Magic wand, some form of reason prevails again in the political sphere. What would you, if there's a thing you would change about current law or policy to maybe prevent some of these things from going forward? I'm going to turn it over to whoever wants to step up and take it.
Dr. Maldonado.
Okay, all right. Dr. Maldonado, you have been voted on the island, off the islander.
Well, I'm not a lawyer, but I would just say, I know this isn't a policy thing, but I think the secretary needs to resign. That is, I happen to be a colleague of Jay Bhattacharya. He's a Stanford faculty member who's the head of the NIH. And I have to say that I don't agree with a lot of what he said, but he is trying to make NIH at least work in some kind of a structure. And he's at least laid out some metrics. We may not agree with what those are, but we don't always agree with every administration. But I don't think that the secretary of HHS has a viable public health policy. And he's really, whether he means to or not, he's destroying public health in this country. And I would love to see him step down.
Thank you. Either one of you want to take a crack at this?
Sort of, I don't know, maybe it's not directly on point, but just sort of broadly, that my dream would be that we rewrite insurance law and we rewrite public health law, and we provide even coverage of preventive services across all markets. Why do we have such fragmentation across all of these? We have such a fragmented healthcare system, and it's the same thing for preventive care. Could be fixed. It'd be complicated legislatively, but it could be fixed. And then I think the public health enterprise needs to be reimagined after this. We have to rethink the public health enterprise and rewrite the laws just like we did in 1944. And I think that we have to find I'm going to say a middle ground, and I just want to be clear about what I mean by that, because I don't think it is in any way conceding to Robert F. Kennedy Jr. and Maha. But if we just dig in on the status quo, I don't think that's ideal. What he's doing is destructive. So what's the middle ground that is disruptive and restorative, right? Do we want the ACIP to go back to what it was? Do we want it to look a little different? Do we want its role to look a little different? That's just one example. I think that we could apply that same thing to the CDC. There's an appetite for reform among really reasonable people in this country, right? There are people that actually want to see that reform. And we could accomplish that reform. We didn't have a postmortem, a meaningful postmortem. We had no postmortem after the pandemic. We've got to have a postmortem after this.
Well, I was also going to say insurance and healthcare access, because very specifically, it's really hard. Like, we know many people will get their vaccines at pharmacies, the respiratory virus ones. But many, for example, in our state, Medicaid children cannot go to a pharmacy because of the way the system is structured. And we know that that is a challenge across the nation. Perhaps then I will add that I would really hope that all of the support, funding, and whatnot for the public health infrastructure, that is built up to, because we got so much support during the COVID pandemic and we needed it, but it really allowed us, I was at the Chicago Department of Public Health then, but really allowed us to innovate and to kind of get with the times that other more private entities can do. That includes data infrastructure as well, to be able to be more nimble and to really be able to react in real time. Yeah.
Thank you all so very much. Thank you
for staying with us here. I'm happy I moderate our third and last panel, which is about the path forward. And our last panel consists of three wonderful speakers. Our first speaker is Renee Nazira, who is infectious disease and social epidemiologist and serves as a director of public health and history of vaccines at the College of Physicians of Philadelphia, where he holds a Susan and Stanley Plotkin Chair in Public Health. He also teaches epidemiology and public health at George Mason University and Johns Hopkins University. Our second speaker is Montrese Ransom. Montrese Ransom leads the National Coordinating Center for Public Health Training at the National Network of Public Health Institutes, directing nationwide efforts to strengthen and sustain the public health workforce through training, technical assistance, and capacity building initiatives. She oversees cross-sector collaboration, supports training centers across the United States, and provides strategic guidance on public health workforce development. And our third speaker is Brian Dean Abramson, who is a leading expert in vaccine law and the founding chair of the National Vaccine Law Conference. He's also the primary author of Vaccination and Immunization Law, the most comprehensive treatise with respect to immunization law. So Brian is going to be our first speaker, and he's going to present via Zoom. I look forward to your presentation.
Thank you very much. I have gone ahead and shared my screen as I have a slide presentation for this occasion. The state of vaccine law in these strange times. Thank you for the introduction. I don't think I need to belabor my experience. I always like to start these presentations by pointing to this triple-decker bacon cheeseburger with French fries. Anyone who owns a restaurant can put this on the menu and sell it and call it, and this is literally called a heart attack burger, sold under the premise that if you eat it, it's just going to kill you. And they can sell this without any kind of prior authorization or affirmation from the government. By contrast, all pharmaceutical products are required to go through rigorous testing and in review in order to determine that they are both safe for use and effective for the purpose for which they are sold. And vaccines in particular are the most heavily regulated commercially available substances on the face of the earth. They fall under the entire regime of review for pharmaceutical products and also under the regime of review for biologics, which include things like blood products, but vaccines fall under both of those regimes, so they're subject to phenomenal levels of review to determine that they're safe and effective before they enter the market. And I like to remind people that you don't have to have any kind of review or any kind of approval from the government to sell food substances, food items that are basically completely unhealthy, but you do have to have that level of review to sell something that is actually preventative of the hazards that perhaps the food items you're eating can be caused. We've had some discussion in this seminar about red states and blue states. I always like to remind people that vaccination has, and I think remains, an issue with very strong bipartisan support and historical bipartisan support. In 1988, President Reagan issued a proclamation in support of vaccination and immunization as a way to safeguard communities. In 1975, I think it was, Gerald Ford, we have the picture here, received the swine flu vaccination as part of a campaign to encourage people to receive that vaccine during an epidemic. And of course, it was Justice Scalia, in his opinion, in Bruce v. Wyeth, as recently as 2011, who wrote that in the 1970s and 1980s, vaccines became victims of their own success. They had been so effective in preventing infectious diseases that the public became much less alarmed at the threat of those diseases and much more concerned with the risk of injury from the vaccines themselves. So, there is a long-standing history of support from across the political spectrum for vaccination. There have been times when opposition to vaccination has come more from the left than from the right, from people who thought, well, corporations are bad and, we need to do the nature or granola bar kind of thing for our health as opposed to that. Modernly, yes, we do have a politicization of vaccination policy, but I think this is not permanent. This is more of an historical anomaly. So we've seen a current transformation of vaccination law. And a lot of the discussion today has been about what the Department of Health and Human Services has done, what Secretary Kennedy has done specifically, and certainly decisions that they have made have affected a great deal of vaccination policy and have stirred opposition to vaccination in the population. Reduction in vaccination rates is certainly fed by the leadership of HHS being non-committal towards vaccination. In addition to some of the things that we've talked about, there has been a substantial reduction in federal funding, federal contracts. A lot of federal contracts for vaccination research have been pulled. There have been licensure decisions that have been stalled or that have been made in ways that historically would not have been. But there has also been movement in terms of state mandates and exemptions and in terms of constitutional litigation. So I want to expand the discussion a little bit to talk about some of the things that have gone on outside of just HHS. Now, one thing that has gone on in HHS is this focus on placebo group testing. That is kind of problematic, the idea that we want to test new vaccines against a placebo instead of testing them against previous existing working vaccines that have a known safety profile. The secretary, before becoming secretary of HHS, said that none of the vaccines the CDC recommends for routine injection into children were licensed based on long-term placebo-controlled trials. That's simply untrue. There are plenty of vaccines that are extant vaccines that were subject to placebo-controlled trials. The language there is kind of ambiguous. So what do you mean by long-term? Is that for a period of decades? Is that what you're thinking? But the fact is that there are many reasons why we don't do those kinds of studies, chief among them being that we don't want to give children, for example, a placebo polio vaccine or a placebo measles vaccine, let them think that they have been protected against that disease. And I have a nice illustration for this, is a comparison. If you're testing new parachutes, you don't give half of your troops fake parachutes that don't actually work and have them all jump out of a plane. So HHS announced in May of last year that all new vaccines will be required to undergo placebo trials. We haven't seen how that looks yet. We have seen an instance where CBER has rejected an application for the Moderna mRNA flu vaccine on the basis that the vaccine that it was tested against wasn't one that was recommended by CBER. That decision has been partially reversed, and I'm happy to say it's been reversed under pressure from the White House, or at least reportedly under pressure from the White House. So going back to the idea that this is a bipartisan issue, I think there is growing daylight between the White House and HHS on vaccination policy. There are increasing reports that the White House is frustrated with the focus on vaccines, sees it as a losing political issue, doesn't want changes to vaccination policy to be something coming out of HHS. in the lead up to the coming midterm election, at least. And I think that's a positive sign. And I think we will see whether that actually eventuates changes in policy from HHS or a change in leadership from HHS if it turns out that the current leadership just can't help themselves with respect to getting involved in vaccine matters. Now, something separate from HHS, this is out of DOJ. In July of last year, the Attorney General of the United States dismissed charges against a plastic surgeon who was accused of issuing fake COVID-19 vaccine cards. And the defendant in this case basically admitted to doing what they were accused of doing. They falsified vaccination records. They received supplies of the vaccine from the federal government on their request to the value of tens of thousands of dollars. Instead of injecting those vaccines into people, they injected saline into people. Whatever amount that they were paid for the service by insurance or any other provider of funds, they kept. But they didn't provide the service that they reported that they had provided and were charged with fraud for that. And this seems kind of paradigmatic of this concept of waste, fraud, and abuse in the healthcare system, that you would have someone engaging in this. But these charges were dismissed by the Department of Justice on the grounds that this person was giving people a choice that the government wasn't giving them. Now, I am all for people having a choice about vaccination. I think we should have robustly available exemptions from vaccination or accommodations from vaccination for people who are unable to be vaccinated, either due to a medical condition. Some people have conditions which prevent them from being vaccinated, or to strongly held religious beliefs that they can demonstrate are sincere and can articulate as being beliefs that prohibit them from being vaccinated. But I don't think people should be allowed to sort of defraud the government and falsify their records. And we are in a time when, since the beginning of the COVID pandemic, perhaps predictably, there has been a surge of falsification of vaccination records, the likes of which has not been seen in this country before. There have been numerous prosecutions, and when we discuss these, we're very often speaking of prosecutions of medical professionals, people who are licensed to practice medicine in some area, providing false records of vaccination, in some cases injecting saline into someone instead of the vaccine and representing that they injected the vaccine, in some cases not providing any treatment at all, but just saying, well, this person's vaccinated, here's a card that says so, I'm entering this information into whatever system or database records vaccination records for the state. And we have seen this not just with COVID-19 vaccines, but there has been an increase in vaccine fraud and fraudulent records of vaccination for childhood vaccines as well. And this is highly problematic. I think it's very difficult to prosecute. You know, here's a case where the numbers of people, thousands of people receiving these false vaccinations were sufficient that it was kind of difficult to hide. But I think this is sort of a tip of the iceberg situation where, for all the prosecutions that we've seen, for every instance that we've seen where someone has been caught with a falsified vaccination record, there's probably a dozen people with a falsified vaccination record who just haven't been caught and won't be caught. This is sort of a collusive crime because people who are seeking false vaccination records aren't going to go and disclose, and well, the doctor didn't give me a real vaccination. So, you know, it's very hard to detect that it's happening, very hard to catch, and very hard to prove. There was a case in New York where a nurse had received about $1.2 million in payments from people seeking false vaccinations. And, you know, that was caught because they were basically advertising this as a service on social media. And they were trying to do it subtly, but, you know, it's very hard to do that when you're trying to reach a fairly large audience of people who are potentially going to pay you for that. But I do think that's something that we need to be wary of. False vaccinations not only defraud the government and lead to medical professionals being paid for a service they're not providing. They also muddy the record of vaccine effectiveness, because now you have a record in the system of a person having received a vaccine. If that person who is actually unvaccinated becomes sick from that disease, it looks like an instance of the vaccine not working. And I wouldn't be surprised if a lot of cases where we think there's been a breakthrough infection or something of that sort turn out to be, or if they were able to be investigated, would turn out to be instances of people not having received the vaccine at all and having just fraudulently received a record of vaccination. There was an instance in December where the CDC reportedly awarded $1.6 million for hepatitis B researchers for a study to be conducted in Guinea-Bissau. That study reportedly has since been pulled, although there are conflicting reports about that. But it is also problematic that among the powers that the government has, in addition to being able to withdraw funding for vaccine studies, they can fund vaccine studies and route funding towards kind of questionable studies that are going to be done. We know their anticipation that, okay, they're going to come up with a study that shows problems with the hepatitis B vaccination. Another concern with this particular study was that it was again going to use a placebo and test the hepatitis B vaccine against a placebo and give children in an area where hepatitis B is endemic the false security of having been vaccinated. That is another thing to be aware of. And I had mentioned that there was a refusal by FDA to consider Moderna's influenza vaccine. And this is mRNA influenza vaccine. And this is kind of a historic circumstance in itself. I have personally never heard of a refusal of CBER to consider an application based on a well-conducted clinical trial. There were, importantly, communications between Moderna and CBER during the conduct of this clinical trial prior to the current administration coming into office. CBER expressed reservations about the vaccine that Moderna intended to test their vaccine against. Moderna tested it against a GSK vaccine, but CBER ultimately gave their approval to Moderna's planned clinical trials, and Moderna spent tens of millions of dollars conducting these clinical trials on the expectation and on the representation from FDA that this would be acceptable, so that when Moderna finally provided its data, the fact that they were met with not just scrutiny, but with a refusal to consider the application was, again, very concerning. And it is, again, kind of heartening that there was a fairly quick turnaround. Within a couple weeks, the White House intervened on Moderna's behalf, and CBER has accepted this application. Now, of course, CBER still has to go through the process of approving this vaccine, and there are obviously substantial political pressures on that entity. Notably, CBER had internally, the staff had said that this application that Moderna had submitted should be accepted. It was the HHS Secretary's appointed head of CBER, Vinay Prasad, who personally rejected the application and actually said that Moderna needs to show some humility in submitting an application. That's sort of kind of language that has not come out of that office, that sort of judgmental tone towards a vaccine manufacturer. And, this reflects the tenor of particularly scrutiny of mRNA vaccines. There are people in the anti-vaccine movement who have said quite frontally that mRNA vaccines should be removed from the market. They should be disallowed. I think there is a degree to which we as advocates of vaccinations, public policy, need to make it clear to the public that the goal, the sort of end goal of people who are opposed to vaccination is not just give you a choice not to be vaccinated or provide information about vaccines, whether misinformation or disinformation or not. They want to remove vaccines from the market. They want to make it impossible for you to receive vaccines that you want to receive. And there are more ends to this than just what is happening with HHS and ACIP recommendations. Of course, there has been a steady drumbeat of efforts to reduce recommendations for vaccines, reduce their availability for populations outside of certain limited areas. There has been commentary from people who are involved in these processes to the effect that they want to strip funding for these vaccines, make these vaccines ineligible to receive funding. And that's something that happens as an effect of ACIP recommendations also. As ACIP recommends vaccines and those vaccines become covered under the ACA by insurance companies. They become covered by various other programs that provide for vaccines, and they fall under the coverage of the National Vaccine Injury Compensation Program. And it's kind of important that, there are people who have said, and for example, Aaron Siri, who's an attorney who represents claims against vaccine manufacturers or attempts to, that if they're able to remove vaccines from being recommended, then those vaccines will be taken out of the purview of the National Vaccine Injury Compensation Program. The manufacturers will no longer be immune from liability from lawsuits initially asserting injuries caused by those vaccines. And they'll be able to sue and recover enormous amounts and enormous attorney's fees, and functionally put the business of manufacturing vaccines in the United States on the chopping block. And I think there's an ultimate goal of just making it impossible to manufacture, distribute, or sell or administer vaccines in this country at all. Now, that may seem like an incredible reach, but there are a lot of things that have been done in the past year and some months that would have seemed like an incredible reach, an impossible thing to conceive that would be coming out of the government. And Aaron Siri has, in fact, recently petitioned HHS to add some 300 conditions to the vaccine injury table. So let me give you a quick overview of that. There's a vaccine injury table that is what the National Vaccine Injury Compensation Program looks to determine if someone who asserts that they have been injured by a vaccine receives basically automatic compensation. For example, if you receive a vaccine containing a tetanus component and you have an anaphylactic reaction within a certain number of hours and you're able to demonstrate those three things, then even without showing causation, you receive compensation. And for 16 vaccines that are recommended for administration to children in the United States, those are all listed on that vaccine injury table. There are 5 or 6 conditions associated with each vaccine, shoulder injury related to vaccine administration, vasovagal syncope, which is a fainting episode, things of that sort, where compensation is automatic if you make those connections. And the Secretary of HHS has the authority to amend the table. And Aaron Siri, who is no stranger to the current Secretary of HHS, has suggested the addition of 300 additional conditions to the table, including such things as arthritis and insomnia, to the extent that, if these were added to the table, then sort of anyone who receives a vaccine and within some period afterwards claims to have developed insomnia would get a substantial award of compensation for that. And that would be, if all of those conditions were added, it would probably make it impossible for the ICP to pay all of the claims. Congress would have to come up with some other way to do that. And it might make it easier to make an argument for eliminating the ICP as a program. Additionally, we have seen state legislative developments. Now, this is something that has been more of a red state, blue state issue, but states are going in different directions with this, while a handful of states have, for example, removed religious exemptions and are fighting to maintain that removal. Other states have expanded exemptions to the point where they devour any vaccination mandates. And they've said, well, anyone who says that they have a conscientious objection to vaccination, for example, in Texas, the law now is that if you assert a conscientious objection to vaccination, then all you have to do is kind of sign a piece of paper saying, I object to vaccination, and vaccination mandates cannot apply to you. And this goes with both employer and school vaccination mandates. In the state of Montana, the state legislature has passed a law prohibiting employers from, as the way the law is framed, discriminating against people on the basis of vaccination status, which means that you cannot have employer vaccination mandates. That law was initially overturned by a district court in Montana, but was upheld by the Ninth Circuit. So the Ninth Circuit has said, yes, the state can do this. And if you have circumstances of someone who has immunological disorder, cannot be vaccinated, needs to be surrounded by coworkers who are vaccinated, then that would be, an individual case where you might be able to require those coworkers to be vaccinated. But absent that, you cannot, as an employer, require vaccination of employees in that state. We saw a couple of years ago, not too long ago, Mississippi for the longest time did not have a religious exemption to vaccination. They had one. It was thrown out in the 1970s as an equal protection violation because it limited the category of religions to which exemptions could be applied. We had this case, Bosarge v. Edney in Mississippi, in which the district court held that Mississippi is required to have a religious exemption to vaccination. This is after 24 years of Mississippi not having one, and the state legislature being unable to pass a new religious exemption that recognized the breadth of religions to the extent that would allow that exemption to escape from equal protection scrutiny. So Bosarge was an interesting case because the government of Mississippi just declined to defend it. And we were left with just one side saying we should have a religious exemption, and no one's speaking in favor of not having the religious exemption. There is litigation ongoing in West Virginia, and Bosarge has pointed to Supreme Court precedent that arose during the COVID-19 pandemic, where we had, for example, a state said, well, you can't have more than a certain number of people in a space. We're going to make an exemption for casinos, but we're not going to make an exemption for churches. And the court found that to be wrongful. But that's a very different proposition from a vaccination requirement. Very recently, in the case of Miller v. McDonald, the Second Circuit upheld New York's removal of a religious exemption. The Supreme Court has vacated and remanded the Second Circuit in that opinion in light of a case in which it said parents have to have a choice about whether their children are exposed to LGBTQ material in school curriculum because it conflicts with their religious upbringing. Again, I think this is a very different case. This is equating religion with medical treatment in a way that has not been done before. Kind of raises the question, well, if an ambulance driver can run a red light while taking an injury victim to the hospital, can the church bus driver run a red light if they assert that they have a comparable religious emergency? Can people who are not physically handicapped park in a handicapped space if they assert that they have a religious handicap? So I think that's the direction that these cases go. And the result of this has been kind of predictable. In Utah, there has been a substantial measles outbreak, and parents have been stunned at how bad a measles infection actually is. Mark Twain wrote that when he had measles as a child, he felt that he had died and gone to hell for 2 weeks, and then after those 2 weeks, miraculously been resurrected. So people are beginning to see that, yes, in fact, these diseases that we're vaccinating against, they're much worse than the sort of routine flu or common cold. They're surprised by the degree to which these illnesses are, in fact, severe and serious. And we have seen at some points, at least, the CDC walking back language that seemed to be negative towards vaccination in light of outbreaks that have gone on, particularly the outbreak in South Carolina. So, it may be that our long history of public health, where we see a tragic circumstance lead to reform, is just repeating that pattern once again. We have declining vaccination rates. We are going to have tragic circumstances as a result of that. We are seeing increases in all of these vaccine-preventable diseases. And that in itself is likely what will stir reform and bringing us back out of the kind of direction that we've gone in the past year and change. So that is my presentation, and I'm Brian Dean Abramson. My contact information is here, and I think my slides will be presented. And with that, I will stop sharing and let the next presenter take the floor.
Thank you for the fascinating presentations. I'm sure we all learned so much. So our second speaker is going to be Renee Nazira, and then our third speaker is Montrese Ransom, and then we'll have time for Q&A. Thank you.
Hello, everybody. Thank you so much for the invitation to this symposium and this phenomenal room. I've never seen anything like it. I mean, I've been to actual court, not for personal reasons, but should I start with, like, if it may please the court? Like, how do we do this? So, my name is Renee Nájera. I am the Director of Public Health at the College of Physicians of Philadelphia. I also teach at George Mason University and at Johns Hopkins University. And my specialization is epidemiology. So I'm a doctor of public health with a degree in epidemiology, study of infectious diseases, but then I moved on to social determinants of health, et cetera, et cetera, et cetera. But one of the things that how do I advance it? Yep. Oh, quick disclaimer, of course. All views and opinions presented here do not necessarily, you're lawyers, right? You know about these things. I'm not a physician. I'm not that kind of doctor. So nothing in here is medical advice. I generated some images with AI. Sue me. We're in 2026. But I did write all of this myself. So no conflicts of interest on anything in here. So, being in public health, one of the biggest things is for me has been to look back on history to where we've been before, so that we know where we're heading with whatever public health problem of the day is. When the pandemic started, people were emailing me and asking me, when are we going to have a vaccine? And the fastest vaccine before that was the mumps vaccine back in the 50s, and it took a while to get that vaccine going, and so into the 60s actually. And so, I had some theories, but I never expected Operation Warp Speed, and then that happened. And so now, going forward, I'm going to be like, well, it's gonna be a year before we get a vaccine. But I want to walk you through some of the major milestones in vaccine history, and we expound so much more on this on historyofvaccines.org, which is a project from the College of Physicians. So if you have like a lot of time and you want to go down a very big rabbit hole into the history of vaccination, I invite you to check out our project, and it's always growing. We're trying to catch up with more recent history, but we have plenty of articles and blog posts about the past. And so you probably heard earlier today talking about the variolation. So I'm not going to talk about variolation and how Cotton Mather and Dr. Bolston were dragged through the mud when they started variolating people, how Cotton Mather's house in Boston got firebombed when he proposed variolation. So violence and mean words and attacks in the media are not a new thing. They happened since before vaccination. So 1796, Jenner discovers vaccination using cowpox, and immediately the attacks began on him. He was trying to change nature. He was trying to go against God. If you took the vaccine, which was made from the cowpox virus, you would turn into a cow because it would change your nature. Does that sound familiar? Right? Pasteur then in 1885 successfully gave us the rabies vaccine. So this was a leap because now you had a live but attenuated virus that caused disease. When it wasn't attenuated, it would cause disease and kill you. Now he attenuated it, and it was able to prevent you from dying if you were bitten by a rabid dog. In 1890, you have the next leap, which is diphtheria and tetanus antitoxins created. So here, scientists learned that if you gave a large mammal like a horse, the diphtheria vaccine or the tetanus vaccine, not the vaccine, the bacteria, the animals will create antiserum, and that you could then take, filter, and give it to people. So kids were the most benefited from this with diphtheria. This was before antibiotics, so you get horse serum in you, and it would help you fight off the infection. And then the next leap is in the 1920s, that no longer do we need to give it to horses and get the serum out. Now we get the actual toxin and we treat it in the lab, so it's not as potent, and we also pair it with some of the antibodies, and now we give it as an actual vaccine. So then you make your own antibodies against the toxin. 1930s, isolation and identification of viruses from culture. So before the 1930s, viruses were kind of this, scientists kind of knew that viruses existed, but they didn't really know what they were. And it wasn't until the 1930s when we got the electron microscope that they saw them. And so they were able to classify them by their size and shape. And then 1954, Jonas Salk does the field trials with the polio vaccine, which were a big success. By 1955, they approved the polio vaccine and everybody starts getting it. 1980s, recombinant DNA technology to give us hepatitis B vaccine and others. So no longer do you need the full germ or virus, you need the genetic code. And then we get the mRNA vaccines from that, where you don't even need, you just need the code to be emailed to you from China of what is floating out there. And then you make it in the lab and you make the mRNA vaccine and you make your own proteins. So major milestones, but not without challenging moments in and of themselves, right? 1832, the Indian Vaccination Act was used to coerce Native American tribes into relocation. I'll talk a little bit more about that because you want to talk about echoes to what is going on today. 1850s to 1922, the rise of opposition in cities like Boston and San Antonio against mandates in schools. 1901, here in St. Louis, 13 children died from a tetanus-contaminated diphtheria antitoxin. A horse named Jim. The horse was given diphtheria to make the antibodies, but the horse also had tetanus. And so when they extracted the antibodies for diphtheria, they extracted the tetanus toxin along with it. And these children who were already pretty sick with diphtheria, they were giving what was supposed to cure them, but they were also given tetanus and they died. This happened, I don't want to say all the time, but it's happened many times in the past, also with the smallpox vaccine in New Jersey, and there's other instances. 1955, I mentioned the polio vaccine being a big success. Well, the Cutter Labs out in California, they forgot to attenuate the virus. And so they gave tens of thousands of people full-blown polio virus in the vaccine. A few hundred of those people developed polio and a few dozen of them died. And so it was a big to-do back in 1955. Eroded trust in the vaccine. Luckily, the oral polio vaccine from Dr. Sabin came along to save the day. 1976, you have the flu vaccine developed after a soldier in Fort Dix, New Jersey, developed flu. And so scientists believed that a new flu pandemic was happening or on the way. They rushed the flu vaccine to market, and they did surveillance for side effects of the vaccine, and they noticed that there was a slight uptick in the Guillain-Barré syndrome that was happening. And debatable whether they just detected it because they were looking for it or if the vaccine really caused this uptick. It's up for debate. 1982, the TV documentary Vaccine Roulette sparked fears over the DTP vaccine. They started this TV show in Washington, D.C., and then it went national with people giving stories about how their children developed seizures after getting the DTP vaccine. There's really good evidence that those children were already predisposed to seizures and to having a seizure disorder. It's just that, temporarily they got the vaccine, they got seizures, but some of them were already getting seizures before the vaccine. It became this whole thing, led to the vaccine legislation that we are living with now today, the vaccine court, all of those things. 1998, Andrew Wakefield, he doesn't like me calling him Andrew Jeremy Wakefield, but Andrew Jeremy Wakefield published a fraudulent study in 1998 saying that, the study, if you read it, the retracted paper, if you read the conclusions, they say that they found no causal association between the MMR vaccine and autism. But he went on the speaker circuit and said that it was his gut instinct that the MMR vaccine did cause autism, and that he wouldn't vaccinate his children with the MMR vaccine. And we were off to the races with the MMR vaccine causes autism debate that's still with us today, almost 30 years later. And then, surveillance identifies a rare myocarditis risk in following the mRNA COVID vaccination, and that was a real signal. And the vaccine manufacturers adjusted the formulation, and now it's still there, but not as prominent as it used to be. And by the way, if you get COVID, you have way more of a chance of getting myocarditis than from the vaccine. So challenging moments, to say the least. A lot of parents really, they look at these things and they amplify. They don't look at the milestones, right? The milestones. Oh, great, we have these fabulous things. They look at the challenging moments, and that's what sticks with parents. When my daughter was born and they went in to give her vitamin K shot and her hepatitis B shot, the needles looked like this big to me. And I had to cognitively tell myself, no, this is okay. She's going to be okay. And something in me was like, well, what if she's not? What if all this science that you've been learning and everything that you know is wrong? Right. And so I can only imagine for somebody that doesn't have the education or the time to read the science or the trust, as we've been talking today, to experts, how they see those needles and how they see the possible side effects of those vaccines. But whenever there's been challenging times, there's always been a champion. And in this case, I mean the U.S. federal government. So a lot of these things that I talked here are the challenging moments. It was human error, right? Human error at Cutter Labs, human error with the horse named Jim. It was bad policy in 1932 with the Indian Vaccination Act. It was fraud with Andrew Jeremy. So it's been humans that cause these things, but always there's been a champion, and that champion has been the federal government of the United States of America. Not so in the last year plus, right? The federal government has been there to fund vaccine research, outbreak response coordination through CDC and state and local health departments, disease surveillance systems that wouldn't exist without federal funding and staffing, laws and regulations to make vaccines safer, just to compensate anybody who's hurt by them, and opposition to state and local governments' attempts at eroding vaccine requirements. The federal government was there to intervene and to kind of guide everybody towards evidence, science-based outcomes. Not so anymore. The relationship between science and the public health and the public, medicine and the public, has always been strained. And I say that it's strained by design just because of the way that the laws and regulations in the US have been set up. I don't believe this picture of, on one side you have pro-medicine, public health people, and on the other side you have people who are pro-liberty, freedom, etc. It certainly looks this way from what we've seen since the pandemic and the debates that we're involved with, but it takes a lot more nuance than this. There's people in the middle. There's people, talking to each other within these groups. There's people who agree that children should be protected from deadly diseases. But what we see is this friction. And I say that the enumerated rights get in the way, but they get in the way of an honest discussion on what's going on. They don't get in the way of public health. They don't get in the way of medicine. They get in the way of, people having a good discussion on what's going on. You have, as we heard from Brian, the freedom of religion. My religion is against that vaccine or its components, so I don't want to get the vaccine. Right? My argument to that is, well, if you say that vaccines are dangerous, but your religion doesn't allow you to get those vaccines, so you're protected from those vaccines through your religion. But what if my religion, or lack thereof, doesn't have any opposition to vaccines? Why should I inherit all the risk? Because then where is the equal protection in that, right? So I'm supposed to take on all the risk because my religion doesn't say it's dangerous, or because I don't have a religion that says that it's not dangerous. Freedom of speech and of the press, that really, in my line of work, it's a headache, because you have all the disinformation and misinformation going on. Almost every other day, I get an email from somebody in the world who wants something clarified, or they heard or saw something. Almost every day, one of my family members sends me something because they heard or saw something in social media or in the regular media about vaccines, and they need it clarified. And so freedom of speech gets in the way. Colleagues in other countries that don't have kind of the same protections tell me that like, oh, so that would never fly here. Places like Britain, Australia. I was like, well, you're not here. So, it's a little bit different. And then the due process and protections from search and seizure, prevent health authorities from holding somebody down and forcefully immunizing them. So that's my argument to people who are like, your vaccine mandates or your vaccine laws. And I'm like, well, you're not being forcefully held down to be given a vaccine. Right. And ever since Jacobson v. Massachusetts, right, the court said that that's not the case. You can pay a fine, you can be excluded from public services, et cetera. But nobody's going to hold you down, even though Washington did it during the Revolutionary War. But that's for you guys to figure out when you go to historyofvaccines.org. All these frictions have come to a head, as we have seen, and you hopefully you know this. Jacobson v. Massachusetts, fines are okay in times of epidemics. Suck versus King, unvaccinated can be excluded from public services. And when the little girl was kept out of school in San Antonio, Texas. Cruzen versus the director of Missouri Department of Health, right to refuse care if somebody is competent. And again, we go back to this whole argument of like, you're not going to force your vaccines on me. Well, what physician has ethically forced anything onto somebody when that person has refused it, right? That is one of the main principles of health and public health is autonomy. And so that hasn't been violated. And I've been hard pressed to find, other than cases of isolation from tuberculosis or Hansen's disease, leprosy, nobody has really been held down and given a vaccine against their will. I did. I grew up in Mexico. And so there was a tuberculosis outbreak in the part of Mexico where I was growing up. They did bring us into the one schoolroom and they did hold us down and gave us a BCG vaccine. I have a lovely scar from that. But again, I was a child and local parentis and all that comes into play. Well, we don't need to get into it. And then Brucewitz versus Wyeth, the Vaccine Act preempts most design defect lawsuits if the vaccine was properly manufactured and accompanied by adequate warnings. And then most recently with the pandemic, NFIB versus OSHA and Biden versus Missouri. And here I want to point out that both agencies have to act within their statutory authority. The court has said, if there's no statutory authority, you can't do it. And so that is going to lead me into one of the slides. So foreshadowing, we call this in storytelling. So has this ever happened before? Yes, it has happened before. And unfortunately, it probably will happen again. But to give you a good example, the Indian Removal Act of 1830 sought to move Native Americans west of the Mississippi. They were in their home, and the European settlers wanted land east of the Mississippi. And so Andrew Jackson and his friends and the military forcefully moved a lot of these tribes west of the Mississippi, what we know as the Trail of Tears. In 1832, fearful that some of these tribes would be hit by smallpox and then give it to the European settlers, Congress allocated a certain amount of money so that the Secretary of War, not Defense, it didn't change names yet, would go and vaccinate the tribes. And Andrew Jackson said, only vaccinate the tribes that are willing to relocate. And the ones that are not, don't vaccinate them. And you can imagine how that turned out for the unvaccinated ones. So the vaccine was actually used as a weapon. And so, there was some very big outbreaks of smallpox because of policy coming out of the White House from uninformed people. So it has happened again, happened before, and it will happen again. And so we have these swings back and forth every 4 years, depending on who wins popularity contests. And I'm sorry to tell you that elections are actually popularity contests. If you look at them, we're not really electing people that are qualified to those positions. We're just electing the ones with the best memes. And that's the sad reality of where we are right now with social media. There's also no stable national health board, and state boards are also subject to the whims of who's in office. Example, Florida, right? Example, pick any state in the South. If the governor doesn't like what's going on with public health, they can remove and replace whoever's on the board. And we saw this happening at the national level with Kennedy and friends. So I have previously, and others have as well, proposed a Federal Reserve model for like a national health board that is a little bit more insulated from changes every 4 years, that is accountable still to Congress and to the people, but is, again, like we do with the Federal Reserve, where it's a steady change. We don't just wildly change policy on the economy. Why should it be the same way with health, which is a little more important? So, there's a lot of opinions about this and how it can be carried out. But if something like this happens, if we ever have, it depends. whoever wins, right? In 2 years, 4 years, whatever, whoever wins, there's going to be a side that's going to be happy, and there's going to be a side that's going to protest. And unfortunately, we're locked into this cycle. But if you go through history, this has happened before. So I want to leave you with an optimism, a point of optimism. So the future is bright. Like, things are going to get better, and they have gotten better. We were talking earlier today about how things, we're at a low point, but in the course of human history, we're like moving. If you look at a chart up and to the right, we're moving forward, advancing. In 200 years, we have these wonderful technologies for vaccines and prevention of infectious diseases. I flew on a plane at 600 miles an hour at 38,000 feet, about 100 years after the first flight. So it's, technology is moving forward. And so we have a lot to be hopeful for. It's going to take a little bit to get there. And we just need to not lose hope. And I'm going to include those of you in the law as public health workers, because your work is adjacent to public health. It's necessary. It's partnering. Obviously, public health is legal. It's political. It's scientific. It's all these other things. But also, if the public is better informed, less misinformed, and the machines that throw out all this disinformation and misinformation are somehow controlled. And I just don't know how that's going to happen in a framework where there's freedom of speech. Maybe the bright legal minds here and if the future will figure that out. But there has to be a way to limit the damage that they're doing, because they really are doing quantifiable damage at this point. And most of all, if the institutions stand the stress, as they seem to have for now, with the courts really stepping in and the decisions, the current administration seems to be sticking to the court decisions, and that's encouraging in some ways. The fact that we have to fight these fights is discouraging. But if the institutions hold, if people don't lose hope, if you don't lose hope, if I don't lose hope, and we try to inform everybody better and keep them in the loop of science and what it really means to get a vaccine, it's not a death sentence. It's not messing with your DNA. It's not changing your nature. It doesn't go against any of the major world religions. And we can have a discussion if it goes against your personal beliefs. The future is bright. So with that, I thank you so much for your time and hand it over to Montrese. Thank you.
So I'm not sure how, but for my last 3 speaking engagements, I have been the last speaker of the day. And I was originally offended by it, right? Like, why would you make me last? Everybody's going to be gone by the time it's time for my presentation. I've gotten to where I sort of appreciate having the opportunity to hear from all of the other speakers and to incorporate that in my talk. And I think for this one in particular, am I supposed to pull the slides up? Okay. For this one in particular, I think it has been particularly helpful for me to hear from the other speakers. As has been mentioned, my name is Montrese McNeil Ransom. I think that my moderator got an old bio. As of 2 weeks today, I'm serving as the executive director of the Cordell Institute for Policy in Medicine and Law at Washington University. Prior to taking on this role, I served as the director of the National Coordinating Center for Public Health Training at the National Network of Public Health Institutes. Do y'all know what public health institutes are, anybody? Everybody in the room? There's 50 of them across the country. There's one in Missouri, the Missouri Public Health Institute. And the goal is to be a partner to governmental public health and to do some of the things that governmental public health can't do to advance health in the states that they're in. My job at an NPHI was focused on developing training and tools to build the capacity of the workforce. And as a lawyer, I obviously brought some legal capacity building into that. I believe that there is no public health in this country without the law. From the establishment of the health department, which is done by statute, to the passing of a clean indoor air ordinance, law is foundational and interventional as a tool in public health. But prior to taking on the role at an NPHI, I served as the team lead for public health law related training and workforce development at CDC in the public health law program. I served in that unit of CDC for about 20 years. So whether you like it or not, you got a trainer up here. So some of this is going to be training and focused. My focus is also really on the workforce. That hasn't changed. When I came into public health, I had a law degree. I couldn't even spell public health. And it was the people in this field that kept me in it, that encouraged me to go back to get an MPH. And my work really focuses on ensuring that our workforce now and in the future has the tools and the competencies that they need to protect the health of the public. So you're going to hear some elements of that in my conversation today. I want to start by giving a little bit of a intro into what the Cordell Institute is. I need to put my glasses on. What do I need to do to make the slides go? Do I have a mouse? I have no power, no control. Oh, maybe because it's the PDF. Okay, perfect. Thank you. Can I maybe do this? Okay. So yeah, the Cordell Institute, there we go. Cordell Institute is at Washington University. It is a partnership between the medical school and the law school. And our mission is to devise solutions to the novel ethical and legal questions accompanying scientific and technological advancements in healthcare, public health. And as of late, it's been particularly related to privacy and information. When you get a public health lawyer at the helm of an organization like this, you're going to see a lot more public health involved in what we do at the Cordell Institute, and I'm super excited about that. But we really focus at the Cordell Institute on the intersection of law, medicine, and innovation. And I think vaccine policy is an example of that intersection. And I don't think there's anybody in this space, or you wouldn't be here today, that won't agree that vaccines represent an extraordinary scientific achievement in this country. But as this moment is reminding us, and as we've heard throughout the day, the success of vaccines ultimately depend on the legal and institutional structures that translate science into policy, or as I like to say, the coupling of scientific insight with legal might. Public health law, the field that I come from, we've long recognized that scientific evidence is not enough by itself. Institutions must exist that truly believe that science is real, right? And that allow that science to be evaluated, trusted, and implemented. I also have the privilege of serving as the current chair of the National Vaccine Law Association. Members of our board include Dorit and Renee and Brian Abramson, who you've heard from today. And in the National Vaccine Law Association, we spend a great deal of time thinking about vaccines and vaccine law and the legal architecture surrounding vaccines. And that architecture includes the elements of public health laws, as you've heard today, regulatory law, litigation, public health authority to act, and administrative law. And for decades, as Renee has shown us, this framework has really supported vaccine innovation, safety, monitoring, and access. And the federal government has been a champion in that. But like many governance systems, the vaccine governance system depends heavily on institutional norms and professional expertise, as Richard kind of alluded to. And when those norms are challenged, as we're seeing today, the entire system becomes more fragile. And that's what we're experiencing. And so I want to ground this in something real. Again, my work has really focused on the public health workforce. And a few years ago, I was speaking to a local public health department director, and she was talking about how she spent a decade and a half trying to build partnerships and trust with the folks in the community that she served, working closely with schools and churches and neighborhood leaders. Her job was not only to implement public health practices and vaccine programs, but to sustain the relationships necessary to make public health possible. I often say that public health is a people business disguised as a systems business. It's a people business. And she said something in that conversation that I haven't been able to shake. She said, I thought the hardest part of my job would be the science, but it turns out the hardest part is defending the system that allows the science to matter. And that quote sat with me. It stayed with me. And I think that that's really where we are now, because what we're seeing is not just a disagreement about vaccines, right? That's certainly a part of it. But we're seeing a strain on the governance system that translates science into action, into public health action. And what this health director was describing was a breakdown in the institutional structures that allow scientific decision-making to function in this country. And that breakdown is happening for a number of reasons that we've heard about today. In some cases, it does reflect political pressure and politicization of our work. In others, it reflects challenges to how decisions are being made or have been made, who has the authority to make them. And in some instances, it reflects real questions about transparency, process, and accountability in the work that we do in public health and public health law. And what I'm seeing is all of that converging now in ways that really place the strain on our colleagues in public health and healthcare. And that brings me to the focus of my talk today. I was asked to be a part of the Path Forward panel. And I believe that where I'm at in my career, my work bridges law, public health, and leadership. And if you're a law student, you're an emerging leader. If you're a lawyer in this space, we have a role as leaders in this space to really think about what's coming next and the role that we have to play there. And I've been able to listen to most of the presentations today. We've covered a lot of ground. I'm not going to reiterate any doctrinal stuff. I'm not going to talk much about case law. We've heard about the current legal challenges. What I want to talk about is strategic foresight. Where do we go next? What might the path forward look like? The ecosystem of vaccine governance, as we've heard today, is pretty broad. Multiple institutions interact to translate scientific evidence into public health action. As Dr. Maldonado, did I get that right? Yep. Dr. Maldonado mentioned, the FDA evaluates safety and efficacy. ACIP is meant to evaluate evidence and development recommendations. CDC provides implementation guidance. I remember when I first got to CDC, it was they would do these surveys of people in the country, and CDC was the #1 most loved federal government agency. And I came to realize it's because we provide guidance. We didn't really regulate anything. We just provided guidance, and the states could then implement it how they wanted to, and then folks would get mad at the states for implementation. We provided guidance based on the science. That has changed a little bit, our perception among the public for sure. In this ecosystem, states determine mandates and exemption policies. Courts review legal challenges, and manufacturers produce vaccines. But it is communities, the people that we serve, that ultimately determine whether vaccines are accepted and used. And in that shift, we're seeing happening today as well. As Dr. Maldonado touched on, this kind of does look like a piecemeal approach. But even with this piecemeal approach, historically, this ecosystem functioned because each of these actors operated from a shared group of norms, but these norms are increasingly being put under pressure. And I see at least 3 distinct pressure points emerging. One in governance, legal authority, and information. So the vulnerabilities, we've heard about them today, and I'll just touch on them again briefly. So we've got governance vulnerabilities, where vaccine policy institutions, ACIP, CDC, tend to heavily rely on professional norms rather than explicit statutory protections. ACIP is written into law, but are the protections there that we need for organizations like ACIP? They were designed to operate through scientific expertise and through professional independence. But recent political debates have demonstrated how easily those norms can be disrupted when advisory processes become politicized. Second, the nature of our convening today, or legal vulnerabilities, policy debates that are increasingly involving disputes about evidentiary standards, and not by way of how we define them in the law, but the scientific evidence, how scientific evidence should be evaluated, and who has the authority to interpret it. And the third are information vulnerabilities, that mis and disinformation that we've heard about today. Data being taken increasingly out of context. We've seen public health data selectively interpreted, and that's putting it nicely, and amplified on social media, where the algorithms, and y'all know this, the algorithms reward controversy rather than scientific consensus, right? And these vulnerabilities are real. This is what that health director in that local community is dealing with. We've talked today about the calendar of disruptions, as I've been calling this. This chart comes from the Kaiser Family Foundation. And it outlines what we've seen over this past year. Not a single disruption, but a series of developments, changes to regulatory requirements, reconstitution of advisory committees, modifications to immunization schedules, shifts in federal messaging, shifts in who's the champion of this work. And these changes are occurring within the broader legal context, increased litigation under the Administrative Procedures Act, scrutiny of advisory committee processes under the Federal Advisory Committee Act, and broader constitutional claims related to agency authority. And as I've mentioned, these dynamics have converged into everything that we've heard about today. So when you put that all together, the vulnerabilities, the disruptions, it creates conditions where certain things become possible that shouldn't be a surprise to us. I call these points of exploitation. We're seeing scientific uncertainty, which is something that is normal in any research. Scientific uncertainty is normal in any research, but we're seeing it get amplified in ways that undermine the confidence that the communities we serve have in public health and public health officials. We're seeing our recognized advisory processes become politicized, with questions being raised about who's at the table and how those decisions are being made. So if we step back and take a look at everything we've talked about today, the administration's actions, the system disruption, the policy changes, the reconstitution of the advisory committee, the revision of the childhood immunization schedule, the disinformation, all the stuff that we've talked about today, we can't be surprised that we see these points of exploitation. But it's not just theoretical. It shows up in the work, like the local health director that I mentioned. It impacts how she does her job in real time. It impacts what school administrators are told and what they're telling their students and parents. It shows up in what providers are being told and what providers are telling their patients. It shows up, as we've heard today, in what coverage looks like. It shows up in ultimately how the communities that we serve in public health experience the system. So we think about the path ahead. The question for me questions become, what does vaccine governance look like in the future that we're creating now if these pressures continue? What happens to the consistency across states that we've seen? What happens to the gains we've made in vaccine equity? What happens to vaccine access? What happens to implementation, real implementation on the ground in clinics and schools and in communities? And what does all of this mean for the most important piece of public health, which is trust? And this is where I think strategic foresight may come in. So I heard about this stuff called strategic foresight and futures thinking maybe a year ago. And then when I mentioned it to some of the interns that I work with, they were like, oh, that sounds like some sci-fi stuff. I'm interested too. But it's not sci-fi stuff. Strategic foresight has been around for a really long time. CDC even has a training on strategic foresight for public health officials. But it's a tool that allows us to think about, to imagine what the future can look like based on the drivers that we're seeing today. I wanted to offer this as a mini training, as the ending of this particular convening, because I think it's an important tool for those of us who are leaders in this work. I want to point out that strategic foresight does not predict the future. What it helps us do is see multiple possible futures based on what we see changing now. It gives us a way to prepare, to test assumptions, and to see where our systems may be subject to vulnerability, and to think more deliberately and be strategic about the choices that we're making in the work that we do today. So it's a structured approach. It requires creativity. And that's often hard for folks like me who lean into the science. It requires us to imagine what the future might look like. It requires us to make a list of what may happen, like Richard said he did, and hear people saying, nah, that's not going to happen. That's crazy. That future doesn't make any sense. That's not possible. But it opens us up to see where the opportunities are to make change and to build the future that we'd like to see. Again, the goal is not prediction, but to prepare for multiple possible futures, anticipate risks, and make better decisions today. And as I've mentioned, it's been around a long time. I saw a strategic foresight scenario that the Coast Guard created back in 1998 that anticipated the pandemic. They got it wrong by 2 years, but it anticipated the pandemic, and it anticipated positive and negative outcomes from our response, a governmental response to the pandemic and what the Coast Guard may want to do in preparation for it. But at its core, again, it's just a structured way of thinking, a more structured way, a more strategic way of thinking. And I'll say this, Renee spoke to this concept of hope. I deliver a lot of keynotes to students, to law schools, to schools of public health. And lately they've been asking me, can you speak to hope for the next generation of leaders in public health and healthcare? Can you speak to hope? Tools like strategic foresight help give us a little bit of hope. It gives us some sense of power to shape what may be coming next, no matter where we sit in the field or no matter the type of work that we do. And the reality is there isn't just one path forward. There are multiple possible futures, and how we individually and collectively respond to this moment matters. Obviously, we can't control every decision being made at the federal government, but as we've learned today, we do shape how those decisions are interpreted, how they're challenged, how they're implemented, and how they're experienced. We do this in courts. For those of us who are researchers, we do this in our research. We do this in legislatures and in agencies, and we do this in practice, in public health and healthcare practice. And when you start to look at the system through this lens, you can start to see a few different directions that this can go. Again, not predictions, but plausible, possible futures. As St. Louis native Yogi Berra once said, you can observe a lot just by watching. Strategic foresight asks us to observe the drivers of change. Watch the drivers of change and imagine what could happen, good or bad, on the other side of those. In foresight work, we observe by watching these drivers, many of which we've talked about today. We identify what they are. We use them to help us imagine and construct plausible future scenarios, and then use those scenarios to stress test our assumptions. So in vaccine governance today, several drivers that we've heard about are particularly important. We've talked about them. The political polarization, right? Challenges around authority, shifts in how trust and institutional legitimacy are experienced both by practitioners, providers, as well as patients and the public. And one way to think about how these drivers play out is to use a strategic foresight tool called a futures wheel. And so I quickly created one just for these purposes. The idea is to plot the change in the middle of the futures wheel, and then to think about first, second, and third order impacts. So generally, this work is done collaboratively. These are just Montrese's thoughts. And if we had time, we'd workshop this together. And toward the end of my talks, I'm going to present an opportunity, if you're interested, if this resonates, for you to join the National Vaccine Law Association to do some strategic foresight work together about the future of vaccine policy. But if we put the driver in the middle, we can start to trace what that change, that shift might mean. Direct effects, things like insurance coverage, vaccine mandates, scope of practice changes in laws. Then the next layer, implementation challenges, variation across states, growing uncertainty for public health officials and providers. And then over time, the broader effects, maybe not even over time, as we've heard today, vaccination uptake changes, outbreak risks, and public trust. To the point, this futures wheel exercise is, again, it's to force people like me who don't get a chance to play in imagination very often to really think about what may be happening next based on the changes, the drivers that we see today. And when you look at these ripple effects on this slide here, alongside the other drivers of change that we've discussed today, you can see a few distinct futures emerging. So possibly future number one is what I call fragmented vaccine federalism. And we can see some elements of this future emerging now. In this future, we see states increasingly taking different approaches to vaccine policy. We see some states that restrict vaccine mandates or limit the authority of public health officials, while others are developing their own vaccine guidance, right? We're seeing some states asserting greater autonomy over interpreting the science and implementing vaccination policy. We're seeing vaccine coverage become questionable here. And in this possible future, we see vaccine coverage becoming increasingly more uneven across states, increasing the risk of interstate transmission of diseases. We also may see more litigation over mandates, regulatory authority, and the boundaries between federal and state public health powers. Now, yes, as Renee mentioned, I'm glad somebody mentioned Jacobson. The Supreme Court has recognized that in Jacobson that affirmed the police powers of the state can be used to enact public health measures, including specifically in that case, vaccination-related measures. But I believe that Jacobson assumed a stable environment, right? We can't make that assumption now. And so it's important to realize that when state policies start to diverge dramatically, which is what this future anticipates, maintaining consistent national immunization strategies becomes more difficult. And as Jennifer has said, these diseases don't care anything about state lines. Or my new favorite line, bodily borders. Is that right? I love that. And so, yeah, this is one possible future. And again, we are seeing some elements of this future emerging now. Possible future number 2, we're seeing some of this emerge as well. I call this one the erosion of institutional stability, or institutional authority, or institutional destabilization. And again, here we see trust, public trust in our institutions shifting, and it's happening fast. And it's not just in vaccines, but in the institutions and the science behind them. And then we see this move away from Chevron deference, right? And that signals a different role for courts in this work in interpreting scientific and regulatory authority. So more of these questions that used to really be able to sit primarily with scientific experts, are now being decided in courts and in political arenas. And over time, that starts to change how the system functions. So this is possible future number 2. A third possible future is one that I'm calling institutional reinforcement. This is where the pendulum swings back. Where I think Richard mentioned that in the 1960s that every state had repealed its Medical Practice Act, and then they saw the outcomes and the outcry, and then a year later the pendulum swung back. So maybe a possible future is that pendulum swing. And here we see legal reforms being used to protect the scientific advisory processes that we see are being disrupted now. We see laws put in place that strengthen statutory authority of local and state public health agency. We see transparency and evidence standards in vaccine governance that really move toward institutional reinforcement. And unlike in the first 2 scenarios, this one imagines something different, right? It imagines a positive possible future. And as mentioned, historically, we have seen this pendulum swinging pattern before. Now, whether we'll see this kind of response in the current moment is currently unclear. I think it's going to depend a lot on the elections, right? It's going to depend a lot on the makeup of the policymakers that we have in office. But history reminds us that governance systems are not static. Strategic foresight gives us a tool to remember that none of what we're seeing today has to be static, that we have a role to play in ensuring that we're building the future that we'd like to see. So then a fourth possible future, and there are many, many possible futures. It's one of the things that I like about strategic foresight work. You may be thinking of your own possible futures out there. But in this one, we see what I call adaptive or data-driven vaccine governance. In this scenario, the response to the disruption that we're seeing now might be to become more flexible, more data-driven, and more responsive to rapidly changing threats. To me, this one, I've been saying, yeah, they're disrupting what's happening in public health, but I don't know if we were always getting it right in the first place. This is an opportunity for us to reimagine what we want to see in public health and advocate for that collectively. But again, in this scenario, we're already seeing some of this future emerge. Real-time immunization data systems in some states are improving our ability to monitor vaccination coverage and detect gaps more quickly. And there are growing conversations about how communities themselves can play more of a meaningful role in shaping public health policy in this country. Now might be the time to bring community voices and community power building into these conversations a little bit more. In other words, becoming much more adaptive. But achieving this kind of system, or whatever the positive future system is that you're thinking about or that comes to mind as I walk through these possible futures, is going to require clearer legal frameworks for public health frameworks. It's going to require action from all of us. It's going to require new models for public engagement and community power building and public health decision making. But what I like about this particular system or this particular future is it doesn't simply restore the system that we're seeing disrupted now. It imagines something different. It gives us something to aspire toward. A vaccine governance system that is more resilient, more transparent, and more capable of learning in real time. A public health system that's more resilient, more transparent, and more capable of learning in real time. So those are the 4 futures from my perspective. And there's certainly, again, more possible futures here. If we do this work collectively, we can come up with many possible futures we see. So what is the path forward? I don't know. I don't know what the path forward is, right? It's part of what this work is. I've learned a lot from you all today around where there are opportunities for building a path forward. But what I do know is that tools like strategic foresight, which is a leadership tool, it's a management tool, it's a strategic tool that we don't get taught in law schools, that we're not taught in public health schools, but that can be critically important to how we do our work and how we shape the path forward. But what I do know is that these sort of tools will be helpful, strategic foresight. And I also know that our skill set as lawyers, right, our skill sets in litigation, in research, in educating policymakers, in educating judges, in educating the community, that becomes important as well. So that question, what is the path forward, is one that those of us in the National Vaccine Law Association are exploring and eager to explore in depth. And we'd love to have all of you join us. In August, we are having a day-long, what I'm calling a do tank, not a think tank. We need to do some more thinking for sure, but we need to put words on paper around actions that we can take and that our partners in the health system can take to address what we're seeing in vaccine policy today. Exploring possible futures for vaccine policy and governance, looking at those scenarios that I've laid out, coming up with different scenarios, and then making assumptions about what's happening in the world of those scenarios. How do we get there if it's a scenario we like? How do we avoid getting there if it's a scenario that we don't like? Again, it's happening in August of this year. It's at the College of Physicians in Philadelphia. Renee is going to be hosting us, and we'd love for you to join us. If you're interested, please connect with Dorit or Renee or me, and we'll share more information with you about the program. That is it for my time. I want to point out that I feel like I've suggested that the future of vaccine governance is not predetermined, right? As we've heard today, there are many potential plausible futures ahead of us, but through a foresight lens, we can think about and be strategic about the role that we take next, about the path forward. And I've got a good closing line here. Oh, well, I lost it. But now I got to find it because it was really good. Okay, here we go. And as we have explored today, this is about the law, but it's also about whether we maintain a system where science can meaningfully inform law and policy. Because the hardest part was never the science. The hardest part is whether we're willing and able to defend and protect the system that allows the science to matter. Thank you.
I would like to thank all the speakers for the amazing presentations. We have almost 15 minutes for questions. I would like to ask a question first. So, I'm so happy that all of our speakers gave us some reason why we should be optimistic about the future. I don't want to create like depression, but one of the reasons I think we could be pessimistic still is because I feel like all these anti-vaccination policies might undermine the incentives of the pharmaceutical industry to invest in R&D, innovation. So I would like to ask the speakers if there is any data about how this current anti-vaccination regime undermines incentives for R&D and how this might affect our economy as a whole.
I think that's something I can definitely speak to.
Yes.
What we are seeing is some of the vaccine manufacturers and some of the vaccine research moving to Europe. Europe is somewhat aggressively taking up the slack of what the United States is letting go by, first of all, pulling a lot of support for vaccination research, and then secondly, by establishing an environment that seems very negative and seems to set up a lot of headwinds towards potential vaccine approvers. My sense is that vaccine manufacturers that have long-term clinical trials underway or before them are just looking for kind of the clock to run out. You know, a presidential administration runs 4 years. At the end of this one, presuming that we adhere to the constitutional limit of 2 terms for a president, we're going to have a new president with new priorities in office. We're probably going to see substantial changes to a lot of areas. Even if the same party were to continue in power, I think we're going to have a very different emphasis on HHS than we've had. And in fact, there are a lot of people who support the current administration whose ideas about HHS are that it should just get out of the way of approval of pharmaceutical products and so forth, and that the previous administrations were too slow to approve things and things of that sort. So those aren't people who are fans of limitations on research for a particular class of pharmaceutical products or on creating an environment that is hostile to their introduction into the economic system. And I think that's, you know, what we're seeing is some movement out of the United States for things that are very immediate, but also a lot of wait and see. And if you're conducting a clinical trial and it's going to take another 3 years to get through the clinical trial you're already conducting, then why change anything? In 3 years, there will be a different situation on the ground politically.
Thank you.
We covered it all.
So do we have any questions for our panelists?
Well, I feel like Phil Donahue.
This one was for you, Mr. Abramson. With regards to, you mentioned that Secretary Kennedy's statement was not true. And I was just wondering which vaccines on the childhood schedule have undergone a long-term randomized placebo-controlled trial using a saline placebo before being authorized by the FDA. Thank you.
Using a saline placebo is another sort of condition that's being thrown in. There are different kinds of placebos. I don't have at my fingertips specific vaccines, but it has been the norm for decades for new vaccines to be tested against placebos. The polio vaccines were initially tested against placebos. I would guess that the initial measles and mumps vaccines, and I can look this up and find out for sure, but most vaccines, when they are first developed, when there's first the notion of, I think we can create a vaccine that will work against this particular disease, are tested against placebos. They may be not necessarily tested against a saline placebo. I mean, not all vaccines are even injections, but there certainly are trials, and there are people who have collected and published the evidence of these in response specifically to the statement made by Secretary Kennedy, showing that here are the various trials that have been conducted and different kinds of trials that have been conducted with respect to different vaccines. So I can definitively say that there are vaccines that are CDC recommended vaccines that have been trialed against placebos. And in fact, the COVID vaccines were most definitely trialed against placebos, and they were trialed against saline injections where those clinical trials were conducted. But generally speaking, it's not difficult to do the research and find the historical record of clinical trials that were conducted that were against placebos. And then I think there may be a nuance where, as newer versions of vaccines are developed, the current version of the vaccine, like the one that's on the market, may be an update of an original vaccine that was tested against placebos, and then this newer version was tested against the original vaccine. But there is no epidemiological value to be gained from specifically testing against a placebo as opposed to testing against a vaccine. It's sort of, if they weren't tested against a placebo, well, so what? That makes absolutely no difference in terms of gauging their safety and their efficacy if they can be tested against a vaccine that has a known profile.
Yeah, the other thing is something I tell my Epi 101 students is epidemiology 101 students is that the randomized clinical trial is not the end all be all of all epidemiological things. Sometimes you just can't do it out of ethics. So kind of what they try to do in Guinea-Bissau. They said, oh, you have a population that, some of them go unvaccinated and some of them we'll randomize into the vaccine. But it's very, very unethical because we know that the vaccine works. And so how could you ethically randomize somebody into a group that doesn't get any protection, be it placebo, be it, just no SIBO. And so we have the hierarchy of evidence. So we have the observational studies. Below that, we have expert opinion and surveys, and then we have the observational studies, and then we have the experimental studies. And then at the top, we have meta-analyses and systematic reviews. And so those systematic reviews take a look at all the evidence throughout the years and throughout the different kind of designs. And those are the ones that have concluded a lot of the safety profiles of the vaccines. And it's just it has become for some reason an anti-vaccine talking point of, okay, you have a new vaccine, let's do an RCT. You have a new vaccine against measles, let's do an RCT. Well, no, and there's no RCT with placebo. And it's like, no, you would do it against what we have now, which is the MMR vaccine. That's what you would do it again. But yes, Brian, you're right. And the original measles vaccine, if you look at the history, they went to an orphanage in I want to say New York State, and you can go on the website and look at it, but they gave it to some kids, and to some other kids they didn't, and then they followed them to see who would get measles and who wouldn't. And an interesting thing that happened from all that is the kids who got the measles vaccine, they also tried to recover the virus from their respiratory secretions, and they never were able to. So they kind of proved two things: that number one, the vaccine was effective, and number two, the vaccine didn't shed, which is another anti-vaccine talking point, that all these outbreaks in the US right now are because of the vaccine, but the vaccine just doesn't shed. So, to answer your question is like, well, at the very beginning, yes, we had those RCTs with placebos, and then now we don't need to because we have these other vaccines that we can test them against, and that's the ethical way of doing it. But beyond that, you have the systematic reviews and the meta-analyses that look at all the evidence and then deliver the statement on how well the vaccine works and how safe they are.
So I have a question for our third speaker. I really like the idea of that we do not have a predetermined future, so we can imagine possibly the best possible future. So how do you imagine the best possible future for vaccination law and policy?
I don't know that I have an answer to that, what I imagine is the best possible future. But I do know, the National Network of Public Health Institutes, where I just came from, was one of the national partners on the CDC's Public Health Infrastructure Grant. And for the last year of my work there, before I took on this new role, it felt like the money that had been given to us to improve the public health infrastructure, this work that we were being asked to do, this list of things that we were being asked to do, was being pulled right from under us as we were in the middle of doing that work. And so one of the things that I would love to see in the future is a path toward building a really solid, sustainable public health system. And I also think it's important for us to think 30, 40, 50 years down the line. The reality is we got here because other people thought 30, 40, 50 years down the line. In public health and the nature of the law, we often tend to be reactive instead of proactive. And what I'm hoping that I landed here is in a space where we can think proactively about what we may want to see on the other side and what our role may be in getting us there.
Thank you. Any other questions for speakers?
Don't be shy. We weren't that good, were we?
Think we're between them and wine.
Yes. So I would like to thank all the participants for staying here with us and all the presenters for excellent presentations. And we can continue the discussion with some wine in the reception. Thank you all so much.